Okay. Tiba harap dari tiba.
Roshan, I'm ready.
Yes, madam. Yeah. Good morning, madam.
Yeah, good morning, Roshan.
Right. Good morning, everyone. Welcome to pre-intern training 2022 September session. We all warmly welcome you for the session. So this is about 2-3 weeks long training session in collaboration with Professional College of Sri Lanka. So ministry officials will join tomorrow to address you all and give the relevant details because they have engaged in some other function. So today we are starting with training session on critical care in collaboration with College of Anaesthesiologists and Intensivists Sri Lanka. So I would like to warmly welcome Professor Vasanthi Pinto, Professor in Anaesthesiology and Critical Care of University of Peradeniya. She is the forefront trainer, organizes programs since 2015. So I would like to invite Professor Vasanthi Pinto, and I will also invite Dr. Harni Jagota, the Secretary of College of Anaesthesiologists, who is organizing the program in behalf of the college. So without any delay, over to you, madam.
Thank you very much, Roshan, and all the very best to all of you for joining the stream of the health system in this country. From the outset, I would like to thank Dr. Asela Gunodana, who is the DGHS, your boss for for some time, and then Dr. Lalpana Piti and Dr. Anti Kanarata, because they have been involving to this program since some time back. And of course, our dear Roshan, I think, Roshan, you should be given a special award from this country because for organizing this for such a long time and contributing this to the health sector in this country. Thank you very much, Roshan. I simply hope that your attempts are being recorded somewhere and awarded something. And another person, as Roshan very well said, is always behind this major program is Dr. Harini Jagoda from our side. All the other colleges are involving. So Dr. Harini Jagoda needs to be mentioned specially because she goes out of her way to organize this every year twice for interns and once for RHOs. And when the need comes for the COVID and all, we have been doing this regularly. So I think this may be the 12th or the 14th program, if I'm right. So we have contributed so much for this country. So on behalf of the College of Anaesthesiologists, the president, Dr. Anuma Pereira, who is helping us right around, and also the head faculty of critical care medicine, Dr. Bimal Kudavidanage, let me warmly welcome all of you to the stream of healthcare in this country. Right, okay. So it's a golden era in your life because you have been a medical student for some time and then you had many problems, COVID, bomb blast, everything has made your life very long as a medical student. But I'm sure now we can't go back to the past to correct, but certainly we can correct the future if you do the present situation properly. So I know with this economic downfall, there's a huge brain drain, but brain, wherever it is drained, it is a brain. And also we should know how to utilize the brain drain as a brain circulation, because wherever it grows, it's a Sri Lankan brain, and you can recirculate it to the country. So you are starting a new era, you're getting into a very good ministry and a very good leadership, and also always supportive. You will realize how supportive the ministry is as much as possible. So this is the starting point of this, because we as a ministry didn't want to let you go unnoticed of the problems and just putting yourself into a major problems without your proper training. I know as a medical student, you have been taught many things on books, and maybe this internship is a golden era in your life because you are going to hands the patients on, and then all what you do is going to be either saving the patient or not. But I would say house officer is the most important position in the hospital, because they come first time, they contact you first, and what you do and what you decide might lead to a good outcome or a bad outcome. That's why all these our consultants want to have good interns. So that is why the ministry is launching this in collaboration with many colleges. And this is what I'm trying to do today is the College of Anaesthesiologists and Intensivists of Sri Lanka to talk to you about the critical care. And like that, all the other colleges will let you know what is important in their own subject. So it's not only the theoretical training, the other training as well. So let me, from the very beginning, warmly welcome you for the health care system, and all the very best for the future, wherever you are, Sri Lanka or abroad. It's still the Sri Lankan brain. Okay, so let me talk about the critical care, and I will minimize me. Yeah, okay. So what is the objective of this program is, I just told you the purpose. And in this particular bit, it is the critical care. And you should know what is critical care, because you have been seeing patients morning and day and night, but whether they're coming under the critical care and what is meant by critical care and what is an ICU. This is the only thing I'm going to talk about, because this is not a lecture on critical care either. Okay, so the purpose of this training, as I just told you, the aim we have just told you. So this particular bit, the aim is to provide you the intensive care training. And of course, the time is very, very limited. So we want to do it in a very, very short program. And it's going to be an island-wide program, thanks to Roshan and the team organizing this. So what is critical care and where are we providing this care, right? Okay, so yeah, so what is critical care and where are we providing this? So if people think the critical care is something that is only to be provided in the ICU, this is 100% wrong. Critical care is critical care, or the intensively involving to the patient, which may be taking place in the ward, in the emergency treatment unit, high dependency unit, or a very specialized place called intensive care. But this can happen anywhere. The critical incidents can happen in the theater, on the road, at the corridors, anywhere. So by other means, it can happen anywhere. So you will be able to give it anywhere. That is why this training is generalized and taught you. Okay. And this. Okay. So when it called the critical care, we are discussing of a critically ill patient. Okay, the critically ill patient, the critical illness is dynamically changing. Now, this moment, the patient may be okay. In another few minutes, he may be changed, right? So it's dynamic. You can never trust on this system. Say, if you see a septic patient in future, you will see, you just speak to the patient, you say hello to the patient, and then maybe you can check the vitals and okay, next 10 minutes, if you come, patient may have gone. That fast, they deteriorate sometimes. It's so dynamic. And which needs or mandates a continuous close monitoring. It could be just a simple monitoring or invasive monitoring. And also, there are a lot of emergencies in this system. So then they need quick attention, quick action. So that is what is called an emergency. And also, when it comes to critical care, it is involving a lot of vital organ support. So they are sick. They are sicker than normal. They are sicker than patients, normal patients. So they are critically sick, critically ill. So they need a lot of organ supports, which is coming under the respiratory system. We might have to give them non-invasive ventilatory support, starting from the oxygen, how to give the oxygen, then how to give the respiratory support, the action of respiration. And that can be given non-invasively, invasively. You all have been medical students, you all have exposed to all these things. And when it comes to cardiovascular system, the heart has unable to pump, maybe the inability to maintain the blood pressure. So you need vasopressors to use. And when it comes to the renal system, we all know 0.5 ml per kilogram per hour urine we have to produce. So if it is less than 0.3, then there's something wrong. So you need to see why it is, and you might need to help the patient with a peritoneal dialysis or hemodialysis or see a continuous renal replacement. many things. So when it comes to the CNS, what you should do, so liver, what you should do. So all these are vital organs need support. So that also needs to be, you know, thought of. And then when it comes to the critical care, so many other things, when I say, you can never do critical care alone. You need multidisciplinary team. You need physicians, you need surgeons, you need microbiologists, you need nutritionists, you need physiotherapists, you need many. So it's a multidisciplinary care. The hematologists, when you come to a patient, so they are also very important. And so many protocols and guidelines, because since the nature is, you know, critical as well as a lot of emergencies, we tend to go by protocols and guidelines, which is a mandatory thing in the ICU setup. So you need to know what is the newest. And also these protocols are being changed with the best evidences. So you need to keep abreast with the newest guidelines. You cannot manage sepsis with the 2010 guideline, or before that, 2004 is the first guideline. So that guideline, 2006 guidelines, these are changing. So you need to know those, the new ones. And when it comes to the critical care, patients are dying. Some patients you decide not to resuscitate. Some patients you decide, okay, I'm going to continue the care or withhold care. So many ethical dilemmas, ethical problems. So it is not just a word. It is full of life. Even though we are talking about losing lives, there are a lot of things to handle. So ethics, and you need 100% ability to communicate, and the way you communicate, with whom you communicate, multidisciplinary approaches, and the patient's discussions, the legality of it, and then the directors, the ordering equipments, and all these things are is a real piece of work. And all these, when it comes to problems like COVID and these things like that, you have to magnify it triple or maybe 100 times, because what you do for your country is the one that is being saving the country. So that type of national disasters, you have to get together, keep aside the differences, and then, so it is the critical care is not only a subject of critical care, it is multidisciplinary. It depends on, as all you know, the intensivists or the critical care specialists or the anesthetists in this country, lots are being managed by anesthetists, but they are like, you know, they are known by everybody. The hospital knows everybody, and then they seep into all the places. The pharmacist knows, the physiotherapist knows, the nutritionist knows, the directors and blah blah blah. Everybody knows, even the laborers knows, because how are you going to clean this ICU when you walk to the ICU in the morning? If it's not being done properly, things like that. So many things to handle. So this is critical care. And for all these things, what I told you on the screen, we are giving you different lectures, and the experts are going to express their teaching abilities as well as the knowledge to you to learn all this stuff during this program. Okay. And so when it comes to the ICU, so this what I was discussing is critical care. When it comes to the ICU, that is different to a ward. And how does that being differed? It's a place where critically ill patients or potentially life-threatening illnesses patients are being cared for. So there are differences in that. So some few differences, if I just show you a few, that is, we need to work with protective gears. When you say, you know, safety measures to be taken, minimize the contamination, protect the healthcare workers who are already there. And you have to think, I mean, you can never say, okay, this patient is HIV positive, I cannot give the critical care. You cannot say, this patient is COVID positive, I cannot give. And fine day, if something comes in, very contaminated stuff, even you have to look after. So you can never say, I cannot do the critical care in this patient. So you have to go with how to attend to it, with the protective gears, how are you going to get it? So these things all needs to be known. And of course, you maybe your research mind should work on, you are sitting on research material, you are sitting on it and you are losing it because you don't see the importance of it. So maybe a new disease, maybe something new presentation. So every day I have now, up to now, I have seen many critical care ill patients. I have never found two patients who are alike. Always they are different. So it's an interesting field to work on, and so many new guidelines. Your time is full of facts. You just open the net, you see a new guideline coming, you see new discussion coming up. So that's a very lively field and you will love to do this. And for this. So we will introduce you to the intensive care. We will give you an idea of general intensive care for critical ill patients, and then organ supports, what you need to do, and monitoring, record keeping, infection control, communication, so many, with narrated lectures or video audio presentations. But we used to do a hands-on session. That's why I made it in a red color, because now with the current situation, we are unable to do it. But we will be doing another program when you are becoming resident house officers. If Roshan is listening to this, I think he should attest me on this. So that time we will try to give you a hands-on session. And the program is for 2 days of lectures. Again, I'm just putting it separately. Earlier, we used to do the hands-on training, which will be done to you. But I just, before this, I thought the skills booklet that we were used to do with this hands-on training, with the permission of Roshan, we will send it to you. And then you can keep the skills booklet. And that is the booklet. I mean, we have thought many times, and thanks to our group, Anupa was also with us. And then we made this skills booklet. You can take this booklet even as a house officer. You can keep this soft copy, or sorry, the hard copy, whatever, you can keep it. And then whenever you do a case, IV cannulations or some mask ventilation, intubation or something like that, you can actually fill that up, because you don't need to wait for the RHO period to fill it. You can still start doing it during the internship as well, and attest it by somebody who attested that you do it. And then unbelievably, within 1 year, you will have a booklet full of your own work, and that's your logbook. And I just happened to thought about it just before this meeting. Me and Harini discussed that even though we programmed it for the RHOs, I think Harini must be listening to this. So we will send you, Harini, you there? So we will send you the book, and you can keep the booklet. If Roshan is also there, I think we will get you the booklet. So that's about it. This is the booklet I was talking about. We will, even though it says the in RHOs, we will send you the booklet, and then you will continue to fill this up, and then you can have a logbook with you even before you get into the RHO period. And this is the whole of our booklet. And enjoy the program and stay safe. And thank you very much. Thank you for Roshan as well, as the whole team behind this big venture of teaching you all how to become a good intern. And this will be the foundation for your life, and you will be so happy and proud of yourself when you introduce this to your, inculcate things to your normal doctor behavior, and learn things in a proper manner. All the very best to you. You have few lectures today itself and tomorrow, and I think you will get to meet Harini, who is the force behind me to pushing me to do this. Thank you very much, and thank you, Roshan, and all the very best to you.
Thank you, madam.
Okay, thank you very much, madam. So, Prashant, is it okay if I start?
Yes, madam.
Yes. Okay, thank you, Prashant. Thank you. I'm going to start with the first lecture of the day. So it will be patient assessment and initial stabilization. Right. So end of this lecture that you're supposed to know what is the important having a patient assessment. And so thereafter, how are you going to do the initial stabilization? So actually, why should we assess a patient? So we supposed to assess a patient to identify the problems. And once you identify the problem, so as madam said, the patient it's a dynamic process. So this time patient can be totally different picture in a 1 hour, or it might be the 15 minutes or half an hour time. It might be a totally different picture of the patient. So for you to identify, you have to assess it to prevent such deterioration. At the same time, so you have to identify the patient and you have to assess the patient for you to ask the relevant investigations. Otherwise, you will do haphazard investigation, necessary investigations, as well as quite unnecessary investigation. In this time, doing unnecessary investigation is a very, very much burden to the country and the healthcare system as well. So therefore, you have to be very specific. You have to identify the exact problem, and you have to ask for a very relevant investigation to prevent unnecessary wastages. At the same time, it is very important that once you have assessed the patient and once you have identified the patient, now have identified the patients are static or whether the patient is deteriorating, and so have identified and have asked for some relevant investigations. So you have to initiate the appropriate treatment for the patient to save the life. So who are very sick, who are very critically ill. So appropriate treatment has to be initiated as early as possible. For that reason, you have to have the proper assessment of the patient. So in overall, so by doing that, you can prevent the morbidity and the mortality of the patient. So once, how does it happen? Right. So I will get this chart. So this is where the patient becomes sick or the patient becomes ill, right? So it might be progressed into very severe stage. So here you have to identify the problem, or it might be without your notice. Unnoticed, it might be going to severe stage. If you haven't noticed it, they might be progressed into very high risk stage where sometimes organ might be get involved, so that there can be an organ failure as well. So there is some stage with the time period where the time goes on. So there is a reversible, even though there is organ failure, that is reversible if you identify early, if you assess the patient properly, and if you have treated promptly, so that is reversible. But without your assessment, without your initial stabilization of the patient might be go into stage where it is irreversible, where the organ failure or the organ damage is irreversible, where you will not be able to do anything at all at this time to save the patient. So what will be the end? So there will be high mortality and high morbidity. So you won't be able to save the patient. So that's why it's very important for you to assess the patient, for identify the problem, and for you to act promptly. Right. So why it is important for in our health sector, or why it is important in our budget price. So if you identify it's in early stage, you will need very small intervention. Like there will be giving some oxygen, it might be propping of airway. So it's if you have attended in early stage, there will be number of survivors are very high. And the number of deteriorations or the patients who are dying trend or the percentage is very, very low. But if you haven't done it properly, if you haven't done identification at the early stage, assessment is failed. So there will be number of survivors will be very less, but number of non-survivors or the number of dying patients will be very high. So what is the problem at the end? So the same time, the number of deaths are very high. At the same time, there will be the cost that you have to spend in each patient. So here I told you that a very simple maneuver that you are supposed to do. Might be giving oxygen, might be giving IV fluid, might be giving antibiotics, very small procedure, small things that you are supposed to do to save the patient. But if you haven't done it properly, once it's become to the late stage, so at the latter part of the process, so you have to do very invasive procedures. So you need very invasive equipment as well. So might be CRRT, as Madam said, the organ support might be very, very the sophisticated things that you have to initiate. They might need the respiratory support, such as invasive ventilation. They have to intubate and go for a ventilation. They might need inotropes. They might be renal replacement therapy or dialysis. There might be other sort of organ support. So the cost that you are supposed to spend, not actually you, but the health sector, hospital, and the government has to spend is very, very high. So that's why it is important for you to identify the early patient, for one thing, to enhance the number of survivors. The second thing, to minimize the cost. Right. So there are levels of care that we are supposed to give. Like, it's just important, something that is very nice, very cute. If you know this level of the care that we are giving in the critically ill patient. So ICU, of course, that's the most highest level care that we give. That's a level 3 care, the ICU that we give, that one-to-one nursing care which is needed, and that need organ support, invasive care support as well. Level 2, where it's HDU care, high dependency unit care. So there are some sort of the organ support, but not as intensive as intensive care unit support. Level 1 and the level 0. So where you encounter in your ward setup. So when the patient get admitted, so if the patient doesn't need any much of the attention, so that patient might be in the normal cubicle of your ward. So they might be giving just IV fluid, IV drugs, antibiotics, or might be some observation. That might be the all required for such patient. But there are some patients that they need more attention, that more care, the oxygen. They might need some vigorous or the very scrutinized monitoring of such patient. So they might be the fluid, not the IV fluid as a normal routine procedures, but they might need fluid boluses. They might need blood. So there might be some sort of analgesic support. So that is the care that you give as a level 1 care, where you preserve a bed in the acute cubicle in your ward setup and give the such, not that intensive, but such vigilant monitoring care for the patient. So that is level 1 and the level 0 that you encounter in your ward setup whom are critically ill patients. Right. So when we are attending such critical patients, you have to have some skills. So they can be technical skills. So what are the technical skills that you need? That you have to know what is the anatomy of the patient, that what is physiology, so what it can be the pathology and how the process is going on. That's what we have learned in our medical colleges. So we have had a very basic knowledge on anatomy, physiology, and pathology. So that knowledge you have to apply here. So you have to think widely, very broad thinking to have that technical skills. And then you have to know that how are you going to do the physical assessment of patient. So that's what we have learned from our second MBBS to onwards to physical assessment. So that's what we had gained from our clinicals by doing the clinicals in our medical schools. The same time that you have to know the critical thinking approach of the patient. So once you have seen the patient, that you have idea. So why this patient? So what sort of organ can be damaged? So you are trained during our medical career. So as a medical students, that we were trained to have that critical thinking. So that is a technical skills that we gain during our medical schools. At the same time, we have, some of us have done the intubation, some IV access and NG tube insertion. So some sort of procedure, arterial blood gas performance, so some sort of procedure that we have done. So those are the technical skills that you have gained so far, which you are supposed to sharpen up or you have supposed to polish it up when you are doing your intern period. The same time, it is very important for you to have this non-technical skills as well. So it is, not the technical skills are the first, but non-technical skills are as equals as the technical skills. There should be an interpersonal as well as cognitive skills, which is very, very important for you to prevent unnecessary conflicts, unnecessary problems. So unnecessary medical legal issues. So what are the interpersonal problems? So you have to have the very good communication. So it's the communication not only for among your staff. So you have to communicate as a intern house officer, you have to communicate with your SHOs, you have to communicate with your consultant, nurses, the junior staff members of the team, or rest of the consultants who are coming for the referrals. So each and every category, you have to have the very good communication with each other. Not only your medical staff, you have to communicate with very importantly, you have to communicate with the patients as well as their bystanders or their relatives, which is very important. If you have not treated the relatives or the bystanders or the next of kins, so that will create unnecessary problems in your career. So that's why we have included the communication and documentation lecture in our lecture series for you to understand how to do it and how to proceed. Right, as Madam says, this is teamwork. The critically ill patient management is not a single person drama. It's a teamwork. So you are a one member of the team. So sometimes that you might be the leader. So if until your senior help comes, until SHO comes, until your consultant comes, so you might be the team leader. So it is why it is important for you to have this interpersonal skills development during your intern period as well. At the same time, there are cognitive skills where you have to have a situational awareness. So what is a situational awareness? So once the patient will say, now the patient has cardiac arrest. So you have to know, now this is a cardiac arrest, what are you supposed to do? Without knowing what is going on, how are you attend? So that is, you have to know the situational awareness. If cardiac arrest happen, so if the CPR commences, if the adrenaline is given, if any other drugs or the intubation is done or supposed to do, you have called the relevant person or the support for this. So you have to know what it can be, the things that you have supposed to do during this process. At the same time, you have to make your decisions. So I told you that you might be the team leader until your senior support comes. So that particular time, you have to make your decision. So it's your decision for you to call your senior as well. So this have to be your prompt decision making with the when to call and whom to call. Right? So that's why I want to highlight these non-technical skills are equally as important as your technical skills. Sometimes it might be more important than your technical skills. Right. So why it be failure to rescue the patient? So what are the reasons? It can be the failure in planning what's going on. So the planning, it might be monitoring problem, it might be placing where you're going to suppose the patient in your acute setup. We'll say now the patient who is coming with a hard chest pain. So you're putting the patient in the far corner bed in your ward. So is it good? No, isn't it? So you have to keep that patient where the monitoring station, somewhere near to the monitoring station. That's an acute cubicle bed. The most important patient in your ward at that particular time is this admitted patient. So you are not supposed to place that patient far away in the ward who seems to be neglected. So the failure of planning, it will be a problem. So failure to communicate. So proper communication failure, such as for you to adequate information given to your seniors, adequate information given to your nurses or junior staff. For we say now the chest pain patient, if you have failed, might be you have written the ECG, but you are not communicated properly or handed over that ECG request form to the nurses or the minor staff. So that will be a communication failure. So that might be in the nurses station for hours. So that this patient need immediate ECG to be done, right? So that's a communication failure. So that has to be prevented. At the same time, so you are failed to recognize the patients who are deteriorating. Who are the patients who are deteriorating? So you are maintaining you are giving the more attention to some other non-critical ill patient, but you are failed to recognize this critical ill patient who is deteriorating. So that is one of reason to fail to rescue the patient. At the same time, you are not responding clear signs of deterioration. So now we'll say the hypovolemic patient, RTA, blood loss, hypovolemic, the patient is having initial tachycardia, then the patient becoming, the conscious level varies, the blood pressure is dropping, urine output is dropping, but this clinical signs that you get, the patient gives you the signs, but you are not in a state, or you are not in a position, you are not identify this deteriorating signs. So that will actually at the end will make a failure to rescue such critical ill patient. Right. When you encounter a patient, so you have to think, when are you going to encounter? So you have to identify once the patient is admitted to your ward, you have to see what seems to be the problem is this patient. So any system of the body has failed, affected in this patient. So whether the patient is seriously ill condition or whether the patient can wait for a couple of minutes. So you have to identify at the same time whether the patient is deteriorating or not, whether you are supposed to call your senior. So those are the problems that you have to address each and every patient when the patient is admitting to your ward. So you have to think not once, think twice or thrice. Right, we'll go by a case. Now, assume now this patient is who is a 50-year-old male coming to your ward in a medical ward who's complaining of central chest pain, where he had it for 3 hours. The patient has symptoms of, patient is in severe pain actually. So he's retching and he's sweating and same time he's confused. It's a problem. Is it a critical ill patient? Or it is someone who you are admitting to level 1 care, or you can wait until a couple of hours until you have your lunch, you have your tea, you can go for a tea and come. Can you wait in such patient? No, isn't it? So this is a care you have to think. So this is a problem, isn't it? This is a problematic patient is admitting. So there is some organ has damaged, affected. So you know that the chest pain is coming. So probably it might be cardiac problem or it might be respiratory problem. So that you have to attend early as possible. So it is a serious condition. So it can be deteriorated. So the condition can be more serious or getting more severe. So there is a time that you know that you have to call for your senior as well. You might be not able to handle this patient by yourself alone. So you have to call your seniors as well. Right. So in this patient, so the chest pain with retching, severe pain, is confused. So do you need to do the complete your routine assessment with a detailed history and examination, and you have to do the investigation first, or you have to come into definitive diagnosis before initiating the treatment? So what's your answer? Well, the answer is no, isn't it? So you have to see now, this is a critically patient that you have to have an idea. That's why you have to think, now this is a cardiac problem. So you are not supposed to sit and do the full range of history examination with taking 1-2 hours, like we did in our taking history in our medical schools, like as we were medical students. This is you have to have do the history examination, and you have to ask for a relevant history. That should be very quick, very focused, very brief, but that's supposed to be very focused. So the brief but focused history examination and relevant investigation you are supposed to do. So then you have to have not the particular diagnosis, but you can have the differential diagnosis in back of your mind. So there it's obvious now in this patient. So it's a coronary event that you have to attend fast. You can't be like you can have a cup of tea and coming and attend this patient. So once you can do it, but when you are coming, the patient will not be survived. So that's why you have to need to act fast in such patients. So that's why in assessment that we do, it's worldwide recommended for you to have the ABCD approach. So that will prevent unnecessary time wasting of the patient, that ensure that you identify, that you pick up the problem very early and your address to the problem is very early. Once you have done the primary phase, you can go for the secondary phase. Like it's not the hours after, but at the same time, just few minutes after, you can do the vital monitoring. You can complete the history, head-to-toe examination. So, and then the rest of the assessment, as well as the socioeconomic problem assessment. So we'll come into the ACD approach. When your assessment of the patient, I told you that now this is ABCD approach is very important. Now, so what is ABCD approach? So A is airway. So what will be happen? Now we'll say, now this patient is confused. I told you the patient is confused, but he talks clear words. Once you ask what's your name, so the patient talks. He doesn't have any secretion. So there is no signs of swelling of lips or tongue. So what does it mean? So are you supposed to, first of all, going to secure the airway? If the patient, even though patient is confused, if the patient talks, so that gives you very good indication. Once you ask, what's your name? So patient says his name. So he'll tell, my name is blah, blah, blah. So that gives you very good information that his airway is protected, isn't it? So therefore, you don't have to do much. Are you going to go any interventions? No, at the moment, you don't have to do any intervention at the moment because his airway is protected. Right. So when are you supposed to do interventions? So if the patient is not talking, if there is any signs of the obstruction, like visible obstruction or the foreign body, if the patient with some edema, lipedema, tongue edema, facial edema, like anaphylaxis cases, some sort of saliva is drooling out where, and there are abnormal sounds like stridor, because that says the patient is in impending problem. Airway is impending. So any instance that it can be collapsed. So in that case, are you supposed to do in interventions? Yes, exactly. That is where you are supposed to do some interventions. So what are you supposed to do? You can do some basics. You can clear the airway. You can, if there is visible foreign body, you can remove it by using a sucker, or it might be gloved finger can be used. And a patient is supposed to have a clear the airway with, open the airway with triple maneuver, that head, tail, jaw thrust, chin lift. So once you have had the skills booklet, that you will see that we have included this, the skills has to be, you are supposed to master the skills. So once you have started your internship, you can come into, so you are doing surgery appointment or imaging ops appointment, you are coming to the theaters, you can get hold with the anesthetist, you can get hold with the anesthetist or the consultant. So you can master these skills by yourself. That's a skill, that a weapon that you are going to have. So if you master that skills, any time that you will be able to give a very initial life-saving support for a patient. So after doing the triple maneuver, that if it is not adequate, you can have airway junks like oral airways, nasal airways, Fuji, back mask airway, and you can do the LMS, or in case that you might need a proper intubation. Right. Now you have secured the airway of the patient. So you have assessed the airway, whether it's needed to secure or whether it's not needed. Then you have decided if it is needed. Now you have secured the airway. We'll say now we have intubated the patient. Now, if it is patient doesn't need airway securing, the second is going for B, the breathing. You have to see what is the signs, symptoms and signs that the patient is having in a part of breathing. Now, we'll say now this patient seems to be having difficulty in breathing. So he is tachypneic. So having chest expansion is quite okay, equal. Trachea is central. So why it is important to see the trachea central? So it might be deviated, it can be pneumothorax, right? So you have to see, that's a basic science you have to elicit. The percussion note, whether it's resonant or dull. So it's an important science. And the bilateral, the crepes are there, are there any spine crepes or rhonchi are there? So any sort of science that you have to elicit. At the same time, you have to see the saturation with room air, with putting a pulse oximeter probe. So we'll say now our patient, the saturation is 89. So what are you supposed to do? Right. So at the same time, you have to identify the rest of the problems. The patient is, whether the patient is spontaneously breathing, whether what is about his rate, respiratory rate. Now our patient is tachypneic. So what the pattern of the breathing? There can be seesaw pattern of breathing. So that says you the labored breathing or the obstructed breathing in this patient. Then you have to see the chest movement. So in our patient, the chest movement is equal, but there might be some patient equality is not there. So that can be a sign of pneumothorax, which might be the life-threatening condition, isn't it? And you have to see how the patient is on the respiratory failure, the signs of respiratory failure that you have to elicit. Nasal flaring, recessions, accessory muscle usage, color, skin color, whether the patient is becoming cyanosis. So that you can't wait. So you have to measure the saturation so that you can't wait. You have to do intervention early as possible. So breathing, as we know, the basics, chest, you have to inspect, you have to examine, you have to percuss, and then you have to auscultate the patient. So if there is a problem, of course, you have to intervene of the patient. So what you can give oxygen to the patient. Depending on appropriaty, you can ask for an investigation. Now, you can ask for a blood gas, you can ask for a chest x-ray, but x-ray is not an immediate thing that you are supposed to do because you don't have the involved chest x-rays, unlike in ICUs. So you can do the blood gas to see are there any respiratory issue. Now, our patient, he was given oxygen via a face mask with the 10 liters per minute, and his saturation, where it's from 89 to, it has increased up to 94. That's a good sign, isn't it? Right. So then you have to see the C, circulation. So what is circulation you are supposed to see? Now patient, so he's with some clammy, sweaty circulation. Capillary refilling time is 3 seconds. He's tachycardic, but his pulse is regular but low volume. The blood pressure is marginal. So, so he is Now with the history thing, he seems to be like ACS, acute coronary event. So you are supposed to treat, you have identified there's a problem. So you have to prompt attention and you have to prompt initiation your treatment as well. So you can give sublingual GTN, the aspirin, clopidogrel or statins can be initiated. They're very important that you have to have the IV access. Now, I told you the patient is in severe pain, so you can give some morphine. IV morphine can be given to relieve the pain of the patient. At the same time, you can ask the investigations, like you can order the 12-lead ECG. That is where you have to very good communication with your staff, not just writing the ECG form. You have to hand it over the nurse who is responsible, and you have to tell them that this patient is in a myocardial infarction or ischemic event. So you have to ask them to get down the ECG technician as early as possible. So in this case, the same time you can have the cardiac monitor attached to the patient, and that now you know that this is the rest is beyond your management. So you have to inform your senior house officer or your consultant early as possible, and you have to say that this is case. So you have to emphasize down this case, and you have to ask for them to be there early as possible. So depending on that, so they are to start enoxaparin, whether it's needed, give Lasix, furosemide, the further investigations, sending of troponin I, serial ECG. So that has to be decided then and there, right? So what are the rest of the things that in circulation you are supposed to see? You have to see the color of the patient, whether the patient is pale, capillary refilling time. It's a very important thing where it's coming to the trauma patient, initial assessment. So the pulse rate, rhythm, volume, and its character is very important, because before the blood pressure crashes in a hypovolemic patient will give you the signs of high capillary refilling time. Patient might be tachycardic, as well as the volume is very low. So until your weight to blood pressure comes low, hypovolemic, so you get some more very important informations from the physiology of the patient. So if there is no pulse, yes, of course, you have to do the cardiac pulmonary resuscitation immediately as a life-saving event. At the same time, you can ask some investigations. And I told you for you to IV access. So you can take some blood, ask to take some bloods, and you can give some fluids if it is appropriate to give some blood. Depending on the condition, to start some medication, like in our patient, you can give some aspirin and clopidogrel, starting off statins. So the appropriate medication has to be initiated. Then it's not immediately, but with the time, you can ask for the specialist care, like cardiology intervention in such patient. Right. In a disability, what are you supposed to see in the disability? So AVPU assessment is one important thing. Alertness. Patient is alert and patient is respond to verbal command. So you ask for a name, the patient is responding only to verbal command. So patient is responding to your pain, and this is you is unresponsive. So this AVPU score is very important. Then patient, you are supposed to see the patient's pupils, whether the patient pupils are reactive or whether it's equal, what is the size. Now, some patients, it's a very important thing that we are doing it under the D, category of D or disability. Let's see the blood sugar levels. It can be hypo or it can be hyperglycemic. Now, our patient, he's arousable to voice. So he's on AVPU V and his pupils are reactive to light with equally responding. And his CBS is around 178. Fine. Then you have to see the E, exposure. So what are you supposed to do? So this is supposed to expose the patient and you are supposed to examine the patient. But make sure that you are maintain the patient dignity. So if when you are examining the patient, you are supposed to cover the patient and not to undress patients unnecessarily, right? So make sure that you maintain the patient dignity. This is not a problem in our country, but hypothermia is a problem in some other countries where the temperatures are very low. So you are supposed to be vigilant to prevent the hypothermia in such patients. Don't forget to turn the patient and to see the posterior aspect, especially if you are in a surgical HO. So the posterior aspects might be that you might be missed some important thing. There may be cuts and anything can be there. So turn the patient to look in the posterior aspect. So the temperature measurement is very important thing. not to make patient hypothermic, but at the same time, make sure that you measure the temperature as well. So our patient, so the temperature is fine, that's within normal. So there, I told you now this assessment should be quick. But it should be focused, relevant history that you are supposed to take. So the ample thing that you have learned in your medical career that you have to remember, and you have to carry this out, this ample thing. So I'm not going to in detail. Allergies, medication, past history, last meal, and what are the events leading to this current situation. Now, our patient is a diabetic. He's on metformin. He had no any cardiac events as such previously, no allergies, and he had just chest pain while he was watching on the TV. So this is quite probably, it might be he's having unstable angina. So the same time you have to then once you have attended the patient, you have done the initial assessment, now you have done the initial stabilization of the patient, then you can go into the secondary phase of assessment to see are there any other thing that you are supposed to identify. So that comes your detailed history, complete systemic review of examination, and ordering of the rest of the investigations, and prescribing some more medications. And of course, you have to have the frequently review of such patient. Now, in our patient, he was not gone into cubicle far away. So he was in level 1 care. So he was kept in the acute cubicle in your ward and he was attached to cardiac monitor and vigilant monitoring. And he was in a continuous monitoring throughout. And the chest X-ray was ordered, but it is not immediately, but it is ordered. Right. The same time, you are supposed to do the ongoing assessment to see. Now, we have initially assessed the patient, now we have stabilized the patient. But does that mean that your story is finishes there? No. So from then and there, you have to identify any further deterioration of the patient, or the patient condition is static, or whether the patient is improving. If the patient is deteriorating, yes, by monitoring that only that you can identify, then you have to escalate the patient. If the study fine, if the patient is improving, so that's your target, isn't it? Right. So for you to identify the deteriorating patient, that is very important for you to have the MUSE. What is MUSE? Modified early warning scores. During our medical career, in your medical schools, that in your ward rounds as a medical students, you might have seen most of the wards that they use the MUSE score. So you have to be familiar with the MUSE score. So basic score, how it's given according to the relevant systems, organs, how does it affect? There are some scores or tools for you to identify in a deteriorating patient. For example, in sepsis patients, so there are something called QSOFA or the SOFA scores that we will discuss those the scores and these modalities in our subsequent lectures. So you have to be aware that this sort of tools are there for you to identify the deteriorating patients. Now, what can be changes? So there are special populations that you're coming into. It can be children, elderly, the archies or CRs coming to your ward. There can be obstetrics, pregnant mothers will be there. So depending on the condition, the category of the population, so there are some modification in your assessment. But important thing that you have to remember, so whatever you did, whatever you are supposed to do, you have to document.
Dr. Hari, we can't hear you.
Can you hear me now?
Yes, we can.
Sure. I think there was some connection failure. Right, okay, let me come back to my presentation. I hope that you can see it now, right? You can.
Yes.
Sure. So where we were, so the importance of documentation and importance that I told you, this teamwork, everything has to be as a team members, and the good, if the effects of the good communication, the staff, patient, family, and the relatives. So this is a key point of the topic today. So you have to have an assessment of the patient, the primary assessment and the secondary assessment, ABCD approach. Then thereafter you go for a detailed assessment of the patient. So this is, as Madam told you, now this is a critical patient. Critical ill patients are not only coming into the ICU, not only in the high dependency units, they are presenting in your ward setup. So you have to identify the critically ill patient. So that's why you need to have a critically thinking. So you have to identify, is there a problem? So think, are there a problem? Then once you think, you will get the solution. With that solution, you are supposed to act on. Okay, so critically patient, there should be a problem. So you have to think to identify the problem. Then you will come into the solution. So at the end of the day, what we are supposed to have, a smiling patient, the healthy patient who has come out of life-threatening condition to be discharged from your ward or the hospital, to see the patient is going home nicely with a good smile. So that's our target. We hope that you will be able to identify such patients, the patients who are critically ill. You have to do the proper assessment of patient and then initial stabilization of the patient to prevent deterioration of the patient. If they are, to identify the deterioration patient. I hope that you have learned something. So this is something for you to boost. So something for you to give you an idea. So what is it? So we will move on our lectures, then you will get an idea about, so what is the critical ill patient? So how you are supposed to manage, monitoring, organ support, rest of the things that you are supposed to do in the critically ill. Thank you very much. Any questions? If you have any questions, you can type it there. Do you have any questions? You may be able to type it in your chat box. Right, I think I'm a little bit, just 2 minutes, okay. 4 minutes have left, right? If it is not, then we can move into, if there is no questions, I think we can move into the next topic. So Dr. Roshan, are you there? So we can move into the next topic.
Yes, yeah. Thank you very much, madam. And that was Dr. Harini Jagor, consultant anesthetist at DDH Amilipedia on assessment and initial stabilization. So next up is by Dr. Livon Karyavasam, senior lecturer, consultant anesthetist at TH Anuradhapura, on the theme of when, what, and how to monitor. So I hope so is there. Are you there? So I think yet to connect Dr. Har.
Yeah, until Dr. Levin comes, do you have any questions? You can put it in the chat box. So I might be able to answer you. So we will send you this clinical skills booklet. So we will send it to Dr. Roshan. So to Dr. Roshan, so we'll get it not today, but tomorrow or day after tomorrow, once the pediatric thing is finalized as well. So we will send you the booklet. So you can go through, as Madam mentioned, you can go through the booklet and then you can see what are the essential basic skills that you are needed to have when you are dealing with a critically ill patient. We'll send you the booklet.
Madam, I think the host amount is full. I think unable. I think can we call him and ask whether he can join, or we can make him
might
available?
be now. This is 500. He might be
Yes.
very. I'll call him.
So at the meantime, those who cannot join the Zoom can watch them on YouTube. We have shared the link. So there will be attendance marked in due course. We will share the link on the chat box. The attendance links will be active for a few minutes. Once you're done, that's how we do the attendance. And the details of the program we will give tomorrow by our Director of Medical Services. Until then, we go with today's session.
Dr. Shan, Dr. Levin has already joined there, so you can make him co-host. He says Dr. Levin Karyosam.
Yes, sir. You can unmute and start, sir. We have given introduction.
Okay, can you hear me? Can you hear?
Can hear. Yes, can hear. Yeah.
Okay.
We can hear you.
Screen, can you see?
Not the screen. We can see you, but you have to share your screen. We can't see it.
Someone sharing screen. Oh, why is it?
No, I'm already left the screen sharing, so you should be able to share.
No?
No, not yet.
No, sir, not yet.
Why is that?
So you are supposed to open it in your computer first, and then you will share that.
Yes, I opened that PowerPoint. Now I.
Once you open the PowerPoint, sorry.
Yes.
Once you open the PowerPoint on the background, then
Alt S.
Yeah, then but it's open. Then press share screen. Press share screen on the toolbar on the bottom.
Yes.
Yeah, then you click on that relevant presentation, and it become blue on the sides. Then you start sharing.
Okay. Okay. Now?
Yeah, it's coming up.
It's coming.
Okay.
Coming into screen.
Okay.
So need to make it full screen, sir. Yeah.
Okay. Now?
Yeah, that's it.
Now,
Yes.
can you see slide?
Sure.
Okay.
Yes, full screen, yes.
Okay. Good morning, everyone. I'm Dr. Levan Karyosam. Sorry for that delay. My topic is ICU monitoring. Okay. First of all, we go through the objective. What is the importance of the monitoring in ICU? Other one is parameters, and know how to incorporate the monitoring into that assessment, and know what essential parameters and how to act upon the that parameters changes. This monitoring is a vital sign should be integrated your daily assessment. Okay. Okay. Why it is important of the monitoring? Then if we monitoring, we can early recognize the deterioration patient. Why? There's a very rarely sudden cardiac arrest or sudden deterioration. There's a first we can see if we monitoring clearly that heart rate rising, blood pressure dropping, and patient become tachypneic. Then we have time to act. Then we can early recognition, and we can plan the management, and we can do the investigation. If blood pressure drop, we can give IV fluid or iron drops. Then we can check the response of the whatever the management or intervention. Okay, that's why important in the ICU monitoring. Okay, parameters we need to. You can see this. This parameter that monitoring chart. Normally we use this ICU monitoring. This one column show 1 hour that we can mark hourly monitoring chart, but we continuously monitoring. Yes, parameters clinically, respiratory, pulse, capillary filling, and lungs also we can calculate capitations like clinically parameters we can monitor. Other thing is equipment, multi-monitor, ventilator also we can get the some parameters like airway pressure, that minute ventilation like. Other thing is investigation. We can take the blood and send. Example that the blood sugar, capillary blood sugar, or the blood gas, or other serum electrolyte like a biochemical that investigation we can monitor. Okay, that monitoring it depend. We need to tell or individualize according to that patient age and the other that medical conditions, and then we can decide what parameters we need to measure, how frequent. For example, if diabetic ketosis, we need to check the blood gas very frequently when we patient like that. Okay, and capillary blood sugar also diabetic patient if uncontrolled, we need to frequent measurement we need to take, and we need to keep the target. It actually that the target also it depends on the what are the whatever the medical condition. For example, if septic shock patient, our target should be mapped more than 60 like that. Other thing is if we are ventilating an ARDS patient, we not that that mean airway pressure should be less than 30. Like that, we need to make a target. Okay, according to whatever the medical conditions and age and the that body weight, everything depend on the our target. Okay, that ICU patient, that bedside we need have multi-monitor, and we can measure the physiological parameters. Okay, we can continuously measure and display in the parameters in that monitor. We can connect the electrode and the other sensors, and we can continuously monitor that the 24 hours that patient, including ECG that we can measure connecting the electrode, and via that we can check the ECG. Normally that the ECG we monitor the leg 2. Okay, respiratory rate also we can measure, and the blood pressure most of the time we measure the non-invasive, and body temperature also we are measuring. For that we normally that monitor has a thermistor that it we can put in the patient post pharynx, and continuously we can measure that ventilated patient and cardiac output. But most of the multi-monitor don't have that. The cardiac output, it need to special monitor, and it analyze the arterial waveform and give the cardiac output. Okay. Another thing is a pulse oximeter give the saturation, that oximetry. And ventilator patient, we need to measure that the in dial carbon dioxide, though, EtCO2 using the capnography. Okay. That in monitor, that alarm signal we need to set, and then when give the alarm, that nurse can attend and that correct the what is the clinical what is the parameter deteriorate, then nurse can intervene and correct that parameter. You can see that the multi-monitor is failed. Okay, you can see that the ECG, that wave, that you can see that we are measuring that the lead to, and I give the heart rate and the 79. It continues the monitoring. Another one is plethysmography of that pulse oximeter waveform, and it will give the saturation, and same time it will give the pulse also 79. Okay. Other one is invasive blood pressure monitoring, that arterial waveform, and it will give the blood pressure also, that systolic and diastolic and MEP. This one is that pulmonary arterial pressure, but we don't measure that one. Normally we measure the CVP. It also give that value. Okay. Last white line, that it will give the EtCO2, inside carbon dioxide, and 34. And using that also we can measure the respiratory rate, that it also give 11. Okay. Okay. Hemodynamic monitoring. Normally, that clinically what we can measure, mental state. That means if patient had a good cardiac output and cerebral perfusion okay, then that mental state good, that alert and conscious. If that that cerebral perfusion reduce, that patient develop confusion or when DCS can low. Another thing is skin and temperature. If that cardiac output good, that skin temperature maintain, and periphery, if cardiac output less, that temperature can drop, peripheral can get cold. And capillary refilling. Yes, normally capillary refilling should be less than 2 seconds. If cardiac output less, yes, it can increase more than that. Another thing is we can check the pulse rate, rhythm, volume, and the character. With that, also we can assess cardiovascular and cyanosis. Okay, peripheral cyanosis that can develop, and edema. Normally, that lying patient, they can develop pedal and the sacral edema. If they have that, we can think that the heart failure and that lung captations also we can assess, and auscultation, that means pulmonary edema, that means heart failure. Okay, we can clinically we can measure using this assessment, and equipment we can use, and with the multi-monitor, intermittent non-invasive blood pressure monitoring or invasive blood pressure monitoring. Other thing is ECG, we can check heart rate and the rhythm. Okay, ECG. Normally, previously also I mentioned, you can see that the ECG waveform, we assess the heart rate and the rhythm, and we measure the continuously using the lead 2. Okay, it will show that the arrhythmia clearly if we use the lead 2. If we see any ECG changes, then we need to request a 12-lead ECG. Then we can take 12-lead ECG with the rhythm strip, and that we can assess any abnormalities clearly with the 12-lead ECG. In monitor, we can't assess, but 12-lead ECG, it will show all that each side heart, how the function, and then we can assess. Okay, blood pressure monitoring. Okay, that why we need to monitoring that blood pressure. It main thing is determine the organ organ perfusion. Okay, we hear that it will give the systolic and diastolic and the mean. Main important thing is mean arterial pressure or the MAP. Okay, for example, that if severe septic patient, our target is maintain more than MAP more than 65 millimeter mercury. Like that, we mainly target MAP, not a systolic or diastolic, that it maintain the organ perfusion. Okay. We can measure two methods. One thing is an non-invasive, that means BP cuff we can put. Other one is invasive, that means arterial catheter, and via that we can use the blood pressure. You can see that radial artery catheter, via that that connect the line and check the blood pressure. Its advantage is that beat to beat monitoring of the arterial blood pressure and access the arterial blood gas also. But non-invasive, it will take, we need to put the interval, and that interval, that 5 minutes to 3 minutes, during that period, we can measure the blood pressure. But invasive one, beat to beat, we can measure. Okay. And some patient will have the arterial line insert in the peripheral arterial why that liable blood pressure, that patient hemodynamic instability, and correctly titrating vasoactive drugs. For example, if patient in inotrope, so the vasopressor adrenaline, that noradrenaline vasopressor, and the inotrope dopamine, we can correctly titrate, because of that it will give the beat to beat that arterial blood pressure. Then we can correctly titrate. Okay, but if we use an non-invasive, it will give the after 5 minutes. Then we can't correctly can't titrate. Other thing is if we need to frequent blood sampling, for example, arterial blood gas. Okay, when we are ventilating, if we have that this line, we can measure the blood pressure. Okay, you can see normally that we insert the radial artery, and or we can use the dorsalis pedis also. We size is 20 gauge or less, that 22 line we can insert that. Okay, and we need to keep the pressure bag 300. Then we need to check that one also. Then this transducer, via that 2 ml fluid going to, and it prevent the clotting this line. Okay, otherwise that line will clot or dam, and it will not give the correct value. Okay, transducer convert the pressure in the arterial to electrical signal, which change the intravascular pressure changes that move in the normal this contain the heparinized saline, normal, not a normal saline. We need to put the heparinized saline, then it will prevent the clotting also, that move in the saline column in the tube. Other thing is that transducer positioning. It should be in the that fourth intercostal phase and mid-axillary line here, and it need to zero. Zero means that this transducer open to air atmosphere, and need to press, there's a button monitor in the button, and we can zero, and after that it will change to this patient side, and it will give the waveform than the arterial blood pressure. Okay, each shift we need to zero. Okay, what are the complications can develop due to the arterial line? That arterial line insertion can cause the vasospasm, embolization, and thrombosis. And during procedure also, that other thing is later infection and bleeding, thrombosis, ischemia. Later they can develop aneurysm and the hematoma. Okay, these most of the complications we can prevent by using the ultrasound machine, and ultrasound guided. We can visualize the radial artery, and easily we can insert it. Other thing is we should never inject drug via the arterial line. If we inject any drug accidentally, that it can cause the vasospasm, and that hand get neck that because of the ischemia, hand can get necrosis. Okay, that's why we should never inject the drug. Okay, then we need to amputate because the hand get necrosis because of severe vasospasm and ischemia. And yes, that we need to prevent that. Okay, correctly label this arterial line. Normally that that we shouldn't insert the. Sometime if we don't available that arterial line, sometime we use the cannula also. Then we should avoid that because of that cannula is their support for injection. Then actually that can also happen. That's why we need to clearly label and insert the correct arterial line. And before insertion also we can do the Allen test. Allen test means that we can twist the hand. We can twist the hand and press the align the radial both artery and the release ulnar artery. Then that hand get perfused. Then we know that ulnar side good perfusion. Okay, that also can prevent the ischemia. Okay, other thing is a urine output. Okay, urine output we need to measure and hourly, and we need to know that hourly we need to monitor. And if the urine output low, then we know that the kidney perfusion. No, the patient had an acute kidney injury because of the low perfusion or any other reason. Okay, and that hourly we need to measure and put in the monitor chart, and daily that fluid balance. That means how much we give and how much we get from the urine output, and we need to balance the fluid. And if we know that the negative or positive, then we need to plan next day fluid management. Okay, our target is a urine output hourly should be 0.5 kg per L. If we say 70 kilos, at least urine output more than 35 ml per hour should be maintained. Okay. Okay. Other thing is we can use a central venous line or catheter. This is a special IV line we can insert in the large vein in the body. Several places we are using to insert that CVP line. One thing is a neck, internal jugular vein. Okay. Other thing is a shoulder, subclavian vein we can use. These two we can use for measuring central venous pressure because of that tip end in the superior vena cava. And femoral vein we can insert it, but we can't measure the CVP because it in the inferior vena cava we can't get the CVP value. And but we can give the drugs and via that any drugs or iron drops or vasoactive drugs. Okay. Okay. Why we need the CVP line? One thing is that we can measure the central venous pressure. With that, we can get idea killing pressure of the right side of the heart. Okay, it helps to fluid management. Other thing is a drug administration. Some drugs we can't administration in periphery. For example, vasoactive drugs and the parenteral nutrition. Okay. Because that the high osmolality parenteral nutrition, but now available low osmolality, we can give the peripheral also. But because of the high osmolality, we can't give this parenteral nutrition, and we need to CVP line. Other thing is a fluid administration, and other that we can some patient need a renal failure patient hemodialysis, so the hemofiltrations. For that, we need to special that normally we use the 7 to 7.5 3 lumen CVP line, but here we use to 11 French double lumen line. Most of the time we can use the femoral, but neck also we can insert because it's a little bit larger. There's a hemofiltration of dialysis catheter. That CVP line. Okay. Sometimes that most of the patient venous access difficult. Okay, that patient stay in the longer period in the hospital, but sometimes that patient get a chemotherapy longer time, then that venous access we can't get. Then what we need to do, we need to insert the CVP line. Okay, Normal person CVP pressure 0 to 6 spontaneous ventilation, and if we ventilate that it can go up to 10. Okay, positive pressure because of the positive pressure in the thoracic, and that's why CVP can get increased up to 10. Okay, here also that CVP we are measuring that it normally we don't use the saline column. It also connect to the pressure transducer and the measuring that using pressure transducer. It also we need to level transducer level that heart mid-axillary line. Okay, and need to use put the heparin and heparin saline also. Otherwise, it will float. Here, actually, it uses the transducer and it using the level bar. It level in the the heart level mid-axillary line. You can see here. Okay, what are the complications can develop CVP because of the central venous catheter CVP line? Okay. During insertion and placement, there are few complications can develop, such as damage around the near the structure and the vessel. One thing is a carotid artery puncture, okay, arterial puncture, and pneumothorax and the hemothorax. Most of the time, pneumothorax and the hemothorax can develop when we are inserting subclavian or low approach of the internal jugular vein. Then these two complications can happen. We can prevent using the ultrasound scan. Other thing is a cardiac arrhythmia. Yes, that cardiac arrhythmia also because of the guide wire that or CP line inserted too far and touch the heart, then cardiac arrhythmia can develop. Air embolism and the air embolism we can prevent patient head when we are inserting we need to put the head low. That's why we put the head low and putting then it is easy also that the internal jugular vein also dilated and prevent the air embolism. And we need that the thrombosis also can happen. Other thing is a perforation of the superior vena cava, right atrium ventricle. Because of that, the perforation of the ventricle or atrium, cardiac tamponade also can happen. And bleeding, infections. Infections is a little bit common complications. We need to insert a strict aseptic condition, prevent for that. And when we are handling also, we need to strict aseptic conditions and clean hand and prevent the infection. And sometimes the line can dislodge and that drug sterilization because of the irritation drug that can cause the complication. Okay, what are things can affect the CVP? That means central venous pressure. That central venous pressure or intravascular pressure can reduce or it because of the bleeding. Okay, if there's sometimes we can visualize the bleeding. Sometimes what can happen? GI bleeding, that gastrointestinal bleeding, we can't see the bleeding, but because of blood bleeding inside. Then, but CVP can reduce. Then we know that because of the bleeding, CVP reducing. Other thing is a fluid redistribution. That what does it mean? That fluid redistribution means fluid leaking out from the vascular compartment to interstitial compartment. It can happen in the severe septic patient that fluid that is still fluid inside the body, but it not in the intravascular compartment, it leaking out and the vasodilatation, then CVP can reduce. Okay. What we can do when CVP low, that we need to take actually the series of the value before giving the fluid boluses. Fluid boluses mean 500 ml normal saline we can give within the 15 minutes, and after that we can measure CVP. Then if the CVP stay that increase and stay same value, then we know that adequate fill, but it will reduce. That means it's still going on dose, or we need to give more fluid boluses. Okay, clear? Okay, that sometime we can have higher CVP reading. Why? Ventilator patient, if we use the PEEP mean positive end accelerated pressure, if we setting that high value, then it increases thoracic pressure and it can cause the high CVP value. that hyperdynamic circulation, and other thing is a right ventricle failure. Right ventricle failure can happen because of the ischemia. Sometimes the pulmonary artery thrombosis, that deep vein thrombosis, that the thrombosis dislodge, and that can embolize in the go to the pulmonary artery, and that can cause the right ventricular failure and give the high CVP value. Other thing is a tricuspid stenosis or regurgitation. And pericardial effusion or constrictive pericarditis also can give, and superior vena caval obstruction because of thrombosis. So, other tumor, whatever the reason, and that can obstruction, and fluid overload. Then we can have guide the fluid when we are giving, and if they have high CVP, no, that patient had a fluid overload, we can restrict the fluid. Okay. Other system is the respiratory. Okay. Respiratory rate is the most sensitive indicator that the critical illness, and we need to measure that the respiratory rate. Okay. Septic patient, we can diagnose if patient tachypneic respiratory rate more than 22. Yes, we can diagnose that. All patients should have continuously monitor that the respiratory rate of and record hourly. That multipara monitors can detect the respiratory rate. It detect several methods. Okay.
It's a durable one.
Okay. Right. Okay.
And you can see that the multi-monitor that it will give the waveform and respiratory rate 15. It normally that give the thoracic impedance using that the ECG electrode, but it's not always accurate. But ventilator patient that give the correct value in the ventilator. Other thing is if we measure in the EtCO2, entirely carbon dioxide, it will also give the correct value. Okay. Pulse oximeter. Okay. We continuously need to measure the using the pulse oximeter or saturation. This device measure and the display saturation of the arterial oxygen, and it will show that the waveform also plethysmography. And we need to place this hand, ear, lobe, toe, and sometimes that the peripheral finger or that the toe, it will, because of the vasoconstriction, it will not give the good wave. Then we can use the earlobe. Then it will give sometimes good waveform and the correct value. Okay. Actually, that pulse oximeter gives the light of the light, infrared and the red, and that intermittently that light on and off, and it will measure the arterial oxygen saturation. Only that the arterial oxygen saturation, that it measure actually the pulse wave, pulsatile saturation. Okay, that's why it will give the arterial saturation. Okay. Continuous monitoring should be placed in all the ICU patient, and our target depend on the whatever the conditions. Okay, medical conditions. Okay, for example, that non-ARDS or non-COVID patient, we can keep the target more than 94, and if a COPD, we can target more than 90. If we think about the chronic COPD patient, we can go a little bit more down. More than 88 also, we can maintain the target. Okay? According to medical conditions, that the saturation we need to keep in target, and we need to maintain. Arterial blood gas we can take a few hours depending on the patient needs, and then we can change that FiO2 according to that. But nowadays, most of the hospital, that arterial blood gas are not available. Sometimes the ventilator patient also we can't do the arterial blood gas, and we can need to go that saturation and the EtCO2, entirely carbon dioxide. With that, we need to change the ventilator settings and maintain the parameters. Okay, I think is that EF ratio, or that arterial oxygen to FiO2 ratio. We need to calculate, and we can determine severity of the lung condition. Severe that ARDS, we can say that lung injury less than 100. Okay. Okay. Other parameters, multimeter, we can see end-tidal carbon dioxide. Okay, capnography, it measures the using the infrared that the carbon dioxide concentration in the respiratory area, each ventricular cycle that and display like this waveform. Okay, this is expiration and inspiration and expiration. Okay, and end-tidal carbon dioxide. Okay. It helps to assess accurately that ventilation and ensure that adequate minute ventilations, because that we can maintain the carbon dioxide 40. Okay, here that is so the kilopascal. Okay, and other thing is that ventilator setting minute ventilation we can set according to that this, and other thing is a tube correct position. When we are doing intubation, we need to that capnography that ICU. If we think about the intubation, we need to prepare the capnography. Then once we insert that ET tube, we need to immediately connect and check carbon dioxide waveform. Then we can ensure that the correct position of the ET tube, because it shows the carbon dioxide waveform. Okay. Suddenly, can happen. Hypertension, like low cardiac output and hypertension, that carbon dioxide can reduce. Other thing is pulmonary embolism. Okay, pulmonary embolism can cause sudden cardiac carbon dioxide reduction and cardiac arrest. Whatever the carbon dioxide production in peripheral tissue, it will not come into lung because there's no flow, cardiac arrest. Then carbon dioxide can reduce. Other thing is tube disconnection or ET tube disclose. We can quickly identify then there's a disappear of the waveform, and it will give the alarm also. We can need to quick intervention before desaturation the patient. Okay, these are the ventilators. We have different ventilators that for ventilating the patient. A ventilator also, there's a monitor, and it will give few values: respiratory rate, tidal volume, each breath, and minute volume, and whatever the FiO2 we dial, and it will go in or not using the here that fuel cell. Fuel cell can measure the oxygen concentration of the inspiratory yeah, and airway pressure, peak airway pressure, and the mean pressure. Most of the time that the mean pressure we use for ARDS patient, target less than 30. We can see that the ventilatory wave, it will give the pressure waveform, and different that loop also we can visualize pressing the button, and flow wave. Okay. Tidal volume should be set according to ideal body weight, not a real body weight. We can calculate using the height and the weight that using that, and our setting should be 4 to 8 ml per kg per ideal body weight. Okay, and yes, most of the time we use the 6 ml per kg per for ideal body weight. We shouldn't give the large tidal volume, which can cause the barotrauma. FiO2 titrate according to saturation. Our target is previously also I mentioned that norm patient 94 for ARDS and the COVID patient more than 90. Other patient we can set 92. Okay. If sun drop tidal volume or minute ventilation, and we can see that the peak airway pressure also rising, and it will give the alarm. So then that means airway obstruction. Okay, or lung collapse. Then we need to do the bronchoscopy. Sometimes there's a sputum plug, and we can suck out the sputum plug. Normally we can blindly we can suck out. Sometimes we can't take out. Then we need to do the bronchoscopy and the suck out. If we think about the airway that a lung collapse, then we can put the increase the P, and the yes, we can whatever the collapse part we can inflate, but most of the time cause the sputum plug. Okay, advanced monitoring. we don't have that most of the time that this monitoring. This I think LITCO monitoring. Okay, LITCO cardiac output monitoring. It helps to measure correctly that the fluid responsiveness. Okay, and allowing measure the stroke volume and that with the fluid boluses we can measure, and we can maintain the optimum cardiac output and the optimum preload. Okay, you can see that the here say cardiac output 2.5, that the resistance and the yes map and the stroke volume. Yes, it gives the few parameters. One thing is that stroke volume variations. That stroke volume variation, that mean with the ventilator patient, stroke volume variation change because that because of the positive thoracic pressure. Okay, stroke volume. Then if stroke volume variation more than we can say about the 12, then that means it's fluid responsive. Less than 10, that means it's not fluid responsive. We no need to give fluid boluses. Okay. If the stroke volume variation 20, that means definitely that patient fluid responsive, we can give the fluid. Okay. And we can assess stroke volume variation coming down after giving the fluid, and correctly we can manage fluid if we have the cardiac output. How we calculate the cardiac output, heart rate and the stroke volume multiplied, and it will give the cardiac output. Normally 70 kilos, it will minute the cardiac output 4.9, and normally adult can change 4 to 6, and we can calculate cardiac index. Cardiac index means that the divide by the body surface area. That means it will average with the patient, and cardiac index can change to 2.5 to 4.2. Okay. That cardiac output if low, and that cardiac output low, and what call that because of the contraction low, then we can use the actually inotrope support. Okay. Another thing is a cardiac output low because of the systemic vascular resistance low, and because of the feeding low, we can use the vasopressor like noradrenaline. Okay. Clear. It will that cardiac output monitoring give the systemic vascular resistance also, because that sometimes the severe septic patient systemic vascular resistance low, then we can titrate using that and vasopressor or noradrenaline. And that we can measure continuously that the systemic vascular resistance, and vasopressor we can prescribe according to that. Systemic vascular resistance calculate mean arterial pressure minus CVP divided by the cardiac output. It also we can divide by the body surface area, and it will give the systemic vascular resistance index. Okay. Okay. When to act on the call for help? Okay. Unstable blood pressure. Yes. If systolic blood pressure less than 80, we need to immediate call and attention also. And both bradyarrhythmia, heart rate less than 55, and tachyarrhythmia. Other thing is that whatever the ECG, so dysarrhythmia or ischemic changes, ST elevations, or that the ST dip, then yes, we need to immediate intervention and call. And respiratory rate less than 8, or same time that the patient tachypneic or respiratory rate more than 30, and saturation suddenly drop less than 94, and capnography also that some change, high or low. Okay. Other assessment is a neurological. Okay. Neurological, we can use two methods, AVPU, AVCVPU, or GCS. Okay. ACVPU, with that quick assessment, we Hello? Can you hear me?
Yes, I can hear. Yes.
Hello? When it
Can
cut,
hear, sir. Yes, can hear. Yeah.
okay, just now cut or?
No,
No,
it got
no.
locked off until it came back.
Okay. Okay.
So we have a few minutes left, sir.
Okay. 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 That GCS assessment, ventilator patient, we can't assess because of the
So you
tube,
need
and we can't assess the best verbal response. Okay.
So sorry,
Ventilator.
so sharing went off, sir. Sharing went off. You need to share again.
Okay.
Yes, you can see. Yeah.
Okay. Okay. No? Yes, we can assess the GCS. Okay. Another thing is that we can use the RUS for ventilator patient that we use for titrate the sedation according to that. Our target is 0 to -2. Okay. With that, we can titrate Mills lamp and whatever the sedation protocol. Okay. Okay. I think it's a pain assessment that normally if they can speak, then we can ask the pain score, what is the pain score? But here that we can't ask because that the ventilator patient or that they don't respond. Then we can assess the facial expressions of upper limb and the compliance with the ventilatory ventilation. Okay, with that we can assess the pain and we can give the pain like a morphine or whatever the using the fentanyl. Okay. Okay, this is a very important thing. Is a fast heartbeat. Okay, I go through the quickly. Patient, when we are clocking every morning, we need to go through the fast heartbeat. Okay, we need to, what is the F? Feeding. Okay, and feeding and the fluid. Every day we need to go, and that sometimes because of the surgery we can't feed. Every day we need to check that patient can go to the feeding. If we longer period we can't feed, then we need to go parenteral feeding. Once we can convert to enteral feeding, we need to convert to enteral feeding. Other thing is a fluid. We need to calculate previous day fluid balance, positive or negative. According that today that we can calculate the fluid. According that because of positive or negative, we can reduce or increase. That also every day we need to do assessment. Other thing is analgesia. Okay, that most of the time that patient coming with the post-operative patient, then we need to think about the pain management, analgesia, whatever the drugs we giving, morphine or whatever the drugs we need to think, and we can the post-operative day we can tail off that. Other thing is sedation. Sedation that previously also I mentioned that the sedation is plus that account that we can titrate the sedation, and every day ventilator patient we need to sedation hold. Okay, sedation hold and assess the sedation that conscious level, and again if we can't extubate we can restart the sedation. Other thing is thromboprophylaxis. When we are ICU patient, they not moving, and we need to think about the thromboprophylaxis like enoxaparin, and if there's a contraindications, we need to that test stocking or intermittent pneumatic cough. Okay, sometimes there's a head injury or head surgery that we can't give the enoxaparin. Then we need to think other method, intermittent pneumatic cough patient or test stocking. Other thing is a head up positioning. Normally, patient, if there's no contraindication, we need to keep the head up positioning 35 to 45 degree head up positioning. Why? That it prevents the VAP. Okay. One thing is the thromboprophylaxis, head-up positioning, and also prophylaxis, both yes, and the prevent. Okay. Also prophylaxis also we need to give because that during ICU period, that because of the stress and that when we are not feeding also, they can develop gastric ulcers and bleeding. That's why we need to give the ulcer prophylaxis, and it reduces also the other thing is a glycemic control. Even though that patient not diabetic, sometimes because of the stress, they have high blood sugar, and we need to tightly control the glycemic control. And our target is less than 180. Now, previously there's a good control, but there's several hypoglycemia. Now, we target is less than 180. If higher than that, we can use the insulin for that infusion for glycemic control. Other thing is spontaneous breathing trial. That means that we need to stop the sedation and put the spontaneous mode. With that, we need to assess patient extubate or not. That also prevent the ventilator-associated pneumonia. Every day morning, we need to assess patient extubate, put in the spontaneous breathing mode. And if can't, then we need to restart sign mode or whatever the mode. I think it's a bowel care. Okay, we need to check the bowel opening and bowel sound and check. And with that, we can use a clean enema, whatever thing. Every day, we need to check whatever the catheter can remove. For example, if CVP line, if we are not using and we can manage the peripheral cannula, then we can take out that. So sometimes intercostal tube, abdominal drain, whatever the drain, there's nothing coming. And if we can remove, we need to take out because otherwise that can cause the infection. Okay, that's why we need to check every day and indwelling catheter, try to remove if it not need anymore. Other thing is a drug de-escalation. We need to tail off the drug. For example, if we give the antibiotic, now there's no signs of the infection, we can stop that antibiotic. Okay, like that iron drops if we giving, now blood pressure improving, then we can take out. Okay. Other thing is a daily assessment. We need to include ABCD assessment also. And that these are the when we need to escalate the treatment. Airway, there's a risk of the, if we hear the signs of the airway obstruction like a stridor, and that ventilator patient, if there's a EtCO2 reducing, and respiratory rate also previously also I mentioned that low, less than 8 or high tachypnea, and saturation also reducing with the 5 to 60, and cardiac arrhythmia, heart rate less than 55 or bradyarrhythmia or tachyarrhythmia 130, systolic blood pressure low or urine output less than 0.5 ml per kg per hour. And neurological also sudden GCS drop, and then we need to quick intervention. We need to check and see sometime non-contrast CT we need to take, and seizures or hypoglycemia. Okay. Infusion pump, normally we use that infusion pump and that we can give the IV fluid or IV medications or that correctly. Normally IV fluid we need to give the correct amount of over the 1 hour. We calculate the hourly fluid requirement and hourly we are giving. Then with the infusion pump we can use that. Okay. Then whatever that drug or fluid we can give, and it we can easily control that hourly. We can set the 70 or whatever the amount correctly, and that amount will give. And pump will be reliable, and if there's a the problem, it will give the alarm, and because of that can in, and it will give the alarm. Then we need to intervene and correct that one also. Okay. Okay. Any questions? Hello. Hello.
Yes, sir. Yeah, sorry.
Any questions?
Right. Yeah. So Those who are having questions can type in chat box. So we go to the next lecture by Dr. Amila Jayasinghe, the identified.
Okay, then. Thank you. Okay.
Yeah. Thank you very much, sir. Yes. Identify and fast act on acute respiratory failure. So are you there?
Hello.
Yes, sir. You can start.
Yeah, actually, I'm going to do the neurocritical care lecture.
Okay.
Dr. Amila wants to software.
Yes, madam. Madam, you are breaking up. Yes. Yeah, we are doing neurocritical care by Dr. Rochana Mallavarachi, consultant anesthetist at. So you're at.
Healthy Hospital, yes.
Yeah. So over to you, so you can start. We have a small change in the lecture series. Dr.
Yes,
Instead of Dr. Amila Jayasinghe, we'll start with Dr. Rochana Mallavarachi. Over to you, sir. Sorry about that.
Thank you very much. So I think we are a little bit behind the time. So can everybody see the screen and the
Yes, so we can see. Yeah, perfect.
That's good. One second. Okay, so neurocritical care means actually we are going to discuss about the head injury or the traumatic brain injuries. Right. We all know it is a leading cause for the morbidity and the disabilities and also the mortalities, right? Road traffic accidents are very common, even in developed countries, and child abuse, very young infants can come to us with a traumatic or head injuries, which we have to suspect. And elderly people, elderly patients, actually, even a fall on the ground can give rise to a fatal head injury. Right. When we go to the Sri Lanka statistics in 2020, that is the COVID, the year in the COVID, I mean, year with the COVID and the lockdown, still there were about 4,200 fatal accidents or fatal deaths due to road traffic accidents, right? So it is very common here in Sri Lanka. We all know that it's about 4%. Actually, if we calculate, it's about 12 per death. So the prevalence is very high in Sri Lanka. If you go by the pathophysiology, what happened is actually the type of injury we can divide to two. One is the immediate or the primary damage, we call it primary damage, and the second one is the secondary damage or the delayed damage. So the primary damage is due to scalp lacerations, skull fractures, cerebral contusions, cerebral lacerations, hemorrhage, or anything which happened then and there during the incident or the injury. But secondary damage is very important because we can prevent that. Right? If we act early, if we promptly assess and treat the patient, we can minimize or we can prevent occurring this secondary damage. It is mainly due to the hypoxia or the ischemia due to cerebral edema or later on maybe due to infections. Primary damage, stretching, compressions, tearing of the blood vessels or brain tissues, which leads to brain cell death. Anyway, ultimately, the thing is brain cell death, right? Or the tissue damage to atrophy. A secondary injury it can be due to cerebral circulation, cerebral blood flow problems, and glutamate toxicities, brain edema, and several reasons are there. Secondary brain injuries can be due to problem with oxygen, energy supply, cerebral blood flow, and excitotoxicity. So we have to prevent these 4 areas. We'll go one by one. Neurophysiology. You might heard or you might learn this if you are doing postgraduate physiology, this Monro-Kelly doctrine. So what do you understand by that? So we know inside this skull, it is a rigid box. there are three compartments. One is brain, the major compartment, that is about 85%. And the other one is CSF, which is about 10%, or volume-wise, it's about 150 ml, and the same volume in blood. So three compartments are there. So Monro-Kelly doctrine means Monro-Kelly doctrine means if there is increase in one compartment, for example, brain tumor, the increase in the brain tissues needs to compensate by other reduction of other two compartments, or at least one. For example, venous blood volume needs to reduce, or arterial blood volume, or the CSF. That is the theory. That is the theory of Monro-Kelly doctrine. So this slide further explains what I mentioned. So when the intracranial pressure rises for a certain extent up to this point, or this point, the pressure, the intracranial pressure rises very slowly. But beyond that, when the compensatory mechanism can't compensate the volume or the pressure, what will happen? There will be a exponentially, increase the intracranial pressure. So in that point, in this point, there can be focal ischemia, and later, when it go beyond that, if the intracranial pressure is more than around 40 to 50, there will be a global ischemia, cell death of the brain cells occur, and we might not be able to survive the patient. So key factor, or what we have to do after we are getting a patient's brain injury, is to prevent this secondary injury, right? Main thing is to minimize or avoid the cerebral ischemia. That is hypoxemia. We all know what is hypoxemia. That is the low oxygen. So we have to give oxygen. We have to treat accordingly. And hypotension, again, the perfusion can be reduced. So the hypotension can be common because head injury doesn't come alone. So it usually comes with several other injuries, chest injuries or limb injuries, which can lead to bleeding. So we have to treat that. So bleeding can cause anemia. We have to correct that. Why the anemia is important? Again, we need to give a good perfusion or nutrition to the brain cells. So anemia means low hemoglobin levels, low red blood cells. So the oxygen carrying capacity reduces. So we have to treat anemia as well. And increase intracranial pressure, ICH, if the one compartment increases, as we discussed earlier, there can be increased intracranial pressure. So we'll learn about that later. So we have to prevent increasing intracranial pressures. And the other thing, anyway, so what our main goal is to give a good perfusion and to reduce or suppress the cerebral metabolic rate or oxygen demand. It's a supply demand imbalance, right? So we have to increase the supply, at the same time minimize the demand, that is to minimize or suppress the cerebral metabolic rate. So hypothermia is not good, epilepsy or seizure activities are not good, we have to treat accordingly. Remember, hypoglycemia both are not good in traumatic brain injuries. We'll go normal physiology. Cerebral blood flow is about 50 mL per 100 grams per minute. So the brain weight is about 1.5 or 1,400 grams. It is about just 2% of the total body weight. But remember, the cerebral blood flow is about 700 mL from the cardiac output, or it is about 15% of the cardiac output, right? So then we can understand this is very important. So oxygen consumption, usually in basal or the normal metabolism, we need about 250 mL per minute oxygen for the body. The consumption of the body oxygen is about 250. About 20% of oxygen is utilized by the brain. So we can understand the importance of oxygen to the brain. Okay, cerebral blood flow depends on the cerebral metabolism, or CMR, we call it CMRO2, and carbon dioxide level oxygen. These are very important because these are the things we have to think, we have to monitor. Previous lecture you learned how to monitor oxygen, how to monitor carbon dioxide and CVP, fluid status. So these are the things you should monitor when you get a traumatic brain injury patient to an ICU. Right? Okay. So what happened when the cerebral metabolic rate or the oxygen utilized or the brain activity increase? There's a linear relationship with that CMRO2, the cerebral blood flow increases to give good oxygen supply. Temperature, we know hypothermia is good. If the temperature increases, the CMRO2 or the brain metabolic rate increases, the oxygen demand increases. So temperature should be less than 37. Carbon dioxide, what happened in this area, you can see it's a linear relationship. When the carbon dioxide increases, the cerebral blood flow increases to further. The reason is when we call it hypercapnia or the high carbon dioxide. With high carbon dioxide, there's a vasodilatation in the brain. So what happened? There is a good perfusion or there's a good increased cerebral blood flow. But remember, when we increase the cerebral blood flow, according to the Monro-Kelly doctrine, there is an increased intracranial pressure because the volume increases, pressure increases. If we reduces carbon dioxide, we'll say below 30, what will happen? There's a severe vasoconstriction. So the cerebral blood flow will compromise, and again the perfusion will be compromised. So the main idea, you need to keep the optimal level of carbon dioxide, that is 30 to 35, right? 35 to 40, not below 30 or not beyond 40. And oxygen, again, very important. You can see here, when the PaO2 is about 8 kilopascal, when it's become around 50 mercury millimeters, what happens? The cerebral blood flow drastically increase. Again, the same scenario can occur if the patient become hypoxic. So we have to treat the hypoxemia as well. In normal people, so you and me, we are auto-regulating this cerebral blood flow. That means when the cerebral, even though the cerebral perfusion pressure changes from 60 to 150, I will tell you what is cerebral perfusion pressure. There won't be big difference or big change in the cerebral blood flow. So it keeps a static range, right? It's about 50 mils per 100 grams per minute, which we discussed. What is the cerebral perfusion pressure? That is the mean arterial pressure minus IC. This is very important equation. What is cerebral perfusion pressure? Cerebral perfusion pressure equals the MAP. You all know what is MAP. That is the diastolic plus 1/3 of the pulse pressure minus the intracranial pressure. Right? So usually we'll say the MAP is around 80 and the ICP is around 10 or 20. So cerebral perfusion usually maintains around 50 to 60. But the problem with the traumatic brain injury is, so this green line is the normal autoregulation curve, but in the traumatic brain injury, this autoregulation mechanism disrupt. So what happened? It becomes a linear proportionate to the perfusion pressure. So when there's a hyperperfusion, cerebral blood flow is low, it leads to ischemia. And when there's a hyperperfusion, what happened? There's a increased blood flow and it increases the ICP, right? Right, okay. So how are you going to, so if you are going to work in an ETU, you are the first one to see a traumatic patient or trauma patient or brain injury patient. Prompt response, prompt assessment, and the treatment or the decision is very important because first hour is valuable, and we call it golden time as well. Right? So how are you going to assess A, B, C, D, E? So primary neurological survey includes assessing the GCS, pupils, motor functions, and see whether there are any lesions which may need surgical interventions. You learn the GCS, assessing GCS, and you have practiced how to assess GCS when you are doing the internship. The importance of GCS here is to categorize. So you can convey the message to a senior or to a colleague by if you have assessed the GCS. For example, GCS 13-15 on admission, we can call it a mild head injury, 9 to 12 moderate. If it is 8 or below 8, that is the severe injury. You have to act promptly. You need to do a CT. You need to refer to a trauma unit as well. We'll go by one by one. So our aim is to identify early whether there is a traumatic brain injury causing to increase the intracranial pressure. If we increase intracranial pressure, we know the cerebral perfusion reducer, so cerebral ischemia leading to secondary brain injury. So we need to identify a patient following a trauma, whether the patient's ICP, intracranial pressure, is rising. The clues are headache, which is a vague symptoms. Yes, anybody comes with the trauma may complain of headache, but vomiting, even a single episode of vomiting is very significant, and seizures can be focal or generalized, papilledema and focal neurological. Late signs, that means you are too late now, and these are signs to show the ICP is significantly increased. Level of conscious or decreased level of conscious, patient is unconscious, maybe GCS 3, and you all know what is pushing reflex. It is a compensatory mechanism, hypertension and bradycardia, and abnormal respiratory pattern when the respiratory center involves, and the pupillary dilatation, and initial decorticate posture, that is leg extension with an arm flexion, and decerebrate means both the arms and legs goes into hyperextension. Right, okay. Again, when there's a patient, we need to act promptly. We need to do a CT. So it is a crucial decision, and it is very important to take this decision without delay, right? So remember this slide. This is a very important slide. When you are going to decide to do the patient might come to you in middle of the night. Then and there, you may work in the peripheral hospital. Even we don't have CT, we have to send to Kandy Hospital. It takes about 1 hour. So arranging an ambulance take more than that sometimes. So the decision you have to take early. GCS if you are less than 13. Even you are assessing after 2 hours of post injury, if the GCS is below 15, and open or depressed skull fractures, and battle signs. If you can see here, fluid drain from the ears and nose gives rise to this battle sign. This is because of the basal skull fracture, right? And seizures, it can be focal neurological focal seizures, and even more than one episode of vomiting is significant. So you have to go for a CT. And loss of consciousness or post-injury in a patient who is in coagulopathy. That means protein disorder, or a patient who is on warfarin. Right. So the same applies here. If you are referring to a neurosurgical specialized team or a specialized unit, it's more or less same to doing a CT. So if you are sending the patient to the CT, most probably you might get a neurosurgical opinion accordingly. So significant surgical abdomen imaging and GCS less than 8, unexplained confusion, deterioration of the GCS after admission, focal neurological signs, seizure without full recovery, CSF leak, and penetrating injuries. You have to refer to a neurosurgical people. Again, this slide is also important. So now you know we need to send this patient to a CT or a tertiary care. And now you should know whether to intubate this patient or secure the airway or not. Remember this slide. Then you don't want to ask from others, or you don't want to be clueless whether to intubate or not. Again, airway, breathing, disability, airway. If the patient can't maintain the airway, if the airway reflexes are lost, and if there's a significant bleeding, you definitely need to secure the airway even before transferring a patient, right? Otherwise, definitely patient will aspirate. So if the patient can't maintain the airway. And breathing means if you can see the signs of hypoxia, if you do a blood gas with oxygen and the PaO2 less than 100 or less than 13, it's an indication. Again, the hypocapnia, that means patient hyperventilating, washing out carbon dioxide, that is less than 30 mercury millimeters is not good. And hypercapnia or the hypercarbia, that is more than 45 mercury millimeters, is also not good. So you can decide on the arterial blood gas whether to intubate this patient or not. And GCS, I have highlighted. If the GCS is 8, without thinking, without a second opinion, intubate this patient, because this means patient can't secure the airway. I mean, the patient's airway reflexes are gone, so we definitely need to intubate the patient. And seizures, if the patient is getting seizures, you need to intubate the patient. If you are transferring a patient, assess the patient and decide the duration of the transfer and how long. By those things, you need to discuss and decide whether to transfer the patient after intubating. So breathing, I mentioned the target PaO2 is 13 kilopascal or 98 mercury millimeters, roughly around 100, and PaCO2 35 to 40 mercury millimeters or kilopascal 45 to 5. And the circulation, we know what is cerebral perfusion pressure. We need, our target cerebral perfusion pressure is 60. So ICP usually it's about 10. So here we are dealing with the traumatic brain injury patient. So we expect that ICP to be high, maybe around 20. So to keep a cerebral perfusion at 60, we have to maintain a MAP of 80. I think you understood what I mentioned here. So cerebral perfusion pressure, our target is 60. So in a traumatic brain injury patient, we expect ICP, if there's something inside and something abnormal, ICH or cerebral edema, ICP can be around 20. So we need to have this MAP. MAP is the one we can easily measure even in a peripheral hospital, looking at the systolic blood pressure and diastolic blood pressure, or the monitor says what is MAP. So we need to keep the MAP about 80, right? Remember this, keep the blood pressure. You may need to start a vasopressor, or you may give fluids accordingly, right? Avoid hypotonic fluids and glucose, because that leads to cerebral edema. So further worsen the cerebral edema. So remember, you can give hypertonic saline or isotonic normal saline or Hardmers. If the patient is anemic, maybe due to bleeding, you can consider giving blood before transferring as well. And reverse or think about the coagulopathies as well. So disability, ICP monitoring, if you can do, you should definitely avoid ICP more than 20. You can treat medically or surgically. Surgically, craniotomy or evacuation of hematoma or EVDs are the surgical options, right? And sedation is very important with analgesia, and seizures we have to treat accordingly. Maybe anti-epileptics like phenytoins, we can start bolus and regular doses, and blood glucose level maintain around 6 to 10. And hypothermia you should avoid, so it should be below 37. Again, remember this slide. This is our goal to prevent secondary brain damage. Do a blood gas PaO2 should be around 100. PaO2 should be around 100, should be above 100. PaCO2, 35 to 40. 35 to 40. It should not be low, or it should not be high as well. MAP more than 80. Glucose 6 to 10. Temperature should be less than 37. And ICP, if you are monitoring, the ideal it should be below 20. Management of raised ICP. What we can do is we have to, we know the options are to minimize the blood flow, right? So venous engorgement is not good. So head up the patient for 15 to 30 degrees and prevent obstructing the venous drainage. For example, if you have a tight collar, that's not good. If you are tied the ET tube, there can be venous engorgement, obstruction of the venous return. And coughing and bucking is also not good. When you intubate and if the patient is intensive care unit, you need to start sedation to suppress the cerebral metabolic activity. At the same time, you have to suppress the coughing and bucking. You don't want to give muscle relaxants. It's not compulsory, and we are not giving muscle relaxants in ICU. But to prevent coughing and bucking, you might give boluses if necessary, but it is not compulsory. Osmotherapeutic agents to keep the sodium level less than 155 and osmolality 320. You can consider mannitol. Now we have hypertonic saline. You can go for 2 mils per kg. That's about 100 mils of 3% or 5% saline. Right? Surgical options we discussed: decompressive, craniotomies, and CSF drainage. Okay, what are the types of hemorrhages? We know subarachnoid hemorrhages, subdural or extradural, which is very common in trauma patients. In our ICU, we had a patient, a young patient, about 38 years. He was still with us about nearly 2 months, I would say about 50 days. What happened was assault during this fuel crisis when he was in a queue. Patient was conscious when we take to the CT, but CT showed significant cerebral edema. We got the patient after intubating, and patient didn't wake up. So we go for neuroprotective ventilation. After 2-3 days, we repeat the CT. There was a global cerebral hypoxemia. Patient is almost not responding now. GC is still around less than 8. So it's very important to prevent secondary brain injuries, right? Okay. So this is a normal CT. What is this? EDH. So extradural hemorrhage. How can you identify this? Biconvex or lemon-shaped white patch due to rupture of middle meningeal arteries usually. If you see this midline, it is shifted to the other side. So definitely there should be a surgical intervention, maybe burr hole evacuation or craniotomy needs to be considered. This crescent shape or the concave shape patch is a subdural hemorrhage. It's usually due to rupture of bridging cranial veins. When there is a high velocity accident because of the tear of this bridging central cranial veins, this kind of STH can occur. Right? The first one is subarachnoid hemorrhage. These white lines are there. You can see. You can say edema as well. IVH. Sorry for the noise. IVH is there. We might go for a drainage. I mean, neurosurgical team may drain this one by looking at the other parameters. And this is a parenchymal of ICH. Okay, that's all the main thing. So remember to maintain the normotension, normoxia, prevent hypoxia, and normocapnia, and normothermia, don't allow the patient to go for hypothermic, and glycemia, normoglycemia, that is 6 to 10 millimoles per liter. Right? Thank you very much. So do you have any questions? So I think you can type on the chat box. We can reply because we are a little bit behind the time. Dr. Shah?
Sorry. Yes. So if anyone's having questions, you can type in, you can unmute and ask. So in the meantime, we can go for a few 5 minutes tea break and come back at like 8:20. Right. Thank you very much, sir. That is Dr. Roshan. Dr. Rochana Malgavarachi, consultant anesthesiologist, BH tenure on neurocritical care. So after the break, we're going to come back to the lecture by Dr. Niluksh Pereira. She'll be doing the next lecture. So 5 minutes tea break.
Yes, madam, I'm even I will see it with your doctor.
Yeah. I'm just, yeah.
The mic is not Sure, we can start.
Okay, yeah.
Right. The next lecture is by Dr. Dilukshu Pereira, consultant anesthetist at DGH Abilipetia on pre-op preparation. Madam, your screen is sharing. We can start in a few minutes time. We can start now. You're muted, madam.
Okay, can you hear me now?
Can hear, yeah.
All right, okay. So good morning, everyone. So we are going to discuss with you for the next half an hour or so about the pre-operative preparation. Okay, so objective would be for the next half an hour or so, what is the pre-operative preparation? What do you mean by that? Why we need to do pre-operative preparations? And the other main thing we are going to discuss is about pre-operative optimization. And do we need to do optimization for each and every patient who is coming for a surgery? And what is the house officer's role in this pre-operative preparation and optimization as a team member? So, in pre-op preparation, there are two main pathways actually. So, one is pre-op assessment, the other thing is optimization. Okay, so pre-op assessment. So, why we need to do a pre-op assessment? Simply to assess whether your patient is fit for a surgery. That is the main aim. So, fitness for a surgery, you can assess in a several ways. It depends actually on several factors. First thing is the grade of the surgery. What is the grade of the surgery? We will discuss it a little bit later, the grades of the surgery. The other thing is the timing of the surgery, whether it's an elective surgery or an emergency surgery. If it is an elective surgery, actually you have a little bit of time, maybe enough time to go through the patient, assess the patient, and optimize the patient. But if this patient comes for an emergency or an urgent surgery, you might not have enough time to properly optimize the patient. So fitness is not actually, even though you have assessed the fitness, you might not have the optimization you need to have before going into the surgery. The second part is the health status of the patient. Those two factors will affect the fitness of the patient to the surgery. So if you do a pre-op assessment, it will ensure that you will optimize this patient before a surgery. That will limit or reduce the complications, because you know this patient, you have assessed this patient, you can identify what are the complications this patient will go through the perioperative period, that is before, during, or after the surgery. So you can plan for that. And because this patient is come to the hospital, in the ward, will meet the staff, that patient will familiarize with the hospital setup. And it will sometimes help to reduce the patient fear or anxiety as well. So all the factors will help for the patient. So who are the people will get involved in the preparation? It's actually a multidisciplinary effort. If you think it's only involved the anesthetists, no. So anesthetists are main part of it, but the surgical team, maybe the general surgical, ENT, GYNOPS, the surgical team will also play a major part. The consultants, senior and junior house officers, and the nursing staff. Sometimes the junior officers, the junior staff members in the hospital also play a major part as well. And the other specialties like radiology department, cardiology department, physiotherapy department. So all play a part in this multidisciplinary effort. So if you go through the pre-op assessment, it has several components. So you all familiar with the history, examination, and investigation. And there's another component comes up under this, risk stratification. We'll go through one by one. So in the history, we can go through why this patient needs this surgery, indication and related issues for this, and the age of the patient and the past medical history and control of the disease. If you take diabetes, so what are the drugs this patient on? How controlled is the diabetes? What is the fasting blood sugar? What are the complications of the diabetes, like end organ damage, like as example, ischemic heart disease, chronic renal failure, so on and so forth. So you can go through this. And then what are the drugs patient on? Drug history, allergic history, past surgical and anesthesia complication. Very important and anesthetic for us, but you have to know about those things as well, because we have, if there's any surgical or anesthesia complication in the patient's history, we have to avoid those complications. And smoking history, because if this patient is a smoker, there is a high possibility of getting lung infections for this patient. It can complicate the post-operative recovery of this patient. So we need to modify this patient's lifestyle. We might have to ask this, actually we need to ask this patient to stop smoking. And the exercise tolerance is very important, because from exercise tolerance, we can get a proved idea of this patient's fitness for surgery as well. So how do we assess the exercise tolerance? We have something called MET value. You might see in the anesthesia assessment, MET value of 4 or more than 4. So what is the cutoff of 4? If you say its MET value is more than 4, we say this patient is, crudely we can say this patient is fit enough to undergo a surgery. So what is MET value of 4? If you go through this, MET value of 4 is stair climbing, that is flight of stairs, 10 steps stairs, go through that at a slow pace without taking any breaks. If you can do that, it is MET 4. So if you can do that, you will fit enough to go under a surgery. That is actually very crude method of seeing this patient is fit enough for a surgery. If it is less than 4, you need to do other investigations to see whether this patient is fit enough to go to surgery. If it is more than 4, sometimes you might need to do other investigations, but you can roughly say this patient is fit enough. Okay, so the other part is, so we have done the history. So this is the next component is doing the examination. We can start with general examination. You can look for pallor, icterus, if the patient is awaiting for a maybe abdominal surgery or something like that. Icterus, obvious facial deformity is very important to us as anesthetists. Obesity, serious examination, pulse rate, BP, any murmurs of the heart, features of any heart failure, respiratory system, bronchospasms if the patient is asthmatic, maybe he is undiagnosed, respiratory tract infections, respiratory rate. If indicated, neurological examination as well. For investigations, what should we order? Actually, it depends on the grade of the surgery and the comorbidities of the patient. So you should not order all the investigation for each and every patient. So keep that in mind, very important. You should not order all the investigations for each and every patient. So it depends on the grade of the surgery and the comorbidities of the patient. So we have actually talked about grades of surgery. So according to the NICE classification, there are 3 grades of surgeries: minor, intermediate, and major. So minor surgeries are like skin lesion excision, abscess drainage. Intermediate surgeries, inguinal hernia, varicose veins surgeries, tonsillectomies, knee arthroscopies, etc. Major surgeries have THs, endoscopic resection of prostate, lung operations, clonic resections, radical nest dissection. So those things comes under major surgeries. So we are discussing about investigations now. So what are the investigations we have? Blood investigations like full blood count, blood urea. I haven't included serum electrolytes or serum electrolytes, sorry, creatinine, liver function test, coagulation test, and full blood fasting blood sugar. ECGs, echoes, chest X-rays, ABGs, lung function tests, and other investigations if indicated like CTs and other stuff. So we have a whole lot of investigations, but we need to go through the grade of the surgery and the patient's comorbidities to select what are the investigations we are going to order. Very important. So for minor surgeries, ASA 1, ASA 2, ASA 3, and I will discuss about what is the ASA grading later. So if you come to minor surgeries, full blood count is actually not needed for any of the grading system. This is ASA 1 is actually healthy patient. ASA 3 to 4 is more complicated patients actually. So hemostasis like coagulation test actually not routinely needed. Kidney functions not routinely needed. ECG not routinely needed. So minor surgeries not routinely needed any of the investigations. So intermediate surgeries, full blood count is not routinely needed actually for ASA 2 even. ASA 3 and 4 you might consider. Okay, kidney functions, ASA 1 that is healthy patients not needed. But ASA 2 you might consider. ASA 3 and 4 that is more complicated patients. Yes, you have to. Something like that, so on and so forth. You have to go through the patient's condition, then order. Okay. So we have discussed about ASA grading. ASA grading is a system. We are doing it in anesthesia to do the risk stratification. So we have talked about 4 components in pre-op anesthesia. That is history, examination, investigation, and the 4th one is the risk stratification. So in risk stratification is the ASA grading. ASA standing for American Society of Anaesthesiologists. So they have formed a grading system to assess the patients who are coming for anesthesia, to categorize them according to their seriousness of the illnesses. So ASA 1 means they are healthy patients. There are no other problems with them. ASA 2 is mild to moderate systemic illnesses, but they are very well under control. No problem at all. Maybe diabetes, but very under control. Sugar is very well under control. ASA 3, severe disease process limits activity, but it's not incapacitating. Severe disease is there, but it's not like severe diabetes is there, but it's not problematic to day-to-day life. ASA 4, severe incapacitating disease process, and it is constant threat to life. As an example, ongoing ischemia, like the patient has acute MI, awaiting the immediate surgery, urgent surgery. That patient has a life-threatening condition at the moment, but he needs urgent surgery as well. So that is the ASA 4 patient. Okay, so ASA 5 is moribund patient not expect to survive 24 hours with or without operation. Even you do the surgery or you do not do the surgery, patient is not expect to survive for the next 24 hours. As an example, ruptured aortic abdominal aneurysm. That kind of patient comes under ASA 5. Okay. So So ASA6 is already declared brain dead patients, but awaiting organ donation. That's why we are keeping this patient on ventilator. So they are the patients comes under ASA6. So that is the risk stratification of pre-op assessment. Okay, so optimization. So we can do optimization in several categories, under several categories. First thing is do the optimization of the medical condition patients are already having. One thing is control the blood sugar. We can start oral hypoglycemics or insulin to control the sugar, control blood pressure, antihypertensives. Optimum chronic lung conditions, maybe we can start bronchodilators, nebulizations. If they have in lower respiratory tract infection, treat that. Chest physiotherapy, spirometry. The patient smoking, as I told you earlier, to stop smoking. So optimize the patient's medical condition before going into the surgery. That is one of the optimization methods that you have. The other thing is modification of the drug therapy. So what can we do? How can we actually modify the drug therapy? One thing is sometimes we might need to stop some of the drugs before the surgery, like withholding oral hypoglycemic drugs day before the surgery. Like if the patient is going for a surgery tomorrow morning, we ask them to fast. So previous day night after the surgery, or in the morning of the surgery, we stop the drugs, the hypoglycemic drugs on the morning dose. We ask them to withhold that dose of the patient. Okay. If the patient is on antiplatelets like clopidogrel, if the patient is awaiting to go for a spinal or epidural, there's a risk of developing hematomas. Because of that, we ask them to stop clopidogrel at least for 5 to 7 days. So that is also modification of drug. And anticoagulants. So if the patient is on warfarin, we need to stop warfarin. And since they might be on warfarin for some reason, like valvular replacement of the heart or chronic AF or something, so we need to put them on some other anticoagulant if we take off the warfarin. So we need to stop warfarin and we need to put them on any other drug, some other alternative drug. So we stop warfarin and we put them on enoxaparin or heparin. So we have to discuss it with multidisciplinary team like neurologists. So we stop warfarin, we start on enoxaparin or heparin. And before the surgery, 24 hours before the surgery, we have to withhold enoxaparin or heparin as well. So we have to discuss and we have to cross liaise with the hematological people and the surgical team as well when we do the drug modification as well. Okay, the other component is the fasting. So we ask when the patient is come to a surgery to fast. So what are the optimal hours to fast? For solids, we ask 6 hours. For breast milk, we ask 4 hours. And for clear fluids, we ask 2 hours. But keep that in mind, avoid over fasting. And if you know your patient is going for a surgery, you have to get an idea, your patient, like let's say Siripala is going as the third case for the surgery. So you can get a rough idea, he is going at 10 a.m. That's it, he's going at 10 a.m. So he's a diabetic and he needs to fast only for 6 hours. So if we keep fasting from 8 p.m. previous day, so he will be over fasted. All the hemodynamics, hemostasis and everything will go haphazardly and he will become hypoglycemic. Okay, so he should be fasting from 4 a.m. So you have to pre-plan those patients. So avoid over fasting, especially in elderly people and in pediatric patients. Keep that in mind. You can pre-plan and avoid over fasting. Keep that in mind. Okay. The other thing is the pre-medication. Pre-medication, we have several groups of drugs: antacids, antiemetics, anxiolytics, and analgesics. Why antacids? To reduce or the neutralize the acidic contents in the stomach, to prevent, if patient aspirate, to prevent the chemical pneumonitis part. Antiemetics to prevent vomiting or the nausea, because sometimes some of the anesthetic drugs and some of the surgeries are nausea, like they are they can provoke emesis. That's why. Okay. And anxiolytics, because almost all patients who comes for surgeries have some component of somewhat anxious. So you can give anxiolytic drugs for these patients, but keep that in mind. Some of the elderly population will not tolerate anxiolytic drugs very well. And analgesics, yes, you can give oral analgesics before coming into surgery as well. So all these drugs, a group of drugs, you can give as pre-medication. So what else we can do for optimization and as the preparation for surgery? Post-operative care plan. So we know this patient, we have assessed this patient, we know this the grade of the surgery, we can predict the complications. So we can predict this patient need ICU or not. So if we think this patient needs ICU care, we have to book an ICU bed pre-operatively. And please check the availability of the bed before this patient comes to the theater on the day of the surgery. Okay, before anesthetizing this patient, you have to check. That is your responsibility as the part of the surgical team. Anesthetist will also do, but that is your responsibility as well to check the availability of the bed. Okay, and getting an informed written consent for the surgery and for the invasive procedures as well. For the lining surgery, maybe the epidurals and the other stuff. So you have to get the informed written consent, and the grouping and DT, and the sending the theater list. So we are usually sending the theater list on the previous day. Why do we need to send the theater list on the previous day? Because we have to get ready for the list without delaying the procedures. Because in our country, we have so many cases on the list. So we don't have time to get ready in between the cases. So we need to get ready with the drugs, get ready with the equipments. Maybe sometimes in between cases, we need to clean them, autoclave and sterilize again to get ready for the next case. And sometimes we might need to get the specially trained staff as well for the surgery, specialized surgery. So you need to inform the theater beforehand. So usually in our hospital, we ask them to at least send before 2 p.m. Previous day to the theater, so they can get ready for the following day for the surgical list. And pre-op checklist before sending to the theater. If you have a pre-op checklist, you will pick them one by one before sending to the theater. So you will not miss any of the important things. So otherwise, the patient will get, the surgery will get postponed, patient will be very disappointed and anxious. So we can avoid all of the things if we do what we have talked about today and check the pre-op checklist. Actually, that is the last slides of my presentation. I hope you have gathered the very important things of my lecture. So I would like to stress on, you should not order all the investigations for intern implication. That is one of the main things. And send the theater list before previous day, because theaters needs to be ready with the enough staff and the drugs and the equipment for the following day for the surgery. If you book ICU beds and ICU bed, check before you send the patient to the theater whether they are available or not. So thank you very much. If you have any questions, please send to the chat box. We will reply back to you. Thank you very much. Prashant, back to you.
Okay. Thank you, madam, for that detailed lecture. So, as well, Dr. Dilux Pereira from DGH Milipitia on pre-op preparation. So, next up is by Dr. Anupa Herath, consultant anesthetist at DGH Trincomalee on airway. Dr. Anupa, are you there? Dr. Samanmali, are you there? Hello.
Hello.
Yes.
Roshan, I think it should be Dr. Bimal.
Okay. I think Dr. Anupa said Dr. Samanmali is here.
No, that is me. That is me.
Okay.
Dirukshi. My other name is Samanmali.
Okay.
Anupa?
Not there.
Ma'am, I have already finished my presentation. No, Bimal.
Okay, we'll have a tea break now. We'll start at 12 o'clock. So join by 12 o'clock. We are going to start at 12. Thank you.
Prashant? Prashant? Prashant, මාව ඇහෙනවද?
Yes, I can hear. Yes.
Good, no? Reception is audible.
Yeah, audible, sir. Clear. I've made you a co-host. You can start.
All right, can I share then? Can you see my slides?
Yes, I can see. Yeah.
Tell me when you want to start.
Right. Welcome back after the tea break. The next lecture, also a very important lecture on oxygen therapy, is delivered by Dr. Bimal Kudavidanage, consultant anesthetist at National Hospital, Colombo, and he's the chairperson for critical care faculty in the College of Anaesthesiologists. Over to you, sir. Can you hear? So you can start.
Thank you, Roshan.
Yes.
Am I audible? Okay. Yeah.
So your mic is not detected on the computer.
Hello. Can you hear me now?
Yes, sir, but it will faintish, but can hear.
I'm sorry about that. I think there's a problem with the connection.
That's okay. That's okay now.
Okay.
It's okay now. Yeah.
Okay. So thank you very much for giving me this opportunity. We are going to discuss about oxygen therapy in this lecture, which is one of the important therapies in critically ill patients. So broad overview is now I will go through the prescription of how to prescribe oxygen, then what are the types of indications you have to prescribe oxygen, and then what are the types of equipment available in our setup. Then not only administering oxygen, we need to avoid any toxicity. So therefore, we will go through some of the monitoring modalities available to monitor oxygen. So why we required oxygen? We need the oxygen for our ATP production at the cellular level. Okay, so therefore, so basically aerobic metabolism, which happens in the cells in the mitochondria, needs oxygen for their metabolism, which produces 38 ATPs. Whereas if you go for, if you have lack of oxygen, which causes anaerobic metabolism, and you will produce only 2 ATPs versus 38 in the aerobic metabolism. Whereas you get, in addition to that, lactic acid production also. So therefore, we need to have a aerobic metabolism for our optimum energy production. So we consider oxygen as a drug, as in other drugs. We prescribe if it is a IV or oral or any other drug, we prescribe. So we have to know, consider oxygen in the same way. So we need to know what are the indications, in which time or at which point we should prescribe, to which patient, and how much to prescribe, in what interface we should be giving it to the patient. So we need to know these things before we prescribe the oxygen. So it has to be done in a by a trained staff. So if you look at the indications for oxygen therapy, if you have a patients having SpO2 or of less than 92 on air, or in a blood gas where the PaO2, that is a partial pressure of oxygen less than 60 millimeter mercury, that is, you have a documented evidence of patient is having hypoxemia. In addition to that, in acute care situations, if you suspect hypoxemia, in ABC management, we usually apply oxygen with a given amount of flow rate. And then in trauma setting also, in our guidelines, ATLS and other guidelines, national guidelines also advise us to give oxygen in a airway and breathing stages. Then acute MI also, we try to give maximum oxygen for the myocardial tissues. Therefore, we should apply, but it may not be the 100% oxygen. Then in a short term, as a short term therapy, we apply oxygen for pre-anesthetized period, so that we need to fill the stores of the oxygen in our body, and also from recovering from patients who are recovering from anesthesia, where they might have we might have been giving nitrous oxide. So those nitrous oxide will be exhaling. So therefore, we need to give oxygen to exhale nitrous oxide. So on the other hand, in severe infection, sepsis, where metabolic demand is high, if the normal oxygen supply is not adequate, we will supply additional amount of oxygen, like in severe sepsis, burns, and multiple injuries, polytrauma, those kind of events. Due to the increased amount of metabolic activity, we may supply oxygen, and in a situation where seizures or fits occur, we supply additional oxygen to the brain, try to give additional oxygen so that it will be supplied to the brain. So what are the goals of oxygen therapy? So main goal is supplying additional oxygen is to prevent hypoxia or hypoxemia. There are two terms that we refer to. Hypoxia is lack of oxygen at tissue levels. And emia or like hypoxemia means that lack of oxygen in the blood. So we try to avoid these two, hypoxemia and hypoxia, so that there is an adequate level of oxygen supply to the cellular level. Then how do you assess adequacy of oxygen? So there are clinical assessments, and there are other ways of using either biochemical or chemical assessment. So what are the clinical features? So if patient is having acute hypoxia, he may be restless, and main organ which affects the body is the brain. So patient become confused, disoriented, and respiratory rate goes up. We become respiratory distress, and probably body try to compensate by increasing blood supply to the vital organs. So initially patient become tachycardic and probably hypertensive, and then later on, once this acute stage progress to the latter stages, they become hypoxic bradycardic and then can lead to cardiac arrest. What are the chronic features of hypoxia? If the patient is exposed to chronic hypoxia, they will feel fatigued, drowsy, and the work capacity may be reduced, and then with delayed reaction time. So whole day they feel very, very tired. So that is a feature of a chronic hypoxia. Probably this is very much evident in patients who are obstructive sleep apneic patients, where they are intermittently hypoxic overnight. So they may be drowsy, sleepy during the daytime. Then good modality of assessing the oxygen level in the blood. Oxygen, that means you can assess oxygen different ways in the body. One is you can assess oxygen saturation. Then you can assess oxygen tension in the blood. Then you can also calculate oxygen capacity in the blood. So one easy way of, common way of assessing oxygen saturation, whether it is adequately saturated. Saturated what? Hemoglobin. Hemoglobin is the main carrying molecule of oxygen. So whether it is adequately saturated with oxygen, we can measure it by pulse oximeter. So you know that there is an oxygen flux equation. So one molecule of hemoglobin can bind 4 oxygen. So to bind all 4 oxygens, you need to have a oxygen saturation of more than, if the 4 oxygen molecules have been bound to the hemoglobin, you get a saturation of more than 94 to 96. Okay, so you can indirectly assess whether oxygen is saturated in the hemoglobin. Then you can also do a arterial blood gas, that takes some blood to a 1 cc syringe, heparinized syringe, and put it to a blood gas analyzer, and then you can take a oxygen level on that blood. Mind you, it gives you an oxygen tension in the dissolved blood. So it's a dissolved blood, and it's an oxygen tension it gives. Then we have a kind of a blood gas machine also gives an oxygen saturation in the blood. So SaO2 means that oxygen saturation in the blood given by the blood gas machine. So That is also, you can read it from the blood gas report. There are other surrogate markers which we can assess whether global oxygen supply is adequate for that patient. So those are in the blood gas, we can get serum lactate levels. So I said earlier that lactate is produced when the oxygen supply is inadequate. So if your blood gas machine gives you more than the normal amount of lactate levels, it is a most common thing to happen is that your oxygen supply to your cells is inadequate. So normal levels may be around 1 to 2. So if it is more than 2 serum lactate levels, you think or you assume that the global oxygen supply to the tissue level is inadequate. There may be various reasons, so you need to find out the reasons. In addition to that, it produces metabolic acidosis due to lactate. So you can see the pH levels also going down due to lactic acidosis. So target of oxygen, how much you are going to target in these patients? So there are different scenarios. We try to achieve different levels of oxygen saturation. Mainly we are talking about because it is very easy to measure the oxygen saturation levels in a patient. It's a non-invasive method of assessing oxygen saturation. Or that is in other words, how much oxygen is bound to as a percentage of to the hemoglobin. So in a young patients, we try to achieve, young active patients, we try to achieve more than 96. If it is patient becomes elderly, you may not target more than 96. It may be around 94, 96, in between those range. In a critically ill patient, we might, like in pneumonia, we might try to achieve more than 90 at least. So those are depending on the clinical situation, we target different levels of oxygen. But we all know that COPD patients, where they are chronically hypercapnic, where their oxygen, the respiration depends on the oxygen tension. We know that our oxygen, our respiratory rate and the drive depend on the carbon dioxide levels. But because of the high carbon dioxide levels in the COPD patient, they are oxygen driven. So if you supply a lot of oxygen, their oxygen drive may be, or their respiratory drive may be suppressed. Therefore, we target around 88 to 92 in COPD patients. So as such, we target different oxygen goals to different patients. This is important when we prescribe the oxygen to the patient, because you need to know the patient, why we are giving that patient oxygen, what is his clinical background, and what are we going to achieve. Okay. So how are we going to achieve this oxygen goals with our devices? So we have to have a oxygen supply, continuous oxygen supply, either with the cylinders or if you have a pipeline supply to in your HDU or ICU, you have a continuous supply from the pipelines, or you need to have a oxygen supply with the cylinder. Then you need to have an interface. Interface means how we are going to give this oxygen supply to the patient. Either it could be either nasal prawns, mask, or any other device we can use. Okay. So what are the factors determining which method of oxygen delivery we are going to achieve? So basically, we need to consider few items. So what patient prefers, or whether patient accept this. Sometimes patients are confused. They don't like to keep the mask, right? So then in these cases, because patient become violent when you put mask. So you have to have an alternative method of giving oxygen, probably nasal prawns. Right? Then how much oxygen you are going to give? So different oxygen giving devices can achieve different levels of saturations. So therefore you need to balance that to the patient's requirement. Okay. Then how much resistance or work of breathing is patients putting the effort to get the oxygen into the lung. So sometimes their work of breathing is normal. In that case, you can use a normal mask. But if the work of breathing is high, they may not be able to sustain that work of breathing out. Therefore, you need to consider giving a bit more support to ventilation, right? So therefore, you need to select a device where supplies breathing support. Then, as you know that during inhalation, the air, outside air goes through nasal passage. While it is going through the nasal passage to the trachea and to the alveoli, dry air, outside dry air is humidified and, I'm sorry, somebody is trying to tell something. So normal breathing, our air is humidified and warm when it goes to the alveoli. But we need to mimic this if you are using a bypass. That means if you are using a tracheal tube or ET tube, there's no way of natural humidification occurring. So therefore, we need to artificially humidify the oxygen we are giving, because cylinder oxygen is dry oxygen. Then you need to know what are the available facilities in your ward or work site or ETU or whatever. So because even if there is an ideal item or the device is there, but if you don't have it, you can't give that method. So you should know what are the alternatives you are having to achieve that oxygen goal. Then of course, oxygen is costly. As other drugs, we need to spend on oxygen. So it is a precious substance. So we need to preserve it. We should not unnecessarily give oxygen to the patient. One thing is it is economic issues. Other thing is it can cause toxicity to the patient. So let's see classification or simple classification of oxygen delivery devices. There are various classifications. So low flow devices and high flow devices, then fixed performance devices and variable performance devices, and then you can divide it as invasive and non-invasive devices, like that. So if you take these low flow systems and the high flow systems, low flow systems contains nasal cannulas, simple mask or Hudson mask, then the Venturi mask. Then if you take high flow devices, you have high flow nasal oxygen devices, non-invasive ventilation and invasive ventilation. So what are the low flow devices? Under low flow devices, variable performance devices. Variable performance devices means that your whatever the oxygen amount or concentration delivered to the patient is variable. It depends on the patient's effort. That means patient tidal volume, respiratory rate, respiratory effort. Those things will determine how much oxygen patient will receive. That is the basis of variable performance device. On the other hand, fixed performance devices does not depend on the patient's respiratory effort for their oxygen concentration, which is delivered to the patient. Okay. So for examples, variable performance devices are the nasal cannulas and simple face mask and non-rebreathing mask. So this may be familiar to you, the nasal prongs or nasal cannulas, right? It delivers about 30% oxygen, and the maximum flow rate you can go is 4 liters per minute. And it is very simple device, and you can attach as shown in the picture here. You can put it around the patient's ear and fix these two nozzles into the patient nostrils. And the advantage is it's a comfortable device. Patient can keep it, and then patient also can, while keeping the oxygen flow in, he can talk, he can cough, he can take drinks, or he can eat, right? And only thing is maximum flow rate is about 4 liters. If you go beyond 4 liters, it becomes discomfort to the patient. So thereby it is a disadvantage. And this, because usually we can't humidify this oxygen, so it tends to dry the nostrils, and sometimes patients can have epistaxis as well. So the simple face mask, or the proper name is Hudson mask. So you may have seen this you may have seen this device in your either your while you are in the medical college or in the ward. So there's a strap and then the mask, polypropylene mask, which fits the patient's mouth and the nose, and then there will be an oxygen supply tube. Okay, and this is a transparent device with a nasal clip like that, so that you can adjust the metal piece according to the shape of the patient's nose. So this is a simple device, lightweight, and we can deliver up to 60%, depending on your oxygen flow rate. So if you give about 5 to 6 liters, it will deliver roughly about 40%, and then beyond that, it goes up to about 60%. The disadvantage is it is a bit uncomfortable to keep, right? The patient, if patient cough, he needs to remove it, and expectoration of secretions is difficult, and it is difficult to speak or drink while having the mask. They have to remove it. Okay, and also this also tend to dry the mouth, right? And overall, it is a bit difficult to keep, especially if you have a trauma in the face. Okay. Then we have the fixed performance devices. What are these fixed performance devices? Venturi mask, and then anesthetic mask, and then high flow nasal oxygen therapy, then CPAP and BiPAP devices, and then oxygen tents. So you may have seen this in the pediatric intensive care units. The small infants or neonates are put into a device like this. It covers basically neonate's head, and fixed amount of oxygen is supplied to this tent or the oxygen hood. So if you apply 40% with the appropriate flow rate, this will contain about, inside this hood, contain about 40% of oxygen. Patient can, or the child can, breathe that oxygen through the normal nasal and nasal passage. Okay. So your access to the other parts of the body is preserved. Okay. Only the hood is, the head is covered. Whereas oxygen tent, you put a whole kind of a canopy onto the children or the infant, so that you can increase the concentration of oxygen inside this volume. Okay. So therefore, you can't increase the pressure, but only the increasing concentration of oxygen, and the child can breathe that oxygen inside this tent. So you can go up to 40% of oxygen with this one. Then you have a mask with a reservoir. So this was popular during our COVID times. There are two types: partial rebreathing mask and non-rebreathing mask. the device is, I will show you a picture later on. There is a reservoir bag attached to the mask. So the purpose of this reservoir bag is to, you know that our respiratory cycle consists of inspiration and expiration. During expiration, we exhale our whatever the inhale volume. But if the patient is connected to the continuous oxygen supply, while we are expiring, this oxygen supply through the tubing is wasted unless you collect it into a bag to give it to on your next inspiration. So these devices is doing that. Okay. So these devices are doing that. So this is a kind of a, so this is actually a non-rebreathing mask. The difference is there's one-way valve either side of the mask, and there is another one-way valve here. So oxygen is connected here. Continuous oxygen flow is connected here. So there is a one-way valve between the mask and the oxygen supply, and this the reservoir bag. So during exhalation, what happens is, this is a non-rebreathing mask. Okay, patient is exhale, and this through this one-way valve, the exhale gas is vented outside. But during that period, say 2 milliseconds, right, or 2 seconds or something like that. 2 seconds actually, about 2 seconds, this oxygen supply, continuous oxygen is supplied to via this tubing, and it is filled inside this bag. Okay, so during next inspiration, this tubing continuously supplies oxygen. Say this, for this device, we have to give about 10 to 15 liters of oxygen flow rate. Okay. So that amount will go towards the mask, and whatever collected here in the reservoir bag is also will go through this one-way valve, because it only goes through this way. It doesn't allow exhale gas to come into this reservoir bag. So it will go through this way and go to the mask, and through the mask, patient will inspire. So this will help to increase the oxygen concentration. Actually, we can give up close to 95% of oxygen if you are giving adequate flow rate. So you need to give about more than 10 liters to achieve this 95%. Okay, so that is non-rebreathing. Partial rebreathing bag is that there is no one-way valves either on the sides of the mask or the in between the reservoir bag and the mask. So it is one-way valves. So whatever the exhale gases exhaled by the patient, part will leak out through the side holes, and other part will be collected in the reservoir bag. And during expiration, this continuous supply of oxygen will be also collected in the reservoir bag. So because there's no one-way valves, these partial rebreathing bags cannot achieve same concentration of oxygen as in non-rebreathing bags. But it can, if you give an adequate flow rate, you can achieve up to 80%. That is more than the Venturi devices. Okay. So advantage of the devices, rebreathing devices are you can achieve higher concentration of oxygen than other masks. Okay. But you need to have a technical knowledge that these bags or these reservoir bags should not be collapsed during inspiration. If it is collapsed, that means your oxygen supply to these devices are inadequate to compensate for the higher intake of oxygen or higher demand of oxygen flow rate to the patient. So you have to be very careful when you are giving oxygen through these devices. You need to monitor the reservoir bag. It should not be fully fully collapsed. Okay. In that case, you need to increase the oxygen to 15 liters. Beyond that, if the bag is collapsing, you need to choose another device because you can't handle that demand of oxygen with the rebreathing or non-rebreathing bags. Okay. Then we come to another fixed performance device, a Venturi mask. So you can see this mask. There is a same kind of transparent polypropylene mask with the shape of the face, and then there is a colored device connected to it, and there's a vented holes here on either side of the mask, and this colored device is connected to oxygen supply. So if you can see here, there are 6 colored devices, and see the markings on that, right? So 24%. Below that, it says 2 liters per minute. 28%, 4 liters. 31%, 6 liters. 35%, 8 liters. 40%, 10 liters, and 60%, 15 liters. So these devices are Venturi device. This depends on the Bernoulli principle. What Bernoulli principle is that when you supply a high flow of oxygen through a narrowing, it will entrain surrounding air through the holes. There are holes here, surrounding air through these holes. If you have a high flow of oxygen through this narrowing, because there will be a negative pressure created here due to this narrowing. Okay. So how much oxygen is entrained will determine by these flow rates and the size of the hole. Okay. So you can appreciate that the size of the hole is changing, right? So here, very small size, and see the flow rates. Now this is 2 liters, and in a 60% one, it is 15 liters. So this is a very high flow rate. Okay. So if you fix this yellow one to the patient, and if you are giving 8 liters per minute, it will give the patient a 35% oxygen, and it will make sure that patient gets 35% of oxygen in a spontaneously breathing patient. Okay. If you want to increase the amount of oxygen to be delivered to the patient, you either select red or green one depending on the requirement and adjust the oxygen flow rate so that it will increase. So this is the chart which gives us the color code and the amount of oxygen delivered to the patient if you give this much of flow rate, right? If you select, for example, if you select a green device, and if you put 15 liters per minute, it will deliver the patient 60% oxygen. Understand? So maximum you can give is 60%, but non-rebreathing bag, you can go up to 95%. Okay. So the advantage is that this gives a precise amount of oxygen. So like patients who you think that you need to control the oxygen, we can use this kind of mask. Okay. And we can humidify this oxygen flow. So therefore, we can reduce the dryness also in the mouth. Then unfortunately, you have to keep the mask, and sometimes you have to give a very high flow rates. It may be a bit uncomfortable for the patient, and he can't, he has to remove the mask to take any drink or eat, and probably remove the secretions. So it is not that easy, but it gives about up to 60% of oxygen. So then we learn about several types of oxygen delivery devices. Those are called interfaces, right? Mask, nasal prawns, right? Various types of masks, right? mask with the reservoir bag, right? Okay. Then we have to know what are the complications of oxygen, because I said it's a drug. So every good thing has a bad side. So therefore, even oxygen has some side effects. So what are the side effects? So it causes dryness, because our oxygen, which we have in our cylinders, is dry oxygen basically. So therefore, without humidification, if you deliver it to the patients gets mucosa gets dried, right? Then if you give unnecessary high amount of oxygen to the patient, as I said earlier, like in COPD patient, their ventilatory drive become less and they may go into respiratory arrest. Okay. Then there is oxygen toxicity. So depending on how much concentration you are delivering and the duration, the toxicity varies. So if you are giving 100% oxygen, within 12 hours, patients can develop pulmonary oxygen toxicity. And if you are supplying 80%, you can give up to 24 hours, but you have a risk of, beyond that, you have a risk of having pulmonary toxicity. Okay. Then what are the symptoms? They will have a cough, dyspnea, reduced compliance in the alveoli, and pulmonary fibrosis if you are continuously give oxygen, unnecessary high amount of oxygen to the patient. Then obviously in neonates, it can cause retrolental fibroplasia, especially in the premature infants if you give high amount of oxygen. So you need to know to which patient and how much oxygen we are going to deliver. That is a prescription, okay? And the duration, you need to limit the duration, okay? Then one other thing is, now if you continuously supply oxygen, then the with 100% oxygen, you tend to collapse the alveoli due to the absorption. So atelectasis is possible if you are giving 100% oxygen to the patient continuously. Then one other thing is, now we know that our lungs have an automatic system of hypoxic pulmonary vasoconstriction, so that what happens is in the pulmonary capillaries, diameter automatically change depending on the oxygen concentration in the alveoli. That is called hypoxic pulmonary vasoconstriction, to reduce the VQ mismatch. So if you're continuously supplying high amount of oxygen, this mechanism will not happen. So you can increase the shunting also. Then how are we going to monitor our oxygen therapy? So you need to monitor these patients regularly. That is a must. Okay. Then objectively you can monitor. Subjectively you can monitor. What are we going to monitor? Respiratory rate, okay, and the discomfort, right? Then we can monitor objectively pulse oximeter values, whether it is 96, 94, or 88, okay. And then of course we can do a ABG depending on our requirement. It's an invasive procedure, so you can't do it very regularly unless you have arterial cannula. So we can assess dissolved oxygen and the oxygen saturation in the blood, okay. Then obviously other standard monitoring, cardiovascular and respiratory monitoring has to be done if you're giving oxygen to the patient. So what other advanced devices are available? If your initial interfaces fail, the other devices we can use is, these are commonly used during the COVID era or COVID period. One is high flow nasal oxygen therapy, right? What it does is it gives a very high flow. You know that our oxygen flow meter gives about maximum of 15 liters per minute. But these devices can produce up to 80 liters per minute. Okay, so it's a very high flow rate, right? But advantage is that in our normal nasal prawns, it does not humidify. But these devices can humidify oxygen, these high flow oxygen, and given to the patient via nasal, kind of a special nasal cannula. Its diameter is larger than the nasal prawns. Okay. So because it is humidified, the less discomfort, and because it is given in a very high flow, you can increase the PEEP or positive pressure to the patient. So that patients, the study shows that patient's airway is kept open, right? And it supports respiratory inspiration rather, right? And you can give specific amount of oxygen up to 100% with these devices, depending on your oxygen supply. You need to have a very high oxygen flow supply to operate this. But the disadvantage is patient may have some discomfort because it's very high oxygen flow rate. And usually we don't ask them to drink or eat during these therapies, right? And patient has to have a spontaneous breathing. Okay. Then failing high flow nasal cannulas, we can go for a non-invasive ventilation. These separate devices are available for NIV or non-invasive ventilation, or we can use conventional ICU ventilators to deliver these modes. Okay. Only thing is you have to select the non-invasive mode in the conventional ICU ventilators, because there are very high leaks when you compare to the tubes, ET tube or a tracheostomy tube. So you can see this in the picture here. There's a mask tightly fitted to the patient's face. Okay. So this can be delivered either with this kind of mask, which is the most popular facility available in Sri Lanka. But you would have seen in European countries, they use the kind of a hood in adults to deliver CPAP hood. Up to, especially in Italy, you would have seen there's a hood like this, which is creating a positive pressure, continuous positive pressure. CPAP is continuous positive airway pressure. Okay. So there's a high, in addition to increasing the oxygen concentration, you can increase the pressure of the supplied oxygen. What will happen is your ultimate oxygen concentration depends on partial pressure of oxygen in the alveoli. Okay. How much diffuse into the blood depends on the partial pressure of oxygen in the alveoli. So not only the oxygen concentration matters, the pressure which it delivers is also matters. So these devices can increase the alveolar oxygen pressure. Okay. So you increase the oxygen concentration, and tightly fitted mask or hoods can increase the oxygen pressure also, partial pressure of the oxygen delivered to the patient. So therefore, the oxygen diffusion through the alveolar capillary membrane is increased, which that's what we want to deliver more oxygen to the blood, patient's blood. Okay. So difference between CPAP and BiPAP is that CPAP is just supplying continuous positive airway pressure in the inspiration and the expiration. If you set at 10 centimeter water, it will deliver 10 centimeter water during inspiration and expiration. But the BiPAP, what happens is that during inspiration, you can set a high pressure, say 15 centimeter water. During expiration, you can lower the pressure like 5 to 7.5 centimeter water. So there will be two pressure levels where patient inspiration, when the patient is inspiring, it will deliver higher pressures of oxygen to the patient, and during expiration, it lowers the pressure. So that is BiPAP or bi-level positive air pressure. Okay, it helps in kind of wash out of carbon dioxide as well as increasing oxygen to the patient, especially in the kind of pneumonia patients who are going into ARDS. You can use these kind of devices. Okay, and especially CPAP you can use in patients with pulmonary edema due to heart failure or any other cause. Or CPAP is commonly used in obstructive sleep apnea patients to keep open the airways so that it doesn't collapse. Okay, that is the main pathology of sleep apnea. So this is there are two types. This is a single lumen devices or single circuit devices where this positive pressure is given by this machine and it is delivered to the mask, and there are holes here to exhale the expiratory gases. Okay, and this is another device, 2 lumen device, right, or dual circuit where inspiration and expiration can occur. Our conventional ventilators also do like this. There is 2 lumen, 2 circuits, inspiratory part and the expiratory part, so that exhale through the machine. If you don't have during COVID era, what happened was that you can't leak the exhale gases through here. So you will have to connect a separate device to a exhale through a filter, because otherwise the whole environment will get contaminated. Okay, so there are different masses for different devices. Single lumen devices has different mass, double lumen devices has different mass, but the main feature is that it has to be fitted tightly to the patient's face. So it is a bit uncomfortable. As you can see, it is strapped to the patient's head. Okay, then failing these devices, because we try high flow nasal, bit of an increase of PEEP, and then high concentration, and then we increase the concentration and we increase the partial pressure of oxygen by NIV or non-invasive ventilation. If the patient is deteriorating, next option is to go for an invasive ventilation. There we need to intubate the patient. So either put an ET tube down the trachea or use LMA or some kind of a interface, invasive interface to the patient, and then connect it to a conventional ventilator like this, so that it will be connected to the patient like that. So you can control oxygen in that device. Then we can select a mode appropriate to the patient requirement, and we can give specific tidal volume, which is patients depending on the patient's weight or the height, basically, and the male, female. And then we can control the rate, how much breaths we are going to give in 1 minute. Okay, and then we can apply PEEP or positive end expiratory pressure. That is, we do not exhale fully. We keep some air inside the alveoli at the end of the expiration to open. Hello. Now this is the last slide. Okay, this is the last slide. Okay, and then if the patient is waking up, we can add some more features to support the inspiration and all that. So disadvantage is that we need to have an endotracheal or tracheostomy tube, and usually we need to add a sedation for these patients. Then there are complications, whole lot of complications added to this mechanical ventilation. So there are different things we did during the COVID era, which is may not be applicable now. So we have to be protected with using PPE, and ideally patients should be in the ICU setup. Patients should be in a negative pressure rooms, right? And the close monitoring is required. Yeah. Thank you for your attention. Any questions I might be able to answer? Any questions? Hello?
I think no questions, sir. If any
Okay.
questions, please type on the chat box. So
you can you can email to me and I will send the answers. Okay. Sorry about the initial delay. There was a connection problem in my place. Sorry about that.
But it was okay afterwards, right? So
Yes,
that was Dr. Bima Kuda Vitanaki, consultant anesthesia in NHSL on oxygen therapy. So we are going to the next lecture by Dr. Anupa Herat, consultant anesthesia at DGH Trincomalee on airway. Over to you, sir.
Yeah, yeah, it's done. Can you hear me? And
yes, we can hear you.
Yeah, right. I'm going to share the screen. Yeah, sharing my screen. I think you all can see my screen, isn't it?
Yeah, we can see.
Fine. Yeah, okay. Good. Right. What about the others? Can you hear me?
Dr. Anupa, this the line, the voice is breaking up.
So we can do, yeah. So welcome back to this intensive care kind of critical care training. I'm going to discuss about the airway management in about 40 minutes. So can you still hear me? What about this? Anyone just in the chat say they can hear? Okay. Roshan, can you hear me now, Roshan?
Yeah, now better, yes.
Oh, okay. There may be some connection error. I'm going to share the screen. Yeah. Okay. Roshan, how's the screen? Can you see the screen?
We can see. Need to make it full screen.
Yeah. Right. Right. So in next Is it interrupting, Roshan?
Still, once you start sharing it.
Hello?
Yeah, once you start sharing, it gets slow. Voice is breaking up. The option is to join, share and join.
Roshan, is still talking?
No, still not clear, the voice.
Roshan, how it's now?
Still breaking up. I think low bandwidth. Yeah, still breaking up, Doctor.
Sorry about this. Breaking up, isn't it? But it shows good signal strength. Don't know what's the problem here. Yeah, give me a second, please.
Dr. Anup is finding some technical issues, so he will join shortly.
Roshan, can you hear me now?
Yeah, can hear.
All right, so let me share the screen, and I'm just connecting with my phone. I think there's a problem with the data connection. Yeah, just let me know whether you can see the screen.
Yeah, now it's better. Yes.
All right, Rani, thank you. And sorry, extremely sorry. There's a it shows full data, but I mean, it's signal strength is fine, and there may be some. Right. Okay. Fine. Okay. Everything is good, isn't it, Roshan?
Yes. Yes. Okay.
Yeah. Okay. Right. Okay. Welcome back, guys. We will discuss about the basics about airway, and it is really, really important you all to know about the basics of airway and some basic airway manuals. It's because it need to be highlighted that everywhere you go, airway plays a big role, right? So therefore, that is why we have incorporated this lecture into this training program, and my objectives are like that. So we'll move on without wasting much time, right? So this is basically two algorithms, so flow charts in managing two different emergencies. One is anaphylactic shock, how to manage a patient with anaphylaxis, and other thing is adult tachycardia algorithm. These are two different entities, but I want you to highlight that this, can you see airway breathing, ABCDE approach is the basis of managing anaphylaxis. The same thing applies in tachycardia algorithm. Again, you need to assess ABCDE. So airway breathing comes first. Whenever, whatever emergency management or critically ill patient, when you're assessing, airway and breathing are the most different things. So if you miss these golden 2 points, airway and breathing, no point attending the rest of the patient, because you might lose the patient. So that's why it's really important to have a good competency in airway handling and identifying compromised airway, right? Yeah, so this is an overview of anatomy. If you can see here, the larynx and the vocal cords, above that is, we used to call it upper airway, and below that we used to call lower airway. And it is really, lower airway is really important, but in most of the time in your, clinical encounters, when we deal with the patients, we have to handle the upper airway 90%. Because patient presents with normal anatomy and abnormal anatomy, whatever physiology or anatomical abnormalities, we are to handle with the upper airway. So you have to have a good understanding and good experienced hands and competency in managing upper airway. And this second picture, just pay your attention to this picture. Can you see when the patient is supine, there are, oral cavity is there and two nostrils and the nasal cavity, and it goes to nasopharynx and the epiglottis, and the air goes into the lower airway or enter into the trachea. So that's the normal anatomy. So what happens when the patient is obese, or maybe poisoned, or maybe patient with a trauma, head injury, or other medical problems like Guillain-Barré, myasthenia, or bulbar palsy, whatever, or just with alcohol overdose, whatever. And what happens is these soft tissues collapse and tongue falls back and airway tend to close. It can be a partial closure or it can be a complete closure. See? So if it is a partial closure, you might hear some kind of a gurgling voices, or maybe snoring, or a little bit of a abnormal breath sounds, but air is passing down but little. If it is completely closed because of this airway closure, the patient will go into kind of hypoxia and respiratory arrest. So it is really important to get the patient's anatomy back to this level when there's a partial closure or complete closure. This happens in various conditions, surgical or medical. Surgical may be head injury, facial trauma, swelling, anaphylaxis, or either it can be medical conditions like neurological conditions and other conditions, right? Therefore, how to get this anatomy back to normal is really important. That is what you need to do at the ETU on admission. So there are 3 basic manuals. We used to call them triple manual, right? So one thing is head tilt and chin lift. The third one is the jaw thrust, right? Head tilt and chin lift I'll play you a video and see how we're going to do these triple maneuvers to open up the airway. Right? Head tilt, chin lift, and jaw thrust. Let's see this video.
Airway maneuvers are simple steps you can take to keep a patient's airway open when they are obstructed.
Roshan, can you hear me, and can you hear the video,
yes.
audio clip of the video? All right.
Yes, can.
Two such maneuvers, the head tilt chin lift and the jaw thrust. The head tilt chin lift is performed by placing one hand on the patient's forehead, tilting their head back, whilst using your other hand to lift the chin up away from the bed. This should bring the soft tissues of the oropharynx forward, reinstating the patient's airway. The second maneuver, a jaw thrust, is performed stood at the head of the bed. Place the thenar eminence of each hand on the corresponding zygomatic arch of the patient's face. From here, place your index and middle finger under the angle of the patient's jaw. Then bring your fingers up towards your thenar eminences, lifting the patient's jaw forward over their top teeth. This will bring the soft tissues of the back of the oropharynx forward, thus reopening the airway.
Yeah, fine. So can you see now when the airway is closed with the tongue, you need to do this triple maneuver, little bit of a head tilt with your one hand, and you can do a little bit of a chin lift with your other hand, right? With two fingers placing underneath the chin. And then you can open up a bit, as well as if it is not helpful really, you can do the third maneuver, that is jaw thrust, placing two hands on either side of the face and two fingers underneath the angle of the mandible, and you pull it up. So it will open up the airway. So you can see this collapsed airway or compromised airway is now back to normal with these three maneuvers. So this is very vital. If a patient comes with struggling and breathing difficulty with obstructed snoring or some other obstructed abnormal breathing noises, do this triple maneuver and always make sure there are no head injury, no cervical spine instability before doing head tilt and chin lift. Otherwise, if you suspect any head injury after trauma, always you can do jaw thrust without mobilizing the cervical spine. That is one important thing I need to highlight here. Right, and then this is the other assessment when if you find a patient collapse, especially outside the hospital and maybe in a medical ward round, yeah, you need to do these three steps: look, listen, feel, where you do triple maneuver still, head tilt and chin lift, and you look at the patient's chest to see whether you can see breath movements. I mean, chest moves with the breathing, and while you can hear whether you can listen to at least a minor breath sound, as well as you can feel the breath in your cheeks, the warm expiratory air, right? So this is a normal teaching, but mind you, I need to highlight in COVID era, we are not doing this, and if you need to have protective wearing, and we are not doing, if it's a suspected COVID patient, we are not going to do this, but in general teaching, we used to do this look, listen, feel technique to identify whether the patient is breathing adequately. Fine. So, sorry. Let's move on to some supraglottic airway devices. These are used to, you can't keep this triple maneuver for long. I mean, you can't hold the patient's head for entire day, isn't it? So if it is not resolving and if it is not going to last longer, then you have to put some devices in order to open up the air. So that is why we use oropharyngeal airways, because oropharyngeal means it goes through the oral cavity to pharynx and open up the airway. That's the main idea of this oropharyngeal airway. You can see there are different sizes, colors, and it can be used from infant to adult, right? And it basically goes and stay in the airway like in this picture. And the other thing, you need to know how to select the proper size. You can see different sizes here. So how to select, you need to keep it at the angle of the mouth, basically at the incisor level. And then this need to go for the angle of the mandible, the other end. So it shouldn't be shorter than that, as well as longer than that. If it is longer, then it can irritate your pharynx and larynx and it can traumatize. If it is shorter, it will not make the airway open and it might just get dislodged into the oral cavity. So ideally, you need to find the proper size. In general, adult males and females, you can go for the green one. Neonates, the white or the pink one. But if it is a big adult, you can select the proper size. So let's see how we're gonna insert an oropharyngeal airway in proper way and just watch this video.
Practice is to insert the OK upside down, let it run along the hard palate, and as soon as you feel the soft palate, rotate it 180 degrees and continue to advance it to the flat sits at the patient's lips. And of course, for this, you'd have your gloves on.
Yeah, let's watch again. So you're gonna put it completely the other way around. I mean, the opposite way where it goes and soothes. And then when you touch the soft palate, only you're gonna turn it to 180 degrees. Just observe the way that he is putting the air.
Insert the OK upside down. Let it run along the hard palate. And as soon as you feel the soft palate, rotate it 180 degrees and continue to advance it to the flat sits at the patient's lip.
Yeah, that's how we are going to put it. So because of the anatomy of the mouth as well as the tongue, you need to start putting it other way around and then turn it 180 degrees when you reach the soft palate. So that is a basic skill that all of you need to practice when handling a compromised airway. Right, and then there are different other supraglottic airway devices called NPA or nasopharyngeal airway. Again, the same technique applies, but it goes through the nostrils to the pharynx. And how to select the proper sizing is, again, you have to keep it at the tip of the nose and up to the level of the tragus. So that is how we're going to size it, and we just need to place it with good lubricant. Nasopharyngeal airways are well tolerated than upper oropharyngeal airways, especially post-operative patients, maybe neuro patients, because it is easier to tolerate something in nose than something in mouth, right? And something like an NG tube. So it is very easily tolerated, and you can keep it with without many problem for post-operative patients and neuro patients. And you just, patient can talk, eat, and sometimes they can breathe and they can have some little sips of water even with the presence of this, and you can just place some oxygen mask over this to give oxygen. So it is very convenient than oropharyngeal airway when it comes to nasopharyngeal airway. Okay, so then this is the other life-saving technique that you all need to practice, and you may be already aware about this ambu bag and the anesthetic face mask. Again, these face masks have different sizes starting from infant to adult. And we need to know how to do bag mask ventilation. One thing before that, we need to identify, we need to have the skill to select the proper size of the face mask. How to select the proper size? Again, this triangular shape is basically towards the nasal bridge, right? And then when you keep the face mask over a patient's face, it should cover both nostrils and the face, mouth, but it should have no pressure on the eyes and it should not go beyond the chin. So those are the three things that you need to see. Again, you should cover both nostrils and the oral cavity, no pressure on eyes, and it should not go beyond the chin. So those are the three things you need to pay attention. So depending on the patient's size, facial appearance, and the size, you need to select the proper size. Otherwise, you won't be able to have a good seal. So our main idea is to have a good seal. And let's see how to hold the face mask and do back mask ventilation using this ambu bag.
Grasp the face mask using the palm, thumb, and index finger to form a C over the face mask. Place the face mask over the patient's nose and mouth. Utilize the remaining fingers under the patient's jaw to form an E and anchor the hand to the face.
Yeah, so this is called C and E technique. C, the letter C and the letter E technique. So can you see this thumb and index finger forms a letter C and letter E? This is to apply a bit of firm pressure over the face to keep a good seal. And these three fingers stabilize the face mask, as well as you can do a little bit of jaw thrust, head tilt, and chin lift with this other fingers. You can just see how he does that while placing the face mask. He does a little bit of a jaw thrust, chin lift, and head tilt. Just observe what happened to the head when he applies.
Patient's nose and mouth. Utilize the remaining fingers under the patient's jaw to form an E and anchor the hand to the face. Squeeze the bag with the other hand, delivering enough air to produce visible chest rise in the patient. Release the bag and allow it to refill with air. Squeeze again and repeat as necessary at an appropriate rate determined by AHA standards or local protocol. If at any time chest rise does not occur when the bag is squeezed, reassess the equipment, technique, and patient. In some instances, the rescuer failed to maintain an adequate seal between the face mask and the patient's face. In other instances, the patient's airway may be occluded given a foreign body or improper positioning. When available, a second rescuer.
Yeah, so sometimes you find it difficult to do bag mask ventilation with a patient with beard, maybe no teeth at all, elderly patients, we used to call edentulous patients, or with obese patients. Sometimes it's be difficult to hold the mask with one hand and do the bag mask ventilation by the other hand. In that case, don't waste your time. Ask your colleague to do the ambuing or the compression of the bag, and you can do C and E technique using both hands. So it will basically, the other hand also C and E technique. So it gives you a firm grip, as well as you can do a little bit of good geo thrust and chin lift and head tilt with both hands rather than doing it with one hand. So this is called four-hand technique. One person to do the holding the airway and jaw thrust and the triple maneuver, and the other person to do bag mask ventilation.
Could be utilized to assist in bag valve mask ventilations. The second rescuer can utilize the EC technique with two hands to ensure a face mask seal over the patient's face, while the primary rescuer can use two hands to squeeze the bag.
Right. Okay, so let's move on. And then there's another supraglottic airway device called LMA, or laryngeal mask airway. Whenever you are in a theater, please go to your anesthetist and just tell them to show you LMAs, and you might get a chance to insert LMA as well, because again, this is a life-threatening, life-saving skill. If you can place a laryngeal mask airway, especially in a cardiac arrest patient. You don't need to intubate patient in a cardiac arrest, but you can save the patient if you can place LMA and just ventilate with the ambu bag. So leisurely, when the anesthetists or experts are there, you can intubate, but at your level, if you can put a LMA and ventilate a patient, it's definitely going to save patients' lives. And there are different types of LMAs. You might see them when you're in a theater, right? But everything works in the same principle. It goes and plays in the larynx, and it gives a good access to provide oxygen directly to the glottic opening. So this opening goes and stays in the laryngeal inlet. Fine. So, and there are some other advanced airway device called the next generation of the LMA is called iGel. It is made with a kind of a thermoplastic material. It goes and melts, it gets a little bit melted, sponge, gel-like appearance, and it plays nicely. And there's no, you don't have to inflate with a cuff like this LMAs, right? So they are usually inflated with air to, keep a good seal. But when it comes to iGel, they are usually gel type of a material. It goes and nicely seals, so it's easier to place it and easy to handle. You might see some iGels as well. Now this is becoming more and more common, and in other countries, ambulance crew and paramedical staff used to place iGels if the patient's breathing is compromising the field itself. So they can jolly well bring the patient to hospital while ventilating either with the LMA or iGel. So it is very, very important if you can go to theater and learn how to place a LMA or a iGel in a compromised patient that's gonna save many lives. Fine. So then let's see how we are going to insert LMA in a video. It will give you a good understanding about the LMA placement.
Under direct vision, hold the tube between fingers and thumb and insert the mask into the mouth whilst pushing the lower jaw downwards.
Yeah. Here also, can you see that this anesthetist is doing a nice jaw thrust, chin lift and head tilt before placing the airway. Just pay attention how they do chin lift and head tilt at the beginning.
Under direct vision, hold the tube between fingers and thumb and insert the mask into the mouth whilst pushing the lower jaw downwards. Advance the mask into the oropharynx with a slight twisting motion to negotiate the tongue and tonsils. The tube tip of the partially inflated cuff is positioned behind the incisor teeth. Insert the tube at an angle towards that of the ear. A slight lateral rotation of the tube between 30 and 45 degrees allows the mask to slide over the tongue and prevent the tongue from entering the atrium of the mask. The angle of insertion is maintained as the tube approaches the posterior wall of the pharynx. At this point, the tube naturally rotates to lay flat against the base of the tongue and presenting the blue line in the midline position. From this point, the tube is continued to be pushed in the same direction as it is generally maneuvered into the hypopharynx. Resistance will be felt as the tip of the mask rests on the upper margins of the esophagus. When the tube is inserted fully into the hypopharyngeal region and the tip of the cuff rests on the upper esophageal margins, this causes air to be displaced within the cuff and assists in creating a seal.
Yeah, so that is very easy. Again, just the initial
Under direct vision, hold the tube between fingers and thumb and insert the mask into the mouth whilst pushing the lower jaw downwards. Advance the mask into the oropharynx with a slight twisting motion to negotiate the tongue and tonsils.
Yeah, it's very easy. It takes only 5 seconds to insert LMA. It's not difficult like intubation, and the learning curve is also very shorter. You can learn it pretty well, and that is a life-saving measure. So please go to theater whenever possible. If you are doing surgical appointment, I think first talk to your anesthetist, and when they are anesthetizing a patient, ask them to give you the chance to put a LMA. And if you do it for say about 3-4 times, definitely you should be able to place it without much difficulty. And in your ward, if there's a cardiac arrest, don't try to intubate in the middle of the cardiopulmonary resuscitation. It's difficult, and you can jolly well place LMA and do back mask ventilation until the patient recovers, and then you can decide whether to intubate or not. Right? Fine. So these are some advantages and disadvantages. I can share these slides. You can read them. Right. Then when it comes to endotracheal intubation, this is the main, challenging thing as well. As still, it is the gold standard to protect the airway and to ventilate. So this can be done in elective setting in a theater or emergency setting in a ward or ETU when the patient comes with a compromised airway, head injury, aspiration or reduced level of consciousness. There are a lot of indications to intubate patients. And we'll discuss some more important points about the intubation. I'm not going to teach you how to intubate, but it is beyond the scope of this lecture. But certain points I need to highlight, I'll talk through with my slides. And these are the laryngoscope blade, and this is a conventional laryngoscope. It has a handle and a blade, and you have to, again, the blade size need to be selected according to the patient's size, right? And this is called direct laryngoscopy because we do laryngoscopy and we see the vocal cords directly and put the tube. So that is why it's called direct laryngoscopy. And so once this intubation is done, you need to be very, you need to have a good understanding about the endotracheal tube itself. It looks a bit complicated, but everything is rational and everything has a reason. Right? So this is distal area or distal end where this end goes to the patient's trachea, and there's a bulb, and you see this bulb is inflatable with this pilot balloon, Usually you can inject about, say, 3 to 5 ml of normal saline, or just basically air with a syringe, and then it get inflated, and it will keep a good seal around the trachea. And when you intubate these patients, vocal cord should be at this level. So that is why there's a black line. When we intubate, we need to stop pushing the tube down when this mark goes into the vocal cord, right? Then this is the proximal part. Once the tube is in the correct position, then the lip should be, the level at the lip is called lip level. In this picture, you can see when the tube is in the correct position, the length of the tube which rests at the lip level is very important, because when the patient is mobilized, to say when the patient is taken from bed to trolley, or theater to another place, to IC, or if you are taking the patient from ambulance to a trolley, this tube might go in further. If the lip level is 22, if it has moved in, the lip level may be 24, 26, right? In that case, it means the tube might have gone into endobronchial, where only one lung will be ventilated. Or else it can come out in some other instances, where the tube might get dislocated. So in that case, it is really important for you to mark the lip level, right? And you need to see at the beginning of every shift, especially, the lip level should be the same as intubated time, okay? And yeah, so these are the things that I need to highlight when you are handling with an intubated patient. Right, positioning for intubation, I think this you need to get, I mean, this will be taught when you are going for practical intubation, intubation practices, so hands-on practicing. The basic idea is you need to place a pillow underneath and make a little bit extension at the neck level, flexion at the neck level, and extension at the head level. So this is the ideal position for intubation. And if it's a very obese patient, we used to have a ramp like this, right? And the whole idea is to get the tragus level, or ear level at the same position of the sternal angle. So then it is easy to intubate. You can see again, extended head and flexed neck. So that's the easiest and most convenient position to intubate. Fine. So then it is a very common question: what are the drugs that we need to prepare when we are intubating a patient? Sorry. So when we intubate, we need certain drugs to sedate the patient. One thing, we need to sedate the patient because we can't intubate an awake patient, right? So we need to make them sleep. And the other thing is, we need to have a little bit of relaxation of the muscles. Otherwise, the jaw muscles and everything, if they are having a normal tone, you can't intubate. The other thing, again, if they are a muscle tone, vocal cords tend to close because, again, they are a muscle. And also these neck muscles and all that can go into spasm, where the patient can develop laryngospasm. Therefore, we need to have intubating drugs that to make the patient sleep as well as to relax. So therefore, we use drugs like propofol, 2 to 4 milligram per kg, and in out of theater or out of ICU, in a ward setting or ETU setting outside the hospital, the best drug would be midazolam. So you can give about 0.1 milligram per kg. Say in adult patient, you can give about say 3 to 5 milligram of midazolam to make a patient well sedated. Otherwise, in a theater setting, we can use ketamine, 2 milligram per kg, propofol, and fentanyl even. But if it is very difficult for you to remember, only remember midazolam, 3 to 5 milligram in adult, or 0.1 milligram per kg dose would be enough to sedate a patient adequately for intubation. And then we need to paralyze the patient or make the patient's muscle relax. So therefore, we use succinylcholine. That is the depolarizing muscle relaxant agent. So you can use 2 milligram per kg dose. That's all you need to remember at that level. And again, there are many things can happen during intubation. The patient can develop bradycardia, hypotension, other arrhythmias. So you have to have your emergency drugs ready. So always have adrenaline 1 in 10,000, atropine 0.1 milligram per kg, that is 1 vial diluted into 6 ml, and ephedrine, and always have flushers, especially hemodynamically unstable patients. Whenever you give a drug, you need to flush it with at least 10 to 20 ml of normal saline. Otherwise, it will not reach the systemic circulation because the circulation is very sluggish in these patients. So in cardiac arrest, as well as in very, very compromised patients, if you are giving any drug, always give a flush with normal saline about 10 ml. Fine. And then one word about using some adjuvants or the assisting devices for intubation. You might see something called this intubating stylus. Yeah, I mean, this is not an ideal thing because if it goes beyond the tube, so it might traumatize your trachea. So don't use this. Instead, you can use something called gum elastic bougie. This is a kind of plastic or some rubber material. It will not disturb or it will not traumatize your trachea. So always use, rather than using a stylet or metal device, you always use a bougie. Right. Fine. And then one word about how to confirm correct intubation. This is called capnography or carbon dioxide measuring technique. And you have a device called this capnometer. It can be a kind of a analog one or a digital one. And anyway, ultimately what happens is it takes a sample from the expiratory gases and analyzes the carbon dioxide. So if the patient's tube is in trachea only, it brings out the carbon dioxide. If it is in the stomach, it might bring a little bit of carbon dioxide, but it will disappear. So therefore, always use capnography for patients intubated. And this is the capno tracing in a normal monitor. It gives a waveform as well as a number. And this is the saturation, and this is the heart rate and the ECG, right? So below you can see the capno or the carbon dioxide reading. So this is very important. Any intubated patient during theater, ETU, ICU, or during transit, always make sure that the capno is connected. Because capno is not coming, that means definitely there is a problem, right? Saturation might be there for some time, but it starts to drop little later, and heart rate and everything will start to drop, or have tachycardia or bradycardia a little later. But capno, if there's no breathing or no connection, then and there capno disappears. So it is really important as a real-time monitoring of corrective placement. Always have the capno ready on your patient. Fine, and this is a little bit of front of neck access. I think at your level it is not really important, but if you can't intubate, that is one way that we used to put a tube emergency with a kind of a cut through the trachea over the cricothyroid membrane. But we might be able to show you when you come to theaters or hands-on training sessions how to do the emergency front of neck access when you can't put a tube from the top, right? And there are other things called tracheostomy. Again, you might get patients with tracheostomy, electively done, or emergency tracheostomy. And you might see in your wards with tracheostomy patients. But again, tracheostomy have advantages and disadvantages. You can read them. I will share the slides. I'm not going to talk each and every. But whenever you have an intubated patient in a theater, ETU or ICU, or whenever you are taking a patient, you might have to transfer the patient who are intubated to tertiary care centers. If you are working in a periphery, you might have to take patients to Kandy, NHSL, or wherever, or ICUs. And anyway, if the patient is intubated, always remember these red flag signs. right? That if there are these red flag signs or symptoms, you have to act promptly rather than waiting, or otherwise call for help at your earliest. Those red flag signs are if the capno waveform disappears or absence of capno waveform, definitely there should be a problem. And chest wall movement, when the patient is being ambu-ventilated or on a ventilator, but still you can't see chest movements, then there should be a problem. And increased airway pressure means when you are ambuing or delivering a tidal volume, if the pressure goes very high, there should be a reason of blockage or kinking of the tube, or it might have gone further in, causing endobronchial intubation. So then you need to act promptly. And reducing tidal volume, if you can't put a suction catheter through an endotracheal tube, obvious air leaks and all these things, and presence of surgical emphysema around the neck and the upper chest, all these things are called red flag signs. Red flag means it's always warning signs. If you have any of these, you need to sort it out then and there. If you can't figure out, if you can't reason it out, always call for help, because next minute patient might go into cardiac arrest or hypoxia-induced respiratory arrest. Always do not wait and do not assume that it will resolve spontaneously. It never happens. It never happens. Airway-related things do not get resolved spontaneously unless you do something on it. Otherwise, the next minute you will lose the patient. Okay. Right. So I have come to an end of my lectures. I had to rush through because of the initial bit of a delay. Any questions regarding airway-related management, or any videos that you want to see again, or anything that if you can just write it down in the chat box, I can show you and I can discuss, or I can play back the video clips or discuss a little bit more about certain clips. Roshan, are you still there?
Yes, sir. Yeah.
It seems they don't have any questions.
Yes. We'll have a lunch break, I guess.
So is it lunch break or tea break after this?
I think we're gonna go for lunch break, I think. Yeah.
Okay. Yeah, okay. Then thank you very much. And if you have any questions, just we should be able to share the slide. Okay. If we suspect cervical spine injury, do we still do triple? No, right? That's why I mentioned any trauma patient, right? Always they should be on a cervical collar until we exclude the cervical spine injury. And if you have a trauma patient fallen from height, even drowning without knowing the reasons, or any trauma patient, any RTA patient, even though if it is not obvious, you have to suspect them having cervical spine injury unless proven otherwise, clinically or with imaging. Therefore, keep the cervical collar intact, and then you can do a little bit of jaw thrust, but no head tilt or chin lift in cervical injury patients, patients with suspected cervical injury. How to mark lip level? Okay, yeah. So as I said, let's see. Lip level is, tube is marked, right? See, tube is marked from, say, about 18 to 28. So whenever you place the tube, your lip level will be that the same level. It is marked in the tube anyway. So you just need to have it documented on your BHT or your writings, right? And you are handing over. You have to tell what is the tube size and what is the lip level. And it is marked always there. And whenever you are starting the shift or whatever, just need to check whether the lip level is the same. So that is how you just need to see it is already mentioned in the tube, but you need to document it in your clinical notes. Yeah, any other questions? Yeah, fine. So in the absence of any other questions, I'm going to wind up and yeah, we can break up for the lunch break and then the next lecture will be started maybe in half an hour. Right. Okay. Thank you very much. Thanks. Thank you.
Thank you, Dr. Anand. So we'll break for lunch. So we have a very short lunch break. We'll start at 2:10. Right.
Okay. Thank you, Roshan. Thank you very much. Thanks.
Intern බලන්න.
Welcome back after lunch. We'll start the next session on ABGN basic interpretation by Dr. Arshika Handike, consultant anesthetist at Provincial General Hospital, Padul. Over to you, madam.
Okay, thank you, Roshan. I hope everybody can hear me.
Yeah, can hear you.
Right. Good afternoon to you all. So, in the next half an hour or so, we'll be talking about blood gases and their basic interpretation. So, a short layout of my lecture today is to tell you how to prepare and to perform an arterial blood gas and their basic interpretation. Here I'm mainly focusing on the metabolic derangement and the gas exchange. So you all know blood gases measure how much oxygen and carbon dioxide is in our blood. It also determines the acidity, the pH in blood. So what are the indications? When would you do arterial or venous blood gases? So most of the time in intensive care units, there are patients who are on either non-invasive or invasive ventilation with respiratory failure. So in those types of patients, you need to do frequent blood gases to know whether they are improving. And any other severe illnesses that might cause severe metabolic acidosis, any other organ failure such as heart failure, liver failure, renal failure, septic shock, and diabetic ketoacidosis. In those types of patients also you need to do serial blood gases to get an idea about the trends or the progression of the disease. You have to do serial blood gases. And in any other condition that I have not mentioned here, to assess the response to treatment. For instance, in patients with septic shock, you might initially treat them with fluids, and then you might want to look at the base deficit and the lactate levels in those patients. So to assess the response to treatment, to know the trends or what your therapeutic intervention has done to the patient, you have to have a series of blood gases. So how are you going to prepare to perform a blood gas analysis? Obviously, you will need a blood gas analyzer, and then you will need a 1 ml syringe, which should be heparinized. So how much heparin should you use? It is the bare minimum amount of heparin that is required to coat the inner surface of the syringe. Not too much, not too less. Because the sole intention of using heparin in our 1 ml syringe is to prevent blood getting clotted, so that there will be errors in the blood gas machine. So you have to take the bare minimum volume of heparin that you need to coat the inner surface of the syringe. And then you will need alcohol wipes and gauze to clean the area. And you will need some local anesthetic. But to be frank, we normally don't, we just perform the blood gas. We normally don't give local anesthetic to each and every patient. We very rarely give local anesthetic before we do a blood gas analysis. And your personal protective equipment, your gloves and the apron. So before you touch the patient, you have to introduce yourself, confirm the patient details, and check whether there are any contraindications for arterial puncture, such as whether the patient has any arteriovenous fistula in the site that you are going to puncture the artery, peripheral vascular disease, any signs of sepsis, or any signs of impaired coagulation. Like what is the platelet count? Is it very low? Or what is the INR of the patient? If it is very high, you can't perform arterial punctures. So once you have explained the procedure to the patient and obtained the consent, you can go ahead with your procedure. The normal sites, the common sites that we use for blood gas analysis are the radial artery, brachial artery, femoral artery, and sometimes we take arterial samples from the dorsalis pedis artery as well. But for beginners like you all, I will suggest to use the radial artery. So when you use the radial artery, always try to use the patient's non-dominant arm's radial artery. So you have to position the patient's non-dominant arm, preferably on a pillow for comfort, and then you have to keep the wrist extended. So you can keep a normal saline bottle or a small bottle, a metronidazole bottle under the wrist to keep it extended. So with your non-dominant hands, index finger, you have to palpate the radial artery. And before doing that, you have to clean the site with alcohol. So with your non-dominant hands, index finger, about 1 centimeter proximal to the planned puncture site, you have to feel for the radial pulse where you feel it best. And with your prepared syringe, which was heparinized before, you have to take the sample, and before inserting the needle, warn the patient so that the patient will cooperate without moving. So you have to insert the needle through the skin at an angle of 45 degrees over the point of maximal radial artery pulsation, and then advance the needle into the artery until you see a flashback of blood in the hub. So once you are in the correct place, you will see the syringe will self-fill in a pulsatile manner if it is an arterial sample. Right, so how much blood should you withdraw? Somewhere between 0.5 to 1 ml is enough, because most of the blood gas analyzers will utilize about 0.3 to 0.5 ml of blood for the analysis. So make sure you take at least 0.5 ml, otherwise you will have to repeat the procedure because it's quite invasive. So once you have collected the required amount of blood, you can withdraw the needle and apply immediate firm pressure for a few minutes over the puncture site. Press the puncture site and hang the patient. So once you have removed the needle, in the Sri Lankan setup, what we do is we puncture the needle, we pierce the needle with a rubber cap, and then we put it in an ice bath and send for analysis. So most of the time, the blood gas analyzers, in the ward setups, we don't have any blood gas analyzers. It's mainly situated either in the intensive care units or the ETUs.
So you have to send it with a properly named label. So what information should be there on the label? So obviously there should be patient identification details, including the name and the bedhead ticket number. And if the patient was on oxygen, you have to write the FiO2 or the fraction of inspired oxygen concentration. So if the patient was on room air, you can write FiO2 of 0.21 and the patient's body temperature. If the patient was febrile, you have to mention the patient's body temperature. So once you have done correctly done the label and sent the sample for analysis, you can dispose your gloves and equipment into the bag, and don't forget to wash your hands afterwards. So in terms of analysis, the sample should be analyzed as soon as possible, ideally in less than 10 minutes. So if the analysis is getting delayed for more than 10 minutes, you have to cover the sample. You have to keep the sample in an ice bath kept at 4 degrees of centigrade. So the reason behind this is because, the blood sample contains red cells, platelets, and white cells, which will consume the oxygen, and it will produce carbon dioxide, and it will consume the nutrients, especially the glucose level in the blood. So the final result you will get will be erroneous if you don't analyze the sample as soon as possible, or if you don't keep it in an ice bath if it is getting delayed. So what I explained was how to puncture the artery to take an arterial blood sample. But if you work in an intensive care unit, most of the patients always have arterial lines in situ. So those are things like cannula inserted into an artery to monitor the arterial blood pressure or for frequent blood gas analysis. So if your patient has an arterial line in situ, you don't have to do a second puncture on another artery. You can take the blood sample from the arterial line itself. So just keep that in mind, so you don't have to do a repeat puncture on another site in another artery. You can take the blood sample from the arterial line itself, but afterwards you have to flush it. So if you're working in an intensive care unit, learn the technique of how to collect a blood sample from an arterial line. Just remember that you don't have to do a repeat puncture. Right, we'll move on to acid-base balance. So remember here, I'm telling you the simple basic steps of interpreting acid-base balance from a blood gas report. So we all know our body pH is maintained within narrow limits. So the normal body pH is maintained within 7.35 to 7.45. So if the pH is more than 7.45, you call it alkalemia or high blood pH. And if the pH is less than 7.35, you call it acidemia. So these acid-base shifts are largely controlled by three main buffers, which helps to maintain homeostasis in the blood and the extracellular fluid. So the main buffer systems in the body include the proteins, hemoglobin, carbonic acid, and the bicarbonate system. So when you look at a blood gas report, these are the 5 key components that you need to look at. Number 1, the pH and the partial pressure of oxygen and carbon dioxide, the bicarbonate level, base excess or the base deficit. So what information can you gather from those key components? So pH, you know from your advanced level chemistry, pH is the negative logarithm of the hydrogen ion concentration in the body. So it obviously tells you about the hydrogen ion concentration in blood. So the lower the pH, higher the hydrogen ion concentration be, and vice versa. And PaO2 is the partial pressure of oxygen dissolved in arterial blood. CO2 is the partial pressure of carbon dioxide dissolved in arterial blood. The saturation is the percentage of oxygen bound to hemoglobin. Bicarbonate is the concentration of bicarbonate in blood, which is mainly regulated by the kidneys. So a little bit about base excess. So a normal value for the base excess is from +2 to -2. Why is it called base excess? Because it is, listen carefully, so base excess or the base deficit is the amount of base that would have to be added or removed from a blood sample with an abnormal pH to restore to a normal pH of 7.4. Let's say there's a blood sample with a pH of 7.2. So it has a base deficit. So we have to add some base to restore its pH to 7.4. That is why it is called base deficit or base excess. If it is an alkaline sample, it would be a base excess. Then you have to remove some base to restore the pH to 7.4. Right. So these are the desired range of values for the components in a blood gas report. So it's always better if you can remember these normal values. So pH, it's you have to know the normal ranges, 7.35 to 4.5. It's not difficult to remember. And the partial pressure of carbon dioxide should be, if it is in millimeters of mercury, which is the commonest unit that we use here, so it should be between 35 to 45. PaO2 should be 80 to 100 in patients breathing room air. If the patient is on supplementary oxygen, this value can be higher. Bicarbonate level concentration would be 22 to 26 millimoles per liter. Base excess, as I told earlier also, +2 to -2. Lactate level is 0.8 to 1.5 is the normal range, and the normal electrolyte ranges: sodium, potassium, magnesium, calcium, and the blood glucose. Right, so we'll move on to stepwise approach to basic blood gas analysis. There are a few steps which are very simple. So number one is to look at the pH so that you can determine whether it's acidosis or alkalosis. So number one, remember, look at the pH. Number two, look at the PCO2 and the bicarbonate level so that you can identify the primary disorder and identify whether there's any compensatory response by the other component. Okay, number one, look at the pH. Number two, look at the PCO2 and the bicarbonate level. So let's talk about looking at the pH. So I'm repeating this. So if the pH is less than 7.35, it's an acidemia. If the pH is more than 7.45, it's an alkalemia. So sometimes the pH may be normal in the presence of a mixed acid-base disorder, particularly if other parameters of the blood gases are abnormal. So the first step was to look at the pH. The second step is to look at the PCO2 and the bicarbonate level. So in simple acid-base disorders, both values, both PCO2 and the bicarbonate will be abnormal, and the direction of the abnormal change is the same for both parameters. So if you don't understand this sentence, just don't worry. With the next few slides, you will understand what this really means. So one abnormal value will be the initial change, and the second abnormal value will be the compensatory response. So you have to distinguish the initial change from the compensatory response. What is the initial change and what is the compensatory response? So how are you going to do that? So the initial change will be the abnormal value that correlates with the abnormal pH. For instance, now from the pH, you get to know that this is an alkalosis. So if it is an alkalosis, your PCO2 should be low or your bicarbonate should be high. Similarly, if it is an acidosis, your PCO2 should be high or bicarbonate should be low. So once you have identified the initial change, then automatically the other abnormal parameter will be the compensated response. If the direction of the change is the same, you will understand that sentence in my next slide. So if not, suspect a mixed disorder. So once you have identified the initial chemical change and the compensated response, you can identify the specific disorder. So if your initial chemical change was in the carbon dioxide partial pressure, then you label it as a respiratory process. In contrast, if your initial chemical change was in the bicarbonate concentration, then the process is metabolic. Right. Now we are talking about, now try to understand this, respiratory acidosis. Okay, so acidosis. So if it is an acidosis, your carbon dioxide should be high or your bicarbonate should be low. But if it is a respiratory one, the initial change should be in the carbon dioxide level. So the carbon dioxide will be high. To compensate for that, bicarbonate will be high. This is why the direction of the change is the same. So carbon dioxide and bicarbonate both are in the higher range. Likewise, in a respiratory alkalosis, in an alkalosis, what should happen? Because it's a respiratory alkalosis, the initial chemical change is carbon dioxide, so the carbon dioxide will be low. To compensate for that, your bicarbonate will be low as well. In a metabolic acidosis, the initial change would be in your bicarbonate level, which is low bicarbonate, and to compensate for that, your CO2 will be also low. In metabolic alkalosis, your bicarbonate will be high because it's metabolic. We are talking about the bicarbonate level, and the carbon dioxide will go up to compensate for that. Let's look at few examples so that you will understand it better. So I'm talking about respiratory acidosis. So in what can respiratory acidosis occur? Especially in hypoventilation due to drugs like opioids, where there is depression of the respiratory center, and in situations where there is respiratory failure, when the patient breathes at a lower rate, so that there will be accumulation of carbon dioxide. So what happens when there's accumulation of carbon dioxide? It will get converted to carbonic acid, which will produce more hydrogen ions, causing a respiratory. So similarly, respiratory alkalosis happens when a patient hyperventilates, when the patient breathes at a faster rate, washing out all the carbon dioxide. So the conditions that can cause respiratory alkalosis include anxiety and emotional disturbance, especially young females tend to have this. And in patients with assisted ventilation, sometimes if we overventilate, the patient might go into a respiratory alkalosis. So we'll look at a few examples. So this one, a 21-year-old woman presents feeling acutely lightheaded and short of breath. She has a final university exams next week. And this is a blood gas report. The pH is 7.48. So remember your steps in analyzing a blood gas report. Look at the pH, 7.48. So it's more than 7.45. So it's an alkalosis. Then look at your bicarbonate and the free CO2. So if it is an alkalosis, you would expect your bicarbonate to be higher or your carbon dioxide to be lower. So your bicarbonate is 22, which is in the lower normal range, but your CO2 is 27, which is less than the range 35 to 45. So your initial chemical change is carbon dioxide. So this is a respiratory alkalosis. So the instances where metabolic acidosis can happen is accumulation of acid, such as lactic acidosis, accumulation of tissue metabolites, and in diabetic ketoacidosis, in renal failure, and also due to loss of bicarbonate from the body, such as in renal tubular acidosis. Another example, a normally fit and well 11-year-old boy presents with diarrhea and vomiting. He is complaining of non-specific abdominal pain. This is a venous blood gas. So remember your steps. Step number 1, look at the pH. So pH is 7.12. Your normal range is 7.35 to 4.5. So this is very low from 7.35. So this is acidosis. And then look at your PCO2 and the bicarbonate. If it is an acidosis, either your carbon dioxide should be high or bicarbonate should be low. Here, the bicarbonate is 9, which is lower than the normal range of 22 to 26. And your carbon dioxide is also low. But out of the two, bicarbonate has a significant reduction. So this is mainly a metabolic acidosis with some compensation with the carbon dioxide. So we label it as a metabolic acidosis with respiratory compensation. So next example is on metabolic acidosis. There will be increase in bicarbonate concentration, usually from loss of bicarbonate, poor fluid, such as in vomiting, you lose hydrochloric acid from the gastric juice, nasogastric suction, and some diuretics can cause metabolic acidosis. A 67-year-old man with a history of peptic ulcer disease presents with persistent vomiting. So this is his blood gas report. So step number 1, look at the pH, 7.56. So it is obviously an alkalosis. So if it is an alkalosis, either your bicarbonate should be high or carbon dioxide should be low. So here you can see your bicarbonate is 31, which is higher than the normal range of 22 to 26. The carbon dioxide is within the normal range. So this is primarily a metabolic alkalosis. So that is about the metabolic derangements. So we'll quickly move on to the gas exchange in humans. So I'm not going to take more than 5 minutes. So it's mainly about oxygenation and ventilation. There are a few parameters that you need to concentrate. Number 1 is the partial pressure of oxygen, partial pressure of carbon dioxide, and the PF ratio. So the first two we have been talking about it with the normal values. So when you talk about the partial pressure of oxygen in a patient who is breathing room air with healthy lungs, the normal PO2 would be 80 to 100 millimeters of mercury, and the saturation will be more than 94% on room air. The normal carbon dioxide partial pressure would be 35 to 45 millimeters of mercury. So in intensive care medicine, there are 2 types of respiratory failure where you have to differentiate between. So type 1 respiratory failure is mainly a hypoxic failure, whereas type 2 failure is a ventilatory failure. So how are you going to differentiate between the two? So in type 1 failure, you have to look at your PCO2 and the POO2. So type 1, as I told you before, it's mainly a hypoxic failure. So your PaO2 would be less than 60 millimeters of mercury. But your carbon dioxide tension will be either normal or low. In contrast, type 2 failure, as I told you, is a ventilatory failure. So there will be both hypoxia and hypercarbia. So your PO2 will be less than 60 and PCO2 would be more than 45. So let's quickly move on to two examples to differentiate between type 1 and type 2 respiratory failure. So you're called to see a 54-year-old lady on the ward. She's 3 days post cholecystectomy and has been complaining of shortness of breath. So this is a blood gas report. Now, I want you to differentiate between type 1 and type 2 failures. So let's look at the PO2. It's 57. So it's less than 60. So she is hypoxic. And the PCO2 is 30. So in type 1 failure, I told you the PCO2 will be low or normal. So this is an example of a type 1 respiratory failure. Let's move on to the other one. A 64-year-old gentleman with a history of COPD presents with worsening shortness of breath and increased sputum production. Now, quickly look at the PO2, which is 55, which is less than 60. So he's hypoxic. And the PCO2 is 65. So the normal range I told you is 35 to 45. So this is more than 45. So he has both hypoxia and hypercarbia. So he has a ventilatory failure. So this is type 2 respiratory failure. So I want you to remember how to differentiate between type 1 and type 2 failure. So type 1, remember it's hypoxic failure where your PO2 should be less than 60. And type 2 respiratory failure will be a ventilatory failure where a patient would be both hypoxic and hypercarbic. So the PaO2 will be less than 60 and the PCO2 tension would be more than 45. So finally, I want you to know about this PF ratio. So it denotes the ratio between the partial pressure of oxygen and the FiO2, the fraction of inspired oxygen. So in a normal healthy adult who is breathing room air, the PaO2 would be around close to 100. So 100 divided by the FiO2. He's breathing room air. So the fraction of inspired oxygen would be 21% or 0.21. So his PF ratio would be 100 divided by 0.21, which comes to around 476. So likewise, in intensive care medicine, we classify the severity of acute respiratory distress syndrome according to this PF ratio. So if the PF ratio is 200 to 300, we classify as mild ARDS. And if it is less than 100, it will be a severe ARDS. So that's about gas exchange. Remember the normal values for partial pressure of oxygen, carbon dioxide, and now you know how to calculate your PF ratio, and depending on that, how to classify the severity of acute respiratory distress syndrome. So in summary, blood gas is a bedside test. You need to collect the sample properly and transport it properly with a correct label. So we have discussed the basic acid-base interpretation. Remember the stepwise approach. You have to look at the pH first and then look at your CO2 and the bicarbonate level. And depending on that, you have to decide which one is the initial change and which one is the compensated response. And we have discussed about blood gas criteria for type 1 and type 2 respiratory failure, and the oxygenation indices, saturation, and the PF ratio. So blood gases always deal with numbers, but remember, clinical history and examination is really very important. Blood gases are there only to guide your treatment. So you have to know the clinical history and examine the patient well. Don't just rely only on the blood gases. You have to have your clinical sense first before going into the blood gases. So with that, I will wind up my lecture. Thank you for listening.
Thank you, Madam, on the detailed lecture. So if anyone's having questions, can ask now or can type in the chat box. So next lecture is by Dr. Anushka Senaviratna on transport of critical ill patient. Over to you.
Yeah, thank you, Roshan. So I'll be talking about transport of a critical ill patient. Yeah, why we talk about this is because transfer of a critical ill patient, you need specific skills and you have to follow certain standards and guidelines. This is just in the sole intention of reducing the morbidity and mortality of a critically ill patient. So you all are pre-interns. So I don't know if you have started your intern period, but if you are placed in peripheral setups, you will be the one who will be transporting these critical ill patients from peripheries to specialized units. So you may face with such an instance maybe in your first month of your training period, the intern period. So this will be a rough sketch for you, a guideline for you to remember what to do when you're faced with transfer of a critical illness, that is a bit of an unstable patient. So I will not be able to tell everything within this 30-40 minutes, but just know there are guidelines. The College of Anaesthesiologists and Intensivists, we have a guideline, and it has a very nice appendices where you can use when you are faced with transferring a critical ill patient. So these guidelines protocols have been developed from UK guidelines. So with the sole aim of reducing the morbidity and mortality and allowing you to.
Dr. Anushika, your slides are not moving. Is it moving or?
It's not moving yet.
Ah, okay, right, okay.
Yeah, to allowing you to have a safe transportation of a patient. So goal of critical care transfer is you maintain a high quality patient care. That is, you give a near normal ICU environment while moving the patient from one place to another in an expedient and safe manner. So transfer of these patients could be inter-hospital, that is from one hospital to another, or within one hospital, that is you may be transferring the patient from ICU setup to the radiology department, right? So why we transfer a patient? The most common indication is for the ICU care. So your peripheral setup, you may not have ICU facilities or your ICU beds are full. So these patients are mainly indicated for like escalation of care. Other thing is for specialized care. That is, you don't have a neurosurgical opinion or interventional radiology opinion in your ICU setup in the hospital where you work at. So you may have to take the patient to these specialized centers. The other thing is for investigations, maybe CT brains or any other hi-fi investigations, which will not be offered in your setup. So you may take the patient, hand over and come back, or you go bring the patient, you come back with the patient. So why we talk about this transferring of a critical ill patient is because they are at increased risk of instability during especially transport. Why? Because of the disease status itself, maybe a cardiogenic shock, myocardial infarction, or because of the medications they are on. The patient may be on multiple inotropes and maybe on other supportive medications. And the other thing is now the critical ill patients are at their best compensatory mechanisms. So even a slightest change in the physiological environment setup, they will go into a sudden decompensation or deterioration. So they tolerate this movement especially very poorly. And the other thing is, if you have to optimize a patient while transporting, you will have a very minimal standards or minimal suboptimal conditions for optimization. So these people are at risk of instability during transport. So just a few physiological changes in transport. If the ambulance is accelerating, that is, if it is going very fast, in the central nervous system, what happens is all your venous return will be pooled in your lower limbs. So if the patient is already hypotensive, they will have a significant hypotension, specifically in hypovolemic patients, and this will prone to arrhythmias. The mean arterial pressure will be low. This will have less cerebral perfusion, and if the patient is having already a traumatic brain injury, they would deteriorate. So deceleration is the opposite. There will be massive input of the venous return to the heart. If the patient is at the verge of heart failure, cardiac failure, he would soon go into decompensation. And of course, the central nervous system, the opposite would take place. There is a massive rise in the ICP, again, further worsening of secondary brain injuries. And of course, gastrointestinal system, there would be risk of aspiration. In both instances, there will be a risk of displacement of unstable cervical and spinal fractures. So a recommendation is to go at a regular speed, at a constant speed, not much acceleration and deceleration. So if you take a transfer process, there are certain steps that you have to follow. That is, you identify the need of a transfer of a patient, and then there has to be agreement between the referring end and the accepting end by the senior clinicians or the consultants. And well, sometimes this patient may already be in the ICU, but same team will not be taking the patient to the receiving end. So there will be a transport team. So there will be handing over of this patient from the ICU team to the transfer team, and then the transfer process takes place. And then you hand over to the receiving end, and then the staff and the equipment come back to the base. So transfer guidelines, I have laid certain guidelines on these 6 aspects. We will talk about these one by one. So as I told you, we have this guideline. There are nice appendices available in the college guideline at the back. So if you can have just a printout, it's freely available online. If you can have just these checklists or just 5 appendices, it will be very helpful for you when you work, when you are to face a transfer of a critically ill patient. So communication, as I have said, there has to be a contact between the receiving and the transferring end. Must be a consultant transfer discussion. This is to prevent any delay or hindering of patient safety and care. You have to make sure that the communication has taken place, because there are a lot of transfers happening where the communication has not taken place, and then you are also at risk. The patient's condition is also at risk, and this will hinder patient safety, and you will face to litigations as well. So make sure communication has taken place. And then, of course, before transferring a patient, you have to stabilize and prepare the patient for the transfer. You can't just take, scoop and transfer a deteriorating patient. You have to make sure certain checklists are fulfilled and the patient is stable enough to transfer. So you have to balance the time between the time taken to achieve this stabilization and the urgency of the transfer. And you do this assessment usually by this ABCDE approach. So if you check the airway, you have to make sure the patient has a patent airway. So if the patient is conscious, talking, that is fine. But if there is a doubt, I mean, if you think the patient is having a compromised airway, if the transferring team says the patient is having a compromised airway, so better to have a low threshold to have a definitive airway, that is to intubate and take the patient, because intubation on the way is a nightmare. So you have to make sure that the patient's airway is stable. So you discuss with your seniors before you transfer. So say for an example, if the GCS is hovering around say 10-9, the indication is to intubate if the GC is less than 8, but you should not transfer the patient if the GC is around 8-9, better to discuss and intubate. And if there are airway traumas, there is an impending threat for the airway, facial injuries, certain type of head injuries, better to discuss and assess the need for intubation before the transfer. And of course, if the patient has some inhalational injuries, you may not see any significant or sinister features at first, but in 2-3 hours, the airway will blow up and then you will not be able to intubate on the way. So on those instances, you have to make sure that you have a definitive airway. And if the patient is having type 1 or type 2 respiratory failure, which was discussed in the previous lecture, you may intubate. So once the patient is intubated, you may use paralysis for intubation. Paralysis is not a must after the first intubation. For maintenance, paralysis is not a must, but sedation and or analgesics is a must. So if you have intubated the patient, please make sure the patient is sedated with appropriate drugs. Say midazolam, fentanyl, morphine. Please make sure the patient is sedated because a lot of people are being transferred and ventilated in the ward setup until a transfer is arranged without giving proper sedation or analgesics. So patient may be paralyzed, but the patient may be feeling what is happening around. He may not be able to move because he's paralyzed, but he will be under a lot of stress, and it is inhuman that you do not sedate this patient. So this has happened several times. So if I want you to take this as the take-home message, please do, because make sure when you do work as HOs, the patient is sedated and analgesics are given if the patient is mechanically ventilated. And once the patient is intubated, you have to make sure this tracheal tube is safe, secured, and note the length and ensure no cuff leaks. And if you have water filters, make sure you attach one between them. So if the patient is breathing spontaneously, if the team is happy to take the patient like that, you continue. But otherwise, the patient could be mechanically ventilated if the patient is not maintaining the accepted oxygenation and carbon dioxide targets. So saturation targets should be more than 94, either ventilated or spontaneous breathing. So if he is maintaining more than 94, you should be happy. And the carbon dioxide, if the patient is ventilated, if it is around 35 to 45 millimeter mercury, you should be happy. That is, if it is more than 4.5 kilopascals, you should be happy. So as I have told, sedation, muscle relaxation is not a must. Sedation is a must. And you can guide your ventilation from the saturation, the peripheral oxygen saturation, and the EtCO2, the capnographic tracing. You may do arterial blood gas just before transfer to make sure everything is all right. So airway checked, breathing checked, and now breathing, if there is a pneumothorax, obviously you have to put an IC tube. So you may clamp these IC tubes when you transport the patient from the bed to trolley. But when you go, you make sure you keep the chest drains down and declamp. Otherwise, there is no point you putting a chest drain. So it has to be one in your checklists. So breathing done, yes. Circulation, the recommendation is to have 2 IV accesses secured. And mind you, this should be the appropriate size because if it is adult, there's no point having 2 pediatric cannulas. At least a green cannula and from upwards from green. So if the cannulation is in doubt, and if the patient just has a pink cannula and obese patient, difficult in cannulation, you discuss with your senior colleagues and better to have a central venous access before the transfer. Otherwise, you will fall into trouble during transfer. So circulation, you have to measure the blood pressure. Could be from this a non-invasive blood pressure, just the cuff, but some people may have an arterial line, especially those who are on inotropes. And of course, circulation, other things, the blood pressure pass rate has to be in the standard recommended values. If there are continuous source of blood loss, you have to identify and control it. Pelvic fractures, femur fractures, those should have pelvic binders and the splints for the femur fractures. Transfusion, you should not transfuse on the way. If the transfusion is indicated, you do the transfusion and take the patient. And if there is a doubt, you can take the blood products with you. And yeah, the values should be stable. The hemoglobin should be stable. And make sure you take off all the unnecessary infusions. Sometimes you have this due electrolyte at particular time. You give it and transfer the patient. Maybe antibiotics, you give it beforehand and transfer the patient, because this is to minimize the lot of drips hanging from here and there, a lot of infusion lines going from here and there. So you make sure these lines are minimal and labeled. You should stop NG feeding during transfer. You can keep it open, free drain, but you shouldn't be feeding during transfer. So ABC checked. Disability D, of course, the blood sugar. And this usually comes under this category for patients transferred with a traumatic brain injury. So most of your transfers could be due to this neurosurgical opinion who comes in road traffic accidents. So you have to make sure the patient has normal oxygen, that is saturation more than 94. Normal carbon dioxide, I would say in head injury patients, we have a different target. You may discuss with your senior colleagues, but it should be around 4 to 4.5 kilopascals. And the patient has to be well sedated, if needed paralyzed. You should prevent frequent bucking, coughing, that will increase the intracranial pressure. And the patient should have, if there are no C-spine injuries as such, should have a 30 degrees head up if it is a head injury. And if the patient, if the seniors decide that he has a very high risk of seizures, depending on the area which is affected in the brain, you may give a anti-epileptic for transfer. And you have to control the normal sugar levels. And of course, you have to cover the patient to have a normal temperature during transfer. And of course, blood pressure targets would differ if it is a head injured patient. You discuss with the consultants on both ends or your senior colleagues what pressure targets, if you're transferring a head injured patient, should you maintain in this patient. And as I said, if there's a C-spine, it has to be stabilized. You all should know how to apply a cervical collar. You have to measure it and then apply it appropriately, and so that you know it is properly there when you transfer the patient. And of course, if the patient has other spine injuries, of course, the patient has to be log-grooved. Right? The patient may be transferred in a spinal board, but mind you, we have seen sometimes transfers coming from other end, which takes about 6-7 hours. Say like if the patient is coming from Jaffna to Colombo, it would take about 6 hours. But in these instances, better not to keep the patient on the spinal board because they have increased risk of this sore backs. So you discuss with the consultants how we are going to transfer, especially in a spinal injury patient. Are you going to bring the patient in your spinal board? Are you going to transfer the patient to the trolley and then strap him and then safely transfer? If it is just 2-3 hour transfer, that should be fine in the spinal board. So sugar, electrolytes, of course, you have to check and make sure they are all right, and the ABG blood gas, and you have to make sure the acid-base balance is all right, because the patient is vulnerable for next maybe 2-3 hours during the transfer. And you will not be able to do much resuscitation on the way. So this is one of the checklists which I have mentioned. This is the pre-transfer checklist 1. So ultimately what it measures is the patient stable for transfer. You check airway, breathing, circulation, disability neurology, and trauma aspect, metabolic aspect, and if the patient is properly attached to the monitoring. So once this is done, you have to make sure your equipment and drugs are ready for transfer. There are a whole lot of set of equipment that you may need to take with the patient, especially a critically ill patient. So this is another appendix. So for airway, breathing, and circulation, you have certain set of things that you should take. So when you go through this one by one just before the transfer, this will make your life easier. So, and I have to tell you that your transport bag has to be tailor-made. You take all the unnecessary stuff outside and take only the necessary stuff. Say for an example, if you're transporting an adult patient, you do not need these small ET tubes, small laryngoscopic blades, and small cannulas, no need. Just you tailor-made the patient's requirement and then make the transfer bag accordingly. So for airway, you need oropharyngeal airways. When you have these surgical appointments, please go to this anesthetic site and then get used to these airway, breathing, and circulatory treatments. Talk to the anesthetist and get to know about these medications, especially sedatives and analgesics, and how you use them. So this will make your life and the patient's life easier and happier. So these are the airway equipments. And this, you must know this self-inflating bag, one of the life-saving devices. And this is a suction apparatus. This is the portable ventilator. So sometimes the patient is intubated. Usually ICU nurse will come with you, but if the patient is going from the ward, there will be very less people who know about this, how to operate this ventilator. So if you have time, please get used to this ventilator as well, because ultimately you will be the one who is transporting this patient. All right, so circulation also, if you go through this checklist, you will find these things. You have to make sure they are there in your bag. Drugs wise, apart from the drugs which is individualized to the patient, you have to take the emergency drugs. Oxygen, of course, you have to bring, and adrenaline. Adrenaline, atropine are emergency drugs. You have to prepare them and take. Don't just take the vials. So adrenaline, you usually prepare 1 in 10,000. 1 vial has 1 milligram. So you dilute it up to 10 ml in a 10 ml syringe, and then it is called 1 in 10,000. You take it. And atropine, 1 vial has 0.6 milligram. You take it into maybe 5 cc syringe or 3 cc syringe. So for adult patient, you usually give all 1 vial, 0.6 milligrams. So if you can dilute, that's fine. If you do not need dilution, just take it as a neat atropine. And you have to make sure you have a distilled water or a normal saline flush in 20 ml, always with these emergency drugs, because once you give the drug, you have to flush it. Apart from that, there will be other supportive drugs such as noradrenaline, vasopressin, dopamine, dobutamine, ephedrine, metronidazole, phenylephrine, which are all vasodilators, vasopressors, and inotropes. And you know this sodium bicarbonate, calcium gluconate, those are also emergency drugs. And make sure those are available. And mannitol, especially in neurosurgical patients, furosemide, amiodarone for arrhythmia management, and esmolol, metoprolol again for arrhythmia management, so hypertension management with GPN, salbutamol for your asthmatic management, and midazolam, propofol are the sedatives, succinylcholine, metocurate are the muscle relaxants, and fentanyl, morphine are the analgesics. So if sux atracurium is being used, this top part or the lower 2 drugs has to be given with the patient as an infusion. Right, so this is what I discussed, resuscitation drugs drawn up. And if the patient is on inotropes, please calculate the volume that will be needed for the patient, and you draw up these inotropes and take, because you can't make it on the way. Please ask the ICU nurses to give you additional inotropes when you're transferring, if the patient is on inotrope, right? And any other drug specifically depending on the patient. Fluids, of course, balanced crystalloids or 0.9 saline you have to carry. Colloids, there is actually no place for any colloids at fluid resuscitation these days. So don't mind if you don't have any colloid, but blood and blood products, if the patient is indicated with that, you may take it. So this is a transport bag, a transfer bag. Usually it is red in color, you say red bag as well. So important thing is that this is compartmentalized. So in your ward setup, try to make a bag like this, which is compartmentalized, so that you know it is when you in an emergency, there is no chaos. So everybody knows what is where and it is labeled. And so that nobody going to panic setup searching which part is in which compartment. And if you don't have these, some people used to have these baby baskets or these animal baskets, where you can have a locally product compartmentalized clothing materials, clothing pockets, and then put them accordingly. And make whatever the method you use, you make sure you're familiarized with this setup. So that your panic level is less finding the necessary equipment in an emergency. So This is the suggested contents for a transfer bag, and as I've told you, this transfer bag has to be tailor-made to the patient. Please throw away all unnecessary stuff and make sure only the tailor-made bag is taken with the patient. So oxygen, we'll talk a bit about oxygen. Whenever you see a cylinder with a black body and a white shoulder, it is an oxygen cylinder. So if it is something else, the color code is different. So always remember oxygen cylinder, black body, and a white shoulder as shown in this. So just know a little bit about oxygen cylinders. You have cylinder types, that is sizes, and you have cylinder valve types, that is at the top end. There are differentiations, and you should know the requirement, what requirement is needed for this transfer of the patient, oxygen requirement. So sizes, you have C to C, D, E, F, G, J. You may have heard of these numbers because of this recent COVID pandemic. J comes for these jumbo cylinders, and C is a smaller one. E is the standard cylinders, which you may have seen in this ward setup. So if you measure the height, it is about 31 inches. And inside its capacity, if you fill it with water, it's about 4.7 liters. And if you fill it with compressed air, that is oxygen cylinder maximum pressure when it is at is 137 kilopascals. And if this is released into the room air, under 1 atm, you will have 680 liters of oxygen in this E cylinder. So jumbo cylinder is 10 times that, you will have 6,800 liters. So that is one. Just get familiarized with types of cylinders you have and the valve types. So oxygen has two valve types. I'm referring to this top end of this oxygen cylinder. One is pin indexed, one is called bullnose valves. So this is pin indexed oxygens. So if you can see the top, you can see it's like a pole, no? It's like a pole, and if you can see here, so it has certain holes. This is the pin index. So for oxygen, you have a specific pin index, and this can be mounted only to the specific yokes in the machine or the ambulance. So some ambulances use this cylinder, and so you have to make sure you have to have an idea about your ambulances as well in the hospital where you work. So you have to make sure that ambulance you take the proper correct oxygen cylinder to the correct ambulance. Otherwise, if you take the other one, you will not be able to use it. So this is the pin indexed oxygen valve type, and the other one, this is the bullnosed valve type. So here is the normal oxygen cylinder which is used in the ward setup. Here you have a handheld wheel where you can open these oxygen cylinders. Otherwise, you need to have a specific key. So with this oxygen cylinder trolley, usually always a key is mounted. You can't open it with anything else. You must have the key. So when you take the patient, you have to make sure, especially when you take the oxygen extra cylinder, you have to make sure you have the key. If it is not this handheld, it doesn't have a handheld cylinder. So you have a pin indexed ones and you have the bullnosed ones. And then on the top, you connect it to a pressure gauge. So as I told you, you have to open it fully and make sure you have to check how much of oxygen is inside. If it is full, it should point at 137. This is 100, this is 150. So in between 125. So somewhere here. So if this arrow should come to somewhere here, because you are taking only full cylinders. Don't take half filled cylinders because it will be unnecessary. It's a waste of cylinders and waste of your time taking these cylinders which are not full, because it will have a less amount of oxygen inside. So you make sure you open it fully, and it is this is indicated at 137, so that you will have 680 liters of oxygen when this is fully used during a transfer. So how much of oxygen you should take for your patient? So recommendation is you should take twice the patient requirement. And some ventilators, they use basal oxygen flow for their function. We will just forget it for the time being. It is a very small amount. So how are you going to calculate the patient requirement? So you have a patient who is mechanically ventilated, who has a tidal volume of 500 mils and a respiratory rate of 10 per minute. And he is on FiO2 1. Previous lecture, I told you about this FiO2. That is, whatever he breathes, he needs 100% oxygen. What we breathe is 20%. So for this patient, you have to give him 100% oxygen. The journey is 120 minutes. And how much of oxygen cylinders are you going to take with this patient? So first we calculate his minute ventilation. That is his tidal volume into respiratory rate. So that would be 5 liters per minute, right? So your journey time, and this is 5 liters per minute, and then he needs all 5 liters in oxygen. If his FiO2, he's breathing only 50% of oxygen, so you multiply 5 liters by 0.5. So it will be 2.5 liters. So for easy calculation, we will take this, he's on 100% and he needs 5 liters of oxygen. So this is per minute, right? And then you need 120 minutes for this patient, 2 hours journey. So 5 liters into 120 minutes is 600 liters for 600, no? Yeah, 600 for 2 hours. So you have to take, recommendation is you take twice the requirement. So you take 1200 liters. So how are you going to take this with your patient? So I told you commonly used one is these E-cylinders. So if you look at this E-cylinder, once it is fully full, 137 pressure indicator, it will have 680 liters. So if you take 2 full cylinders, you are safe. Okay. And if you go to situation 2, suppose you are taking this patient from the ICU to the radiology department and taking the patient back. The journey 10 minutes to go, 10 minutes for the procedure, 10 minutes to come back, so 30 minutes. And the patient is just on a Venturi, 40%, sorry, I would say, yeah, 40% Venturi. And the Venturis, you will not be familiar with sometimes. So when you say 40%, usually the color coding is red, and that is the patient is breathing 40% oxygen. But to give this 40%, you have to open the oxygen at 10 liters per minute, right? So this is not like this ventilation, mechanical ventilation, but this is, if you want to give this patient Venturi 40%, you have to open it at 10 liters per minute. So 10 minutes, altogether 30 minutes. The patient needs 10 liters per minute. So 10 liters into 30, 300 liters. So you need to take twice the requirement. So if you can take just 1 full E-cylinder, it should be enough, right? Okay. So now we are ready with all the equipment and drugs and oxygen, and monitoring is a must. So you have to make sure your portable monitor has the battery backup and it is capable of monitoring at least the basics, the ECG, heart rate, the non-invasive blood pressure, saturation, and if the patient is ventilated, EtCO2 or the end-tidal CO2 is a must, which says 5 here. This capnograph is a must if the patient is intubated, and you may measure temperature if the facility is available. And you have to make sure these alarms you tailor-made to the patient. Say like if the patient's heart rate is at 105, if the alarm is set up at the maximum heart rate alarm at 100, so this will be alarming throughout your journey. So you have to make sure you ask someone or just get used to your monitor and you set the alarm according to patient. You set it at 110 so that it won't alarm unnecessarily. And if it alarms, you are also alert that the patient is having some deterioration. So like that, you tailor-made the alarms as well according to the patient's clinical picture, and it should be audible enough, right? And whatever it is, whatever the machines are available, there has to be continuous presence and vigilance of a trained staff looking at the patient. This is the portable ventilator. Should be able to identify this FiO to P rate, tidal volumes, inspirator-expirator ratios. And if you take the ambulances, as I have told before, you just get yourself familiarized with your ambulance, because some ambulances are fully equipped. You have the suction, you have all the strapping of this and this beds, which is movable, and you have the monitors. Some have defibrillators, and some have these drip hangers. Some have portable ventilators. So just get yourself familiarized with these things in your hospital, especially the ambulance. And personnel, unfortunately, the recommendation is the senior, most experienced, competent person should be taking the patient. But in this situation, it could be you. So make sure you update yourself and make the opportunities best, especially during your theater times, to get familiarized with this emergency management. So this is the pre-transfer checklist 2. We have done the checklist 1 to make sure the patient is stable, and checklist 2 is done just before the departure. To see if the patient is stable, to see if the staff is stable, to see you have all the equipment, to see all these organizational activities have been done, informed, and then just before departure, you do some certain checklists. If the trolley is secured and electrical equipments are plugged and ventilators plugged, and you are happy, and then you transfer the patient. So during transportation, documentation is important. The recommendation is you should monitor every 5 minutes and write them. And the copy has to be in duplicate. Whatever happens, you have to document these things, significant events, administration of drugs, any interventions, and you have a copy for yourself and to the receiving end. So patient has to be secured, equipment has to be secured, staff has to be secured. It's better if you can have insurance coverage and membership from some defense organizations, especially these are a must in other countries. And if there is any clinical emergency, you are not going to resuscitate when the ambulance is going. You stop the vehicle, administer the treatment CPR. If the patient is unstable, you bypass and divert to the nearest hospital. High-speed travel is not necessary. Acceleration, deceleration has its own problems. You can use these lights and sirens just to pass the traffic. All these ambulance drivers are under the normal law of Sri Lanka, motor traffic regulations. So they can't cut any rules, bypass any rules when they transfer, because they have the same license. Right? If it is a child, you may allow this mother to come. And when you hand over the patient, there has to be a transfer somebody. So handing over at the receiving end, both medical and the nursing personnel simultaneously should hand this patient over to the receiving end. And once everything is being done, you, the staff, yourself, and the equipment has to come back to the base. And while you are coming back, you can have a debrief and then just discuss what went good, what went wrong, and to make sure that next, when you transfer, you know your deficiencies, you know your strengths, and then you can have a better patient outcome when you transfer the next patient. So try to get involved in simulation workshops, discuss with your senior colleagues, and discuss with your colleagues about your past experience, and then make sure you achieve a safe transportation of a patient. So that's it. I will not be talking about this transport of a patient who has COVID, because COVID is no longer taken as a separate illness now. So Dr. Roshan, if you're happy, I can stop sharing.
Yes. If anyone's having question, can ask Dr. Anushka. Sorry. Or you can type in the chat box at the same time. So that's in the meantime, thank you, Dr. Anushka Seniviratna, consultant anesthetist at Police Hospital, Colombo. Very important lecture on transport of critical patients. So next up is safety measures and infectious infection control at ICUs by Dr. Nandika Manika Singh, consultant anesthetist, Base Hospital, Kolana. Madam, can you hear?
Dr. Roshan?
Can hear, yes.
Yes. Can I proceed?
Yes.
Yeah, okay, thank you. Thank you, Dr. Roshan. I'm Nandika Vaniga Singha. I'm going to talk to you on infection control and safety measures in critically ill patients. At the end of this presentation, I expect you to know about infection control, general measures we have to apply to prevent infections, the standard precautions, care bundles, and safety of healthcare workers. First, what is an infection? Infection is the invasion of body tissues by disease-causing agents, their multiplication, and the reaction of host tissues to the infectious agents and the toxins they produce. That means there are infectious agents, they are bacteria, viruses, or parasites. They invade to our body and multiply, and they release toxins. But our body, or we are the host, have a reaction against those toxins and infectious agents. So that is an infection. How do infections happen? There should be 3 elements to infection occur. They are the source, host, and transmission. The source is the organism. It could be virus or bacteria or any pathogen. The host is a person who is at risk of getting an infection from the source. The transmission is the way organisms are moved to the susceptible person from the source. There are mainly 3 ways of transmission of infection. They are contact transmission, droplet transmission, and airborne transmission. We are talking here on healthcare-associated infections, or similarly nosocomial or hospital-acquired infections. These infections take place patients in a hospital or other healthcare facility, such as elderly home, nursing home, and orphanage, such a place. And these infections occur after 6 hours of admission to the healthcare unit or within 72 hours after discharge. That means they are not present or in incubating at the time of admission. So 48 hours after admission, and it could be appear within 72 hours after discharge also. This is healthcare associated infection. They are critically patients are at high risk of getting infections. Why? Basically, because of the critical illness, they are immunocompromised. So they are prone to get infection. And they do follow more invasive procedures and interventions, such as central venous catheter insertion, dialysis, for dialysis vascular catheter insertion, arterial lines, sometimes intubation. So lots of procedures we are doing to them, which make them prone to infection. And they come to the ICU after treating in other units. So they might have already infected and showing it now. And in the critical care setting, there are more pathogens which are multi-drug resistance. And we don't have very much isolation facilities in our setup, which makes patients keep too close to each other, makes susceptible for infection. And we do have less facilities to clean the environment, and we may insufficient adherence to the precautions, which we are going to talk next. So what is infection control? It is a series of procedures and guidelines to prevent healthcare associated infections. In this, your role is very much important. We have to adhere to infection prevention and control protocols. And today you learn, but this would be an old instructions when in the future. So you have to update regularly your knowledge regarding infection control and prevention. Plus, as you are the person who knows about that, you have to encourage others to follow these guidelines and principles. How can we prevent healthcare-associated infections in patients? Can you do it your own? So we discussed there are 3 elements on infection to happen. So it happens like a chain. We call it chain of infection. We said there's an infectious agent and they are stagnated in the reservoir. From this reservoir, there should be a portal of exit to come out the organism. And these organisms, there should be a mode of transmission to enter somebody else. And there should be a portal of entry here. And to get that, there should be a susceptible host. Again, this infectious agent multiply and stagnate. Same happen as a cycle. We call it chain of infection. So how can we prevent infection in our patient? We have to break the chain. It is very much important that they had internationally recognized International Infection Prevention Week. Every year we celebrate. So it is our responsibility to break this chain to prevent infections in our patients. Your role in contact transmission. We see lots of patients day to day in the ward. As interns, you see much more patients. So you touch patient A, which has the organisms located. We examine him and without precautions, we go and see the second patient, patient B, who is susceptible for infection. And we give this organism to the patient B. So they had found that contact transmission most commonly by healthcare workers' hands. So we do have more responsibility regarding this. Can you do it alone? As anything in medicine, infection control is also teamwork. It is not only you. We have a team in the hospital. It includes hospital administration to the housekeeping thing. Sometimes ministry also involved in this. They are conducting this type of programs regularly to update your knowledge. So that is also important when we talk on infection control. Usually the microbiologist is the chairperson because he knows about the pathogens, they are spread like things. And all the hospitals, we do have infection control unit and infection control nurses. And it includes the treating physician to our critically ill patient, pharmacist who issues equipment, instruments, medications for us. And it is also very important cleaning things, housekeeping and maintenance. So we all are a team to act against infections, to prevent infections in our patients. So what are the general safety measures we have to take? These measures we take to prevent or limit infection transmission. The standard precautions, additional precautions, administrative control, environmental control, and other important measures are there to prevent infections. These not only apply to the safety of the patient, but also the healthcare worker also. So standard precautions, to whom we use these things. All the staff in the hospital should follow these standard precautions. And in all healthcare settings, not only in critically ill patients, not only in the ICU, you should apply standard precautions in the wards, clinics, theaters, in all the places in the healthcare setting. And at all times, there's not to do this now, not to do next time, nothing like that. We have to apply it all times and for all patients, not only critically ill patients. And these are to ensure the safety of being cared for. Those are the patients, staff, and visitors. So, which we are going to talk as standard precautions we have to apply in all these situations. What are the standard precautions? They are hand hygiene, respiratory hygiene, appropriate personal protective equipment use, safe waste disposal management, environmental cleaning, patient care equipment cleaning, and patient placement. Hand hygiene. It is such important. The WHO had declared Global Hand Washing Day, October 15th. This is to improve hand hygiene and prevent infections in the healthcare settings. They had found hand hygiene is the most single important effective action to minimize spread of infections. More than 90% of infections in hospital could be prevented by hand hygiene practices. You know 5 moments of hand hygiene. This poster must be very familiar to you. Each and every ward near wash basin, you have seen these things. Your 5 moments. There are 5 times you have to use hand hygiene. If we go by one, first is before touching patient. It would be simply you just touch the patient. Even before that, you have to wash your hands. Second, before clean aseptic procedures. What are those things like urinary catheter insertion, blood culture taking, intravenous cannula insertion? Before those procedures, you have to follow hand hygiene technique. Then after body fluid exposure risk. That means you might have changed the catheter, insert the catheter. You might have changed the drains, or you might have assisted in endotracheal tube suctioning. Everything is, you are at risk of body fluid exposure. After that, you have to follow hand hygiene techniques. And after touching a patient, you may not done any invasive procedure. You may not have exposed to body fluids, but still if you check pulse, if you check the abdomen, if examine the abdomen, if you check temperature, whatever, if you had touched the patient, you have to follow hand hygiene before you go to the next patient. And after touching patient surroundings, that means not only the patient carries pathogens, his surrounding also. Those means the bed, red bells, saline stand, monitor, ventilator, bedhead ticket keeping table, everything are contaminated with pathogens. So you have to keep in mind these 5 moments of hand hygiene thoroughly. If I repeat again, before touching a patient, before clean aseptic procedure, after body fluid exposure risk, after touching a patient, and after touching patient surroundings. So don't forget your 5 moments of hand hygiene. Then you have to know your steps of hand washing. These are your steps of hand washing. You have to know each and every step. You may already know as you had done your surgical and chin and obs appointments. And you have to cleanse your hands separately. If your hands are visibly soiled with patient's blood or secretions, you have to use soap and water. And if it is not visibly soiled, but if you touch patient, you have to use alcohol-based hand rub. And we do have alcohol-based hand rubs now in hospital with each and every patient's bedhead table. So you can use those things, but if they don't keep, please keep one in your pocket when you do the ward rounds and seeing the patient. So these are very much important. You can assist to prevent infections by hand hygiene technique per se. And we talk lots of things on hand hygiene. We learn on that, we practice, but still we can't achieve preventing infections. Why? There's a dress code called bare below elbow. they recommend not to have any item below our elbows. So when you do ward round, when you see patient, please keep your bare below elbow dress code. That means you can't wear jewelry, rings, bangles, bracelets below elbow. And girls, sorry, no long nails, nail varnish, and false nails, which those things can make a pathogen growing area. And no wristbands, no wrist washers. And male doctors, if you come to the hospital with long sleeves, it's good always to push up your long sleeve above the elbow when you see the patient. If we can adhere to bare below elbow dress code, we can prevent loss of infections in our patients. So that is for your hand hygiene. It's easier to remember and easier to follow for all of you when you start your work. Second is respiratory hygiene. What are those things? Cover the mouth and nose when sneezing. Not with your palm, but with your elbow or with the tissue. And when you get these respiratory secretions in your hand, make sure follow hand hygiene after that. And always wear a medical mask. And tell your healthcare work team also to wear a medical mask. And educate your patients also follow respiratory hygiene. If you use a tissue for sneezing, don't squeeze the tissue in your hand. Just drop it into a bin, which can be controlled by a paddle with your leg, not open with your hand. Drop the tissue into the bin and wash your hands. So this is for respiratory hygiene. Next is appropriate use of PPE. You all might have worn full personal protective equipment during the COVID era, the pandemic at the peak. So there are lots of components in the personal protective equipment. We have to know standard personal protective equipment. They are the hairnet or the cap, goggles or the visor, surgical face mask, isolation gown, disposable gloves, shoes covers. You don't have to use each and every component of this standard PPE for each and every procedure. Depending on your procedure, you can use which is relevant to that procedure. For example, if you are doing intravenous cannulation, you can scrub up your hands and wear sterile gloves or plain gloves and mask. But if you are doing the lumbar puncture-like thing, you have to wear hairnet, face mask, isolation gown, and sterile gloves like that. But if you are managing a COVID patient and it is an aerosol generating procedure, you have to use full PPE. So you have to use your PPE appropriately and select according to the procedure. And if you are doing PPE, you have to know Dunning and Dauphin of the PPE also. These posters are available in the wards. And next is safe disposable of waste. You have already seen these color-coded bins in the wards. And adhere to this color coding system, which makes lots of infection prevention. The black bin is non-infectious waste. What are non-infectious? They can be papers, empty vials, leaflets, empty drug boxes, or your food also. So you can drop it into the non-infectious waste bin. And there's infectious waste bin. Those are your used surgical gloves, used gauze soaps, or infusion sets you use to give fluids to the patients. And there are highly infectious waste. Those are empty blood packs, empty blood containers, and patient tissues such as placenta, or if you had done wound toilet, the scraped tissues, you have to drop them to the highly infectious waste. The separation of waste also very important, otherwise they would get intact and contaminated. And in locally Sri Lanka also we do have color coding system and we have to follow that. What is this? It is the sharps bin. You have to very much precautious when you use sharps. You have to know proper handling of sharps. There are things you should not do and things you should do. What are the things you should not do when you handle sharps? Don't use needles from the disposable syringes by hand. If you draw blood from the patient, if you gave an injection, don't remove the needle from the syringe before discarding. And don't bend, break, or manipulate used needles in your hands. Don't sharp pass directly from hand to hand. If you do a tube insertion, if you do a suturing, don't give the needle or the scalpel to the nurse's hand. So, how are you going to discard the sharps properly? After using, you have to directly put your sharps into the sharps bin, which is located at the point of generation. What is point of generation? It is the sharps bin we keep as close as to the patient. If you do use sharps, always take the sharps bin close to you. And you have to discard it immediately after use. You can't keep it on the trolley or in the kidney tray for longer. And never leave them lying around to clean it later. So these things you have to follow when you use sharps. This is your sharps bin. It should be leak-proof, puncture-proof, with a small mouth and sealing possible with the handle. And make sure it has a biohazard symbol. This is your sharps, proper sharps bin, which you have to use for discarding sharps. So that is your waste disposable. And we have to take care about patient care equipment also. In the hospital, we do have different types of patient care equipment. Some of them are single-use, disposable, or dedicated. Single-use are like nebulizer mask, simple face mask you use to give oxygen to the patient. What is meant by single-use? You can use the same appliance to the one patient after cleaning, but not between two patients. You nebulize the mask with the mask now, you keep it to the clean and keep, and next time also to the same patient, you can use. That is single use. Disposable is after one time use, you remove it or discard it, such as suction catheters, needles, you don't reuse. And dedicated, that means it's good to have each equipment of these to one patient, such as stethoscope, blood pressure cuffs, thermometers. But I know we don't have those facilities. So we do share those things between patients. But before sharing between patients, make sure you clean and disinfect with approved disinfectant. And we have to follow manufacturer's guidelines when cleaning and disinfecting, sharing equipments. So always stethoscope clean when you see one patient. Before using to the next patient, you have to clean your stethoscope like that. And advise your patient, they should not share their utensils or any other consumables between each other. In the hospital, we see they share plates, mugs, or any other equipment they do have, but they should not do those things, and you have to advise the patients not to do that. And environmental cleaning. This should be, you have to supervise these things. We have to keep minimum number of equipment inside the unit, because when there are lots of equipment in our wards, all are good, good reservoirs for the pathogens. So we have to make sure, keep minimum equipment in the unit and clean patient's area at least once per day. And clean, disinfect surfaces like tables, bedhead ticket trolleys, such things according to microbiologist or hospital instructions. And we have to do it consistently and correctly, not just wiping. And make sure the unit is adequately ventilated. And we have to do proper environmental cleaning, that is walls, doors, knobs, washrooms, such things. And patient utensils and laundry also should be used safely. That is for the environmental cleaning. Then patient placement also important. That is, we have to find the patients at risk of getting infections. So we have to triage them, assess properly, and early recognize. Then we can isolate those patients and source control is achieved. We have to keep high level of clinical suspicion on patients with vomiting, diarrhea, and respiratory symptoms. We have to isolate to prevent others getting infections. Then those are your standard precautions. Then administrative control, we said we are a team. So we have, the administration also has a role in infection prevention and control. That means they have to train the healthcare workers regarding infection prevention and control. They have to surveillance to identify infections and monitor the compliance of healthcare workers, ensure adequate supply of necessary equipment, and they have to ensure adherence to infection control and prevention policies, because not only the patient, staff safety, well-being, and satisfaction also very much important. And we use antibiotics to control pathogens. So it is important to use antibiotics rationally. You have microbiology lectures also, but I would just tell you have to use correct antibiotics at correct time, and you should not delay giving antibiotics. Make sure you get specimens for antibiotic sensitivity tests before you initiate antibiotic. After taking specimens for antibiotic sensitivity test, you have to give antibiotics which are broad spectrum, which called empirical antibiotics. And if you don't know when to or what antibiotics to be used, just contact microbiologists. They are very helpful and you can call them at any time. And if you don't have an microbiologist at your hospital, call your seniors, discuss with them, and start antibiotics without delay. And please consider pharmacology and physiology when you prescribe antibiotics. Basically, they are dynamics and kinetics. And when you get the ABST, please de-escalate also the broad spectrum antibiotic to sensitive antibiotics. Those are for antibiotics. And we do apply care bundles in hospitals. What are those care bundles? Care bundle is a group of evidence-based interventions which, when performed together, have a better outcome than if performed individually. We apply these to prevent nosocomial infection. That means we do know we get central venous catheter related bloodstream infections, urinary catheter related infections. So to prevent those things, we apply care bundle. That means group of evidence-based interventions. If we go for the first one, central venous catheter care bundle. So to prevent central venous catheter related bloodstream infections, you have to apply these 5 interventions. You have to apply these 5 elements during insertion and maintenance. Hand hygiene, maximum barrier precaution at insertion. That means we have to follow strict aseptic technique, your hand hygiene and appropriate personal protective equipment. And to clean the skin, we have to use 2% chlorhexidine. And optimal catheter site selection. That means we do usual internal jugular vein, subclavian vein, femoral vein as the central veins. You have to select the sites depending on your patient. And we do insert central venous catheters for particular indications. So we have to daily review line necessity with prompt removal of unnecessary. If you can do with the peripheral cannula, if you don't need a central venous catheter, we have to remove that without keeping long. So these 5 elements includes your central venous catheter care bundle. If there's a patient in your ward-centric central venous catheter, you have to use these 5 elements as your care bundle. If we go to next care bundle, it's urinary catheter care bundle. You have to follow 2 things, 2 steps, that is at insertion and ongoing care. What are the things? You all might have inserted urinary catheters, but you have to make sure you follow the care bundle. That means if you have to insert the urinary catheter only if there's an indication. If the patient can go to the washroom, if the patient can use urinal, you can use it to measure. And make sure your hand hygiene technique before and after insertion. Your appropriate personal protective equipment use, and make sure you insert the catheter under aseptic non-touch technique. That means it comes in 2 bags. Remove outer cover, keep the polythene bag inside and only remove it from the tip. While keeping the polythene cover, you insert and connect to the catheter urinary bag, and then only you remove the polythene bag. That is non-touch. And you have to attach closed drainage system in sterile manner. So you have to follow these 5 elements when you insert the urinary catheter. And ongoing care. Whenever you handle the urinary catheter, make sure you follow hand hygiene. Second, aseptic sampling technique. You don't prick here and there of the urinary catheter to take samples, and you use only the sample pot. And always keep the drainage bag below the bladder level, otherwise reverse flow would take place and can introduce infection. And always use aseptic catheter manipulation. And you have to attach it to the patient's skin. And as your central venous catheter, daily review whether this patient needs the catheter, and when there's no need, please remove the catheter without keeping. And when you do surgeries, we have to follow surgical site infection care bundle. Those are prophylactic antibiotics when indicated. You can get advice from your consultant regarding this. And advise patients to have bath using soap the day before on the day of surgery. When appropriate, the hair removal should be done. And skin cleaning, 2% chlorhexidine in 70% alcohol. And always follow aseptic technique when you do the dressing change. These are very much important to prevent surgical site infection. Peripheral venous cannula care bundle. You think it's something simple which cannot cause infection, but it is also very important. Again, this also has 2 sections, insertion and maintenance. Insertion, again, only clinically, if only clinically indicate, it is inserted. Follow hand hygiene technique. Screen cleaning with 2% chlorhexidine with 70% alcohol. Antiseptics, if you clean with 2% chlorhexidine, don't wipe it out. Keep it there till it dry. Then maintain aseptic technique throughout the procedure. Don't touch the needle, this aseptic area when you insert. And sterile dressing to cover the cannula like this. And when it is in situ, again, you have to reassess the site and need for it, keeping it. And whenever you touch, you have to follow hand hygiene technique and check the dressing. And it should be intact and waterproof. And always clean and rub the access hub, that is, this cannula does not have, but we have an injection part. You have to clean it with 70% alcohol for 15 seconds or 30 twist before accessing the hub. That means before you give your medication, you have to clean the hub. Then only you give and nicely close it after use. So those are for cannula. And just few things for your protection, because you are very important to the country, to the healthcare service. So we are taking care of yourselves also. They said healthcare workers are at higher risk of exposure to infectious agents because they expose to body fluids, blood, secretions, invasive procedures. So you always follow the standard precautions and additional precautions. Make sure before you go to work, you get immunized. And you have to update, educate regarding infection control, prevention and occupational hazards. If you get accidental exposure to bloody fluids, such as percutaneous injuries, exposure to broken skin, mucous membranes, please immediately inform to the infection control unit and your seniors. They will advise you what to do. Make sure you are safe because you are very important. And from your side also, make sure you think as you are very much essential person, because your safety, your well-being, your satisfaction is very much important for the patient outcome, not only with regard to infection control, in every way. So maintain your immunity. I know you don't have time, but make sure you eat and drink. Your psychological status is very much important to prevent infections. Limit your long shifts for the capacity. Keep an alcohol rub always for your personal use. And don't touch your mouth, nose, eyes with potentially contaminated, gloved or bare hands after contact with patient, because you are very essential and important for us. In summary, I had discussed with you about infections and infection control, general precautions you have to take, and standard precautions you have to apply always to all the patients, few things on care bundles and safety of you. And thank you for your dedication by participating in this presentation to infection prevention and to help save lives. And these are my references. Hospital Infection Prevention and Control Manual. This is published by Sri Lanka College of Microbiologists. You can get lengthy details on infection prevention, and it can be downloaded also if you search for Google. And National Infection Prevention and Control Manual for England. And this is also very good, Central for Disease Control and WHO Infection Prevention and Control. If you go any of these websites, you can get lots of details on infection prevention and control. And on behalf of College of Anaesthesiologists and Intensivists of Sri Lanka, I wish you good luck for your internship and for your future. Thank you. Dr. Roshan, I had finished.
Yes, madam. Thank you very much. That was Dr. Nandika Manigasinghe on safety measures and infectious control in ICU. Thank you for the detailed lecture, madam. So, we come to the final lecture for the day. It's by Professor Makulolu. Is on acute pain. Just give us. Professor Makululu will join in a short while. She's joining from UK, said go for some function, so she'll join from there. Give us a moment. At the meantime, if you're having questions from Madam Nandika, Madam, you can ask now. You can unmute yourself or you can type in the chat box. You can start, Madam. Yeah.
Yeah. Thank you, Roshan. Yeah. Can you all see my slides? Hello?
Yes, Madam, can see. Yeah.
Okay, thank you. I think welcome to the last session of the day. I hope all of you are quite tired since you have connected since morning. So I'll try and keep my presentation as brief as possible and then try to finish off on time. So the topic I'm given is acute pain, how to treat patients coming to you with pain. So you all know that pain is a very common problem that we come across as medical professionals. So as house officers, you come across a lot of patients daily, and you should know, you should have some idea as to how you are supposed to manage the pain of these patients and why it's very important for you all to manage pain effectively to avoid certain complications of pain, which we often see in our patients. But, this is the outline of my presentation. So very briefly, I'll go through the global and Sri Lankan perspectives of acute pain and why it is necessary to treat patients coming to us with acute pain. And very briefly, the definition of pain put forward by the International Association for the Study of Pain, because very recently in 2020, this definition of pain has been revised. So it's very important for you to know the revised definition. And again, very briefly, pathophysiology of pain I wish to introduce you to this, the concept of multidimensional nature of pain, why it is important for us to manage their pain as a team and with multidimensional or multidisciplinary inputs. And then I'll very briefly and also very in a simplistic way, I'll tell you how you can approach the pain of these patients through what's called this RAT approach, where you give emphasis on recognition, assessment, and treatment in managing their pain. So these are the areas I'm going to touch upon during my presentation. Right. So here you can see RAT. So you might wonder as to why we have put a picture of a rat in this first slide. It's because untreated pain is considered as a rat. So you all know the rats are very destructive. It can cause a lot of damage to our personal belongings. Because of that, and also the rats, mostly during daytime, they are not visible. Unless you really look for them, it might not be possible for us to find them inside our houses. So the untreated pain is considered as it's considered as rats, because it's mostly the untreated pain might be hidden in many occasions. So in certain circumstances, unless you really look for it, you might not be able to identify the pain in some of our patients. So it's important for us to make sure that the patients to look for pain, because otherwise it might be hidden, or the patients themselves might not come up with their underlying pain. So the recognition is very important. And also, as I told you before, unless you identify the pain and treat it, the pain can cause a lot of suffering to the patients, with a lot of can interfere with their daily activities, and also their quality of life can get affected if the pain is untreated in most of these occasions. And finally, the pain can be treated by using simple ways, and also using very with less costly methods. So just as an introduction, the pain is the commonest symptom seen among 50 to 70% of patients come to us for treatment for several different conditions. And it's the commonest reason to see a doctor, or the reason for them to come to a hospital. However, though it's a common problem, it's in a global setting, even it's something that's ignored by doctors and nurses, especially the medical professionals in our system. So despite recent developments in pain management, still the pain is poorly managed, even in the developed world. This is something that we have seen in a global setting. So it same applies to us as well. So uncontrolled pain is associated with significant morbidity and mortality. This is something that you must understand. So it can cause a lot of damage to these patients. And therefore, it's important for us to recognize to avoid many complications in these patients. So one of the steps forward to improve pain management is to introduce education and training programs in pain management, whereby we can make the medical professionals aware of their problems related to the pain management, the complications related to the untreated pain, and thereby try and improve pain services at different levels in the medical system. Right, so why treat pain? So, as you all know, the untreated pain can impact on the individual, so their physical, psychological, and social well-being can get affected, especially the people, the mobility, their day-to-day activities, everything can get affected if the pain is untreated. Similarly, they psychologically can get affected. Their sleep can get affected. They can be depressed. They can be anxious. So many psychological problems can arise if the pain is not treated, and socially also they can get affected. Apart from the impact on the individual, the family also can get affected due to the pain of their siblings or family members. So the burden on the family can be quite huge. And on the whole, the society can get affected due to pain of individuals. I'll show you why. So untreated pain can impact on social well-being of the individuals and as well as the family. So it can interfere with their daily activities, and also their productivity can go down, and also there can be loss of, there can be financial issues due to the due to the loss of their productivity. So it will be a burden to the family, to the workplace, and as a whole to the society. So this is one of the areas where we must not overlook. Then coming on to the impact on general and physical well-being of the individuals. So pain can cause a lot of physiological derangements, such as it can initiate the stress response and with activation of sympathetic nervous system with multi-system and generalized effects on the injury. So if you concentrate on the cardiovascular system, the most of these patients in pain, they may be tachycardic, their blood pressure might go up with increased, with an imbalance in the myocardial oxygen supply and demand. So in susceptible individuals, pain can cause precipitate angina or MI or even congestive cardiac failure. So in terms of respiratory system, the pain can lead to poor cough. The patients who are in pain might not cough well to clear their secretions, and also their breathing can get affected with the tachypnea and shallow breathing. All can give rise to atelectasis, pneumonia, eventually leading to hypoxemia. So this is something that we often see among our patients following major surgeries, and also those who have got multiple injuries. So because of their pain, all respiratory parameters get affected. Eventually, they might end up in complications like orthostatic pneumonias and hypoxemias. So this is a major area where we need to focus on following major surgical procedures and in those with multiple injuries. And in terms of GI, general gastrointestinal system, sympathetic stimulation can lead to gastric stasis and paralytic ileus. So the feeding can get delayed if the bowel sounds are not present, and also the patients may be constipated and they're likely to develop stress ulcers and also loss of appetite. So these are the negative aspects in relation to gastrointestinal system. And in so somebody who is in pain can get urinary retention, so they may not pass the urine with the tendency for urinary retention. And in relation to central nervous system, the pain can cause a lot of anxiety, restlessness, and also lack of sleep. So on the whole, all these effects on different systems in the body can lead to reduced mobility and delayed recovery. This is one of the things that we pay a lot of focus in the perioperative period, especially. So we want the patients to be mobilized quickly and also to hasten their recovery. So if we don't relieve their pain, their mobility as well as recovery can get affected. Another important downside of pain is the tendency for the tendency for deep vein thrombosis. This is another area we need to look into. So unless we focus on their mobility, early mobilization, they can end up in having deep vein thrombosis, and also pain can cause immunosuppression with tendency for infections and impaired wound healing. And finally, but not finally, and also not the least important aspects of what I have mentioned so far, unrelieved pain, acute pain can lead to chronic pain conditions in these patients. So this is something that you need to remember. If you don't relieve acute pain when they come to us following surgery or following injuries, so unrelieved acute pain can give rise to chronic pain, which is quite difficult to treat and difficult to manage compared to acute pain conditions. Right. Then coming on to the impact on psychological well-being unrelieved pain can cause a lot of mental agony, stress, anxiety, restlessness, depression, lack of sleep. So a lot of impact on interpersonal relationships of these individuals. So there's a reason for us to look for these things and try and relieve their pain. So just to go through the pain pathway to show why it's an unpleasant sensory and emotional experience. So, following exposure to a noxious stimulus, the pain pathway, the neuronal pathways get activated, and eventually the patients will perceive pain with certain localization related to the area of damage. So we all know it's an unpleasant experience with sensory component as well as emotional component. So emotional components are very important. So somebody who is in pain may be having emotional changes, anxiety, they may be crying, they may be restless, they may be very boisterous, there may be behavioral problems. So emotional experiences are very, very important, which we've seen in association with the perception of pain. And in the majority of instances in instances where there's acute pain, we can identify the area of tissue damage. But in certain conditions like backache or phantom limb pain, you may not be able to visualize the tissue damage or tissue injury from outside, but there's always some damage somewhere along the pain pathway, giving rise to pain in the individuals. So what is important is to understand the subjective nature of pain, which is very subjective, individualized. So pain experience vary from person to person. So it's not compared. Pain cannot be compared with somebody else's pain. So it's a very subjective feeling. And then what the patient says hurts, we need to accept. This should not challenge their expression of pain. So it's a individual. There's a lot of individual variation among these patients. This slide shows the physiological pathway of pain. So you all know the nociceptors are the pain receptors in the periphery in relation to tissues. When following a tissue injury, these nociceptors, there's a lot of anti-inflammatory agents are released. So they sensitize these nociceptors. And following the sensitization, then A delta and C fibers get activated and they carry pain impulses to the dorsal horn. It's an important area of pain modulation. So there are descending tracts which try to minimize the pain transmission beyond this point. So that's why the modulatory activities are very, very important at this point. And then it's carried to the thalamus. Thalamus is the area where the pain is perceived or feeling of pain is taking place at the point of thalamus. And again, it's a very important area of pain modulation, which we make use during our treatment intervention. So this thalamus has a lot of connections with higher areas, high centers in the brain. And also so many other areas. So this is an area where which we can make use in modulating the extent of pain perceived by the individual. So meditation, music therapy, distraction therapies, almost all act through this area, the thalamus, where we can try and minimize the increase the pain threshold or minimize the pain perceived by interfering with the pain perception at the thalamic level. And beyond this point, it goes up to the sensory cortex where the pain localization takes place. So as far as the pain perception is concerned, thalamus is the most important area where we can use different techniques to modulate the extent of pain perceived. Coming on to the definition, I told you it's been revised recently. So most of the initial definition is not changed, but there are certain additions to the initial definition. So as I said before, the International Association for the Study of Pain is a world organization. We all make use of the definition put forward by this organization. So according to them, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So the most important terms, the words I have highlighted. So it's an unpleasant, it's sensory, and often associated with emotional changes. And seen with the presence of actual or potential tissue damage. Right. Then this is the additional parts added to the recent definition of pain, which was revised in 2020, and they have added these as pain notes to the main definition. So according to that, the pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. So this is something very important for you to understand. That's why the pain is going to be variable from person to person. So based on the physical, psychological, and social factors of the individual, the pain perception, the feeling of pain or the perception can vary. The other thing is pain and nociception are different phenomena. Pain cannot be inferred solely from activity in the soul. So it's not always related to the extent of tissue damage. So it's something going beyond that. So that's where these the biological, psychological, and social factors come into play. So the pain perception is not directly related to the extent of pain, tissue damage, but it goes beyond that. So there are so many other factors which can influence the pain perception. Through their life experiences, individuals learn the concept of pain. So somebody who has gone through the pain experience before might have less pain perceived later on in their lives. But similarly, somebody who has got underlying cancers or some other medical problems, they might experience more pain than a person with similar condition that we see. So it's pain, the life experiences can affect the perception or the feeling of pain. A person's report of an experience as pain should be respected. So this is very important. We must never challenge challenge patients when they express the extent of pain. They tell us. So we have to accept what they say. Although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological. And so pain is going to have a lot of impact on our overall well-being. And also quality of life. So these are things that we need to look for in the assessment. I'll show you when I come to pain assessment. And the verbal description is only one of several behaviors to express pain. So inability to communicate does not negate the possibility that a human or a non-human animal experiences. So this is where the recognition comes very important. So not everyone in pain will tell us that they are in pain, but there may be patients who might not tell us anything verbally, but they may be in pain. So that's why the recognition, or we must always look for pain in instances where the patients could be having pain. So recognition of pain is very, very important as when it comes to pain management. Now, this is something that most of you are familiar with. Now here you can see that there's definite tissue damage, but do you think he's feeling pain? I think it doesn't seem to be in pain, even though there's definite tissue damage. That's because due to the religious or or cultural beliefs. Even though there's tissue damage, he doesn't seem to be in pain. Same applies to this instance where the people walk on fire, and here you can see they don't seem to be in pain. So let's see why. It's because there's a lot of pain modulation takes place at the thalamic level. So their personal beliefs like religion, attitudes, psychological factors like anxiety, depression, they all can affect at the thalamic level to either increase or reduce the level of pain perceived by the individuals. So from the point of injury, tissue injury, to the place where the pain is perceived at the thalamic level, many things can affect the pain, the ascending pain pathway, the impulses coming up to thalamus. So those can directly influence the pain perception at the thalamic level. So that's one of the reasons why the picture I've shown you in my previous slide, the person there might not feel pain. So psychological factors like anxiety, depression, like patients who have already got some medical problems like cancers, they might feel more pain than somebody without a cancer. So again, they have some influence on the thalamic level to modulate the pain perception. Similarly, some of the treatment strategies we use, the coping strategies like meditation, music therapy, just to distract these patients who are in pain from distraction therapies, that again acting at the thalamic level to try and distract them from their pain and to make use as pain intervention. So same thing, same observation we have used in our treatment interventions. The social factors are also important. So the people who come from lower socioeconomic area levels, they tend to have more pain than those who come from higher levels. So this is something that they have seen. Also, other illnesses, as I told you before. So somebody who has got underlying cancers and chronic illnesses tend to feel more pain than others. So what is important for you to understand is that thalamic level, the pain is modulated individually. So based on that, pain can be expressed at a higher level or at a lower level. Similarly, the same observation have been made use in our treatment interventions to try and influence at the thalamic level to try and minimize their pain perception. So this is very important. So what is pain? It's an unpleasant condition, experience with associated emotional and behavioral changes. The cause is not always possible, as I told you before. In patients with backache, you might not be able to see any injury from here. So therefore, pain is considered as what the patient says. So you must respect their feeling or expressions. So it's a subjective feeling influenced by the age, sex, physical, and psychosocial status of the individual, and it has a multidimensional nature. So the feeling of pain is just a sensation that you see, but beyond that, there's so many other aspects of the patient is affected physically. They can be affected psychologically and socially. So you must always look for the impact of pain on the whole individual, how the pain has affected them physically, socially, and psychologically. So this is very important for you to understand. So because of that, the pain management is multidisciplinary, and we need to have a holistic approach. So somebody with physical disability, say they have their physical mobility is limited, then we might have to get the inputs from occupational therapists or from physios to try and improve their mobility. So that's why it's called multidisciplinary. Some say with the patients having psychological problems, we might have to get the psychologist input, the counselors input, psychiatrist input to try and improve their to try and minimize the psychological impact. So it's a multidisciplinary. So it's not only the anesthetist or the pain specialist can manage their pain, but it's a multidisciplinary input that we require in managing pain in a holistic manner. Same applies to social well-being. So as a result of their pain, if they have underlying social problems, then again, we must try and get the social workers' inputs to try and help them with their social effects. Right. So coming on to that approach, I told you this is an approach described by two anesthetists, one from New Zealand and another one is from Australia. So this is a very simplistic approach that all of us in managing pain of our patients. So it's a very simplistic approach to pain management. So RAT includes the R for recognition of pain, A for assessment, and T for treatment. So RAT approach is very simple and it's very easy to remember. And this is something that you can make use in your practice as a house officer. So recognition, so as I told you, it's very important because some of these patients might tell us that they are in pain. So recognition of pain is very important. And having recognized the pain in our patients, so then we must assess to see how bad their pain is, along with other other aspects of pain, the impact of pain on the individual. So first of all, we must find out the severity of pain because our treatment interventions are based on the severity. And also having assessed the severity, then we must try and identify the type of pain, whether it's usually pain is categorized into two broad areas, the cancer pain and non-cancer pain. Now today I'll be focusing mainly on non-cancer pain. So I'm not going to go into cancer pain. So it's mostly the acute pain I covered today. And as I told you, and it's important for us to find out how the pain has affected the individual, other effects, how the pain has affected the individual physically, psychologically, and socially, and how the pain has affected the rest of the family, and also in a broad context, how it has affected the society. So these are the aspects we are supposed to assess when we see a patient in pain. So assessment of pain. Now it's something that some of you might be already aware that pain has been classified as the 5th vital sign by the International Association for the Study of Pain. So that itself tells us the importance of monitoring pain as any other vital sign like heart rate, blood pressure, respiratory rate, etc. So pain is considered as, has already been declared as the 5th vital sign. So it's important for you to give its due recognition when you are dealing with pain. So it's like any other vital sign, it's important for you to monitor it regularly. And it's mandatory to assess pain on a regular basis. So assessment of severity. So let's see how we are supposed to assess severity, and it's important for you to use a validated pain scale. So it's something that we all must use. Now there are different types of pain scales available. here you can see here, we can use verbal rating scale, the numerical rating. So verbal rating scale is the most simplistic scale where you can straight away ask verbally whether the patient has got pain. When if they do have pain, then it's mild, moderate, or severe. So this is something which can be used by any of us in the ward setting, even though it's not so accurate, but still it can be used in a busy ward setting. And always make sure that you record what the patient, record the extent of it. Apart from that, you can use what's called the numerical rating scale, where the scale is from 0 to 10. 0 is no pain and 10 is worst pain. Here you can see this is a scale which we always recommend we all to use. And this is numbered from 0 to 10. 0 is the no pain, 10 is the worst possible pain, and in between you have 9 numbers from 1 to 9, and it's color coded as well. From 1 to 3 is the mild pain, from 4 to 6 is kind of moderate pain, and from 7 to 9 is severe pain, and 10 is unbearable and has supposed to be something immediately. So it's always advisable to use this kind of pain scale, and we can always show this to the patient and give the patient to rate their pain, the extent of pain, and so it's more individualized and self-rated. It's very, very important that we try to rate their pain. And faces scale is something that you can use in small children, where you go by the facial expressions in ICUs, and somebody who cannot verbally tell us rate their pain. So these are some of the scales, simple scales that you can use. The faces scale, the facial expressions. So you always use a validated pain scale, one of them you're supposed to use, and try and get the patient to rate the pain. Self-reported pain is better, so get the patient to rate their pain rather than we try to come up with our own decisions. And so assessment of pain scores are important on a regular basis as another vital sign. So regular pain assessment is very, very important. It's not enough for us to assess it only once, but you must do it regularly, and also important for you to remember to assess pain at rest and on movement, and especially those who are in the post-operative period or following some kind of injury. So when they are in the bed, so at rest, they may not be having a lot of pain, but the moment they start mobilizing themselves, like during coughing, deep breathing, mobilization to chair, or during physiotherapy, maybe experience quite a lot of pain. So that's why the pain scores are important to assess at rest as well as on movement. So what is important is to try and keep them pain-free on movement, especially during coughing, deep breathing, and during physiotherapy. If the pain is not relieved during these activities, then they might not mobilize, they might resist physio, and then eventually they might end up in having a lot of complications, especially related to the respiratory system. So assessment at rest and on movement is very, very important. And then finally, the record of, you make use of a pain chart. Now, all of you record your vital signs. You get the nurses to record vital signs on a piece of, on the bedhead tickets. Similarly, get the nurses to chart the pain on the same chart where you monitor the vital signs. So assess pain and also keep records of pain is very, very important, because when the next doctor comes, or when another nurse comes, then they would always, when they go through the pain charts or the vital charts, record chart, then they would know the extent of pain the patients have experienced previous to, or a few hours ago or previously. So charting is very, very important. So these are the scales. I've gone through it, and so this is something that you can use. And you can have these downloaded onto your phones, and or else you can use the paper version to assess the pain. So apart from assessing the severity, then I told you it's important to assess the effects of other effects of pain on the individual. So physical, psychological. So this is something we always forget. So now hereafter, as the moment you become house officers, so remember to assess their physical, the impact of pain on the physical, psychological, and socioeconomic aspects of the individual. So impact on self, so assess their mobility, whether the mobility is affected, whether they are in a lot of discomfort, whether the appetite is affected, whether there's nausea, vomiting. So these things are very, very important. And if you do find any of them, so it's important for you to do what is necessary for them to improve the physical well-being of these individuals. And psychologically, it's always important for us to see whether they're anxious, depressed, or there's lack of sleep due to the pain. And again, pain, you must try and relieve their pain, and that is not going to improve their the psychological impact. Then you might have to get the advice or the assistance of psychologists, psychiatrists to help them with the psychological well-being. And socioeconomic aspects, again, very, very important. The interpersonal relationships can be affected due to pain. So here is another area where we need to monitor in terms of assessment. So then, apart from assessing the impact on the individual, then especially in patients coming with chronic pain conditions, we look at how the pain has affected the other members of the family and also on the society as a whole. So, but at your level as house officers, since you'll be dealing mostly with acute pain conditions, these areas are very, very important, how the pain has affected the individual. So coming on to treatment, so I've gone through the recognition of pain and the assessment on the right approach. So finally is the treatment. Now remember, so you make use of drugs as well as non-drug interventions in managing the pain of these patients. So this is again an area which we tend to overlook. So remember, there are so many non-drug interventions that are available for us to make use in managing pain, even acute pain conditions in these patients. So never ever forget these non-drug interventions in treating pain of these patients. So pain management is basically, it's multimodal. We use different techniques, different drugs. So drugs as well as non-drug techniques, that's why it's multimodal. And also we need multidisciplinary inputs. It's not only the anesthetist who would look after the pain of these patients or other doctors. We always can get others in our team, others in the healthcare system to help us with managing pain, that the physios, psychologists, these occupational therapists, so many people can help us in managing their pain. So that's why multidisciplinary inputs are necessary. So coming on to multimodal therapy. So multimodal therapy includes the use of multiple drugs and multiple methods and techniques to different routes as well as non-drug. And so that's why it's called multimodal, different type of drugs, different type of interventions used through different routes and also by different techniques. So all these are important. So coming on to multiple drugs, we commonly use simple analgesics like paracetamol and non-steroidals. These are used in almost all the situations. But apart from that, depending on the severity of pain, we can keep adding different other drugs like weak and strong opioids like tramadol, or strong opioids like morphine. And then apart from those, then we can make use of other non-adjuvant non-analgesics like gabapentin, carbamazepine, and pregabalin. So, but remember, at your level, you are not supposed to use them. So they should be used under the supervision of a consultant pain specialists because they have a lot of other side effects. Therefore, those drugs are meant to be used under the direct supervision of pain specialist or anesthetist. But at your level, you can make use of any of these simple analgesics or weak or strong opioids, depending on the extent of pain to relieve their pain. And under multimodal therapy, so there's multiple methods we use. So we can use these drugs through multiple methods, techniques, and through use. So coming on to routes, they can be used orally, parenterally, IM, IV, or subcut, or parectal, or sublingual. So many methods, routes are used to administer these medications. And also some of the techniques like spinals, epidurals, neuraxial blocks can be used, and also they can be used as regional blocks. So a lot of methods or techniques are used in administering different types of drugs through different routes. Apart from drugs, I told you, not forgetting the non-drug interventions. So some of them, to name a few, includes reassurance. So somebody who is in pain, the reassurance of the individual as well as the family is very, very important, because they may be having a lot of fears about their pain. So speak to the patients and try and give them a lot of reassurance that that's going to be very helpful for those patients. And counseling is wherever it's needed, counseling can be used. And also, I'll come to this eyes, what's this eyes, and also physio. So these are some of the non-drugs. So always use multiple therapies, multiple drugs, as well as non-drug interventions through different techniques and rules to try and help these patients in their pain. So multimodal therapy includes both drug and non-drug treatments used through different routes, different techniques, and different methods. So this is a very important concept you must take into your head when managing patients in pain. So multimodal therapy, just to give the advantages. So it's basically, the multimodal therapy is the use of more than one medication or technique through different rules and different methods. Why? It's been shown that it's very efficient by using multimodal therapy, different drugs, different non-drug interventions have been very effective in managing pain of these patients. And here, by using multiple therapies, you can minimize the dose used of individual agents. So if you try to manage the severe pain of a patient following major surgery, only with the opioids, you might have to use fairly large doses quite often compared to using opioids with other simple analgesics like paracetamol and non-steroidal. So by using multimodal therapy, by combining opioids with simple analgesics, then you can minimize the dose that you use, and also you can use the strong opioids less frequently, and thereby you can minimize the side effects of these injuries. So that's a major advantage of using multimodal therapy. So how you use it? By using different types of drugs, simple analgesics, mild or strong opioids, along with other non-adjuvant drugs, non-analgesic drugs like adjuvant analgesics, along with other drug interventions. So these are the advantages of multimodal therapy. Now, just to justify why we recommend using multimodal therapy, so this is the pharmacological basis of using multimodal therapy. Here you can see different drugs, different interventions. They act on different levels of the pain path. You know, if you take, for instance, if you use anti-inflammatory drug, non-steroids, they act in the periphery. They all know they inhibit the enzyme cyclooxygenase, thereby the production of prostaglandins. They are inflammatory agents which sensitizes the nociceptor. So by using non-steroids, we can minimize the number of pain impulses originating from the periphery. And then if you want to go for a regional block, nerve block, then by using local anesthetics, you can block the pain pathway, peripheral nerves. Thereby you can minimize the number of impulses going up on the pain, up to the pain going up to the thalamus where the pain is perceived. Similarly, dorsal horn is a very important area where both local anesthetics, we use epidural through epidural spinal or combined spinal epidurals, and also opioid given through the spinal. There are opioid receptors, the mu receptors here in the dorsal horn. They all act at the dorsal horn level, and they minimize the number of impulses going up on the pain pathway to the thalamus. So dorsal horn is an important area in the pain pathway where we use a lot of medications to try and minimize the number of pain impulses going up, and thereby minimize the pain perception or pain feeling of extent of pain they perceive. And apart from that, and the opioids given systemically, IV, IM, or subcut, they all get into the thalamus in the brain, where there's mu receptors, the opioid receptors, and then they can minimize the pain perception. So you can see different types of drugs. They act at different levels in the pain pathway to try and minimize the number of impulses going up to the thalamus, where the pain is perceived. So that way we can minimize the pain perception. So those are the drug interventions. Apart from that, I told you non-drug interventions like meditation, counseling, relaxation methods, the music therapy, where we can distract the patients from it. So all these non-drug interventions, they act at the thalamic level. They minimize the pain, they increase the pain threshold at the thalamic level. So they have a major role to play, especially in managing chronic pain conditions. So we make use of these treatment interventions to try and minimize the pain perception along with other drug interventions. The other physical methods include TENS and acupuncture. They modulate the pain at the dorsal horn level. So TENS and acupuncture, they both stimulate the beta fibers, the large fibers, and they help to block the pain gate at the dorsal horn. So TENS, acupuncture, they all help in blocking the pain gate, and thereby again minimize the pain transmission beyond that point. So all these drugs as well as non-drug interventions, they all act somewhere along this pain pathway and thereby minimize the pain perceived at the thalamic level. So this is the basis of using multimodal therapy in managing pain of our patients. So why the severity of pain is very important? It's because it's whether mild, moderate, because the treatment depends on the type of drugs that we select, depends on the severity. This is a very important chart again. Now you see the mild pain is somebody with scores from 1 to 3, moderate pain 4 to 6, and severe pain. Somebody with mild pain, so we can give, most of the time we can get away with simple analgesic, paracetamol, non-steroidal. But in somebody with moderate pain, in addition to paracetamol, non-steroidal, you might have to add one of the mild opioid like tramadol or opium, or the codeine like preparations, even though they are not available to us. And somebody coming with severe pain, apart from paracetamol and non-steroidal, the simple analgesic, you might have to add morphine and also plus or minus nerve blocks and other intervention. So this is a very important chart which you can, if you can remember. So for almost all the patients, we are supposed to use one of the simple analgesics, and depending on the extent of severity, then if it's moderate pain, you can add tramadol or some of the mild opioid, and if the pain is very severe, then you can add morphine. So this is a chart that again you can use as house access. Then again, this is the pain ladder showing mild, moderate pain. The same thing I had shown in my previous slide. If it's mild pain, you use simple analgesic. This is moderate. Apart from simple analgesic, you add an opioid, weak opioid, tramadol or codeine. And if it's severe pain, to the simple analgesics, you add strong opioids, morphine or pethidine. So depending on the severity of pain, that's why we assess severity. You can go up on the, if the pain is increasing, you can go up on the ladder. But if the pain is decreasing, you can come down on the ladder. So assessment of severity of pain is very important. Because of this reason, depending on the severity of pain, you've got to decide whether the kind of medications that you are going to use. So pharmacological methods, I told you, these are the drugs that we use. Paracetamol, maybe anti-inflammatory tissue, nobody knows where exactly it acts. Non-steroidal reduce prostaglandins, and at tissue level reduce nociceptor stimulation. Opioids act on opioid receptors in the central nervous system, spinal cord, and in the brain. And local anesthetics, they simply block the sodium channels in the nerves, thereby prevent transmission beyond the place of administration. And individual drugs, coming on to the routes, paracetamol, you can use oral PR. Remember, there are IV preparations available for those who cannot take, cannot be given orally. It's good for mild and moderate severe pain, along with non-steroidals. And dose is very important. These are things that you should remember. 15 milligrams per kilogram per dose. You can be given 4 to 6 hours. The maximum dose should not exceed 60 milligrams per kilogram for 24 hours. The onset of action takes about 30 minutes, absorbed in the small intestine. Side effects are seen only with large doses and also in patients with liver failure. Then diclofenac, again, oral parectal preparations are available. Unfortunately, we don't have the IM and IV preparation at present in Sri Lanka. The dose, again, very important. Its dose is 1 to 2 milligrams per kilogram, given 8 to 2 hourly. The maximum adult dose, you should not, adult dose is 150 milligrams over 24. You should not exceed 150 milligrams over 24 hours per adult person. So if you have given a loading dose of 100, then in the next 12 hours, you can give only another 50. So remember that, so shouldn't exceed 150 milligrams over 24 hours. From next day onwards, you can use 50 milligrams TDS. So this is again very important because a lot of side effects are seen with the use of diclofenac, large doses over longer periods of time. So onset and duration, 30 to 60, onset is about 30 to 60 minutes, and depending on the route of administration, and the duration 8 to 12 hours. If you give a loading dose, it lasts for about 12 hours, but if it's a 50 milligram dose, it lasts for about 8 hours. So you have to give it 3 times a day. Side effects, it's important before administering diclofenac, always look for side effects, any precautions you're supposed to take. These are the precautions. Look for any gastritis or gastric ulcers in the past. So whether they have these symptoms, GI symptoms, is always combined to be given with omeprazole, proton pump inhibitors, and look for any evidence of renal failure. You might have to monitor their serum creatinine, and advisable to avoiding extremes of age over the age of 75, 80, because invariably their renal functions are in the borderline. So by giving diclofenac non-steroidal, you can precipitate renal failure in these patients. So better to avoid in extremes of life. And also some of these patients reported to have precipitation of asthmatic attacks. Then again, you might have to check with the patients whether they have taken medications safely in the past without having any attacks, asthmatic attacks precipitated. So that's something that you got to see. And also, you should not use the diclofenac in patients with who having bleeding tendencies. Then ibuprofen is less potent than diclofenac sodium. It's oral route drug tablets are available. Dose is 10 milligrams per kilogram body weight. You can give it 8 hourly. Again, duration and onset and duration is more or less the same. Side effects profile are more or less similar to other non-steroidal. So you've got to look for this. Remember, this is used commonly for children because the syrup preparations are available now. Then tramadol is a weak opioid. It's previously it's a non-controlled drug, but since there had been a lot of issues recently, then it's being used as a controlled drug like any other opioid. The tablet versions are available, 50 to 100 milligram tablets, or also injections are available, IM/IV preparations, which you can use on a 6 to 8 hour basis. Then onset and duration, again, it's the same, about 30 to 60 minute onset, and lasts for 6 to 8 hours, the effect. Side effects, nausea and vomiting is very, very common. If you're using tramadol, it's always write a antiemetic on a PRN basis, and also it can cause sedation. It's respiratory depression, very, very unlikely in patients having tramadol IV or IM parenterally. Then morphine is a controlled drug, you all know. It's IM subcut IV for acute severe pain, but we use oral preparations for chronic pain conditions like cancer pain and other conditions. But as a house officer, you can use IM subcut or IV preparations in patients you come across during your daily practice. Remember, the dose is very important, 0.1 milligram per kilogram. But if the patient is weighing 50 kilos, then you can give 5 milligrams, provided there are other renal functions and liver functions are okay. So you can use it IM or subcut 4 hourly, minimum 4 to 6 hourly, or even depending on the situation, you can use it you can start off with 4 hourly if they have a lot of pain, and then you can space out later on. So injections are IV preparations. Some of you can, if there's special precautions taken if you're using it IV in the ward setting, but in ICUs and theaters, we use it IV. But in a ward setting, you are supposed to monitor them if you're using initial doses of IV preparations. And apart from that, PCA, the patient-controlled analgesia, can be used as infusions. You learn them wherever, depending on the place you're going to work. If you're going to work in a major hospital, you'll see us using patient-controlled analgesia with morphine. So you'll have to get yourself familiar with the devices, the PCA pumps that we use. So those cannot be taught during a lecture like this, but you learn them during our practice. So if you given it IM or subcuts, onset is about 30 minutes and it will last for 4 to 6 hours. But if you give it IV, you can see the effects in 5 minutes, and the duration will be shorter compared to IM subcut injections. It will not last for more than 1 hour. So that's why it's always you're supposed to combine that with IM subcut to have a longer effect. Side effects include sedation, nausea, vomiting, and respiratory depression. It's not common, but if you use a very large dose, then you can get, patients can get respiratory depression. Before you see respiratory, you can see the patients are getting sedated. So under supervision, that's why you have to give it under supervision. But if you stick to the usual dose in a healthy person, it's very unlikely for them to develop respiratory depression. Then pethidine is a less potent drug compared to morphine. It's again a controlled drug. The dose, the vials we get in 50-75 milligrams vials. Again, IM/IV can be given. The dose is here, it's 1 milligram per kilogram. It's easy to remember. Morphine is 0.1. Here it's 1 milligram per kilogram per body weight. And you can give again 4 hourly. NIV can give 1 to 2 hourly. The onset and duration is more or less similar to morphine, and side effect profile is also the same. So those are the commonly used drugs for managing acute pain. So coming on to drug interventions, just to show where they act. So if you use RICE is where is dry R for rest, for somebody coming with pain due to fracture, then you need to rest the area with a splint so that itself gives them a lot of pain relief. You can use ice or compression or elevation. So these RISE stands for rest, ice, compression and elevation, which you can use for those coming with fractures or some edema, swelling due to some underlying another problem. So in the peripheral areas, you can use RISE to try and minimize the number of nociceptors stimulated. And at the spinal cord level, you can use TENS acupuncture at the dorsal horn level to try and minimize the pain transmission beyond that. So TENS is something that is commonly used during labor pains. So that again helps in minimizing the pain perceived. And at the brain level, as a lot of psychological and other distraction therapies are very, very used. Counseling, reassurance, and other music therapy, those things act at the thalamic level to try and minimize the pain perceived. So this again shows how the non-drug different types of non-drug interventions help to minimize the pain transmission up to the thalamic level where the pain is perceived. So often the pain is underestimated and undertreated due to these reasons. It's mostly underestimated by doctors and nurses, and that's why this education on RATEP approach of pain management is very, very important for us to make you aware of the different aspects of pain, and thereby to try and minimize the underestimation of pain by the medical professionals. And pain may be underestimated due to distraction, may be distracted by the surgery and injury. So often we give more preference or more focus on the surgery and the underlying injuries, forgetting about the pain management. So this is something again that you got to remember. So pain management is as equally important as managing the underlying injury or the surgical procedure. Another reason for underestimation is the lack of knowledge. Again, that's why I said so awareness and pain education is very, very important about the drugs as well as non-drug interventions. And a lot of myths are associated with pain management. So there are people who believe that, even medical professionals among us, believe that pain is something acceptable following a surgery or during delivery. It's not so. It can cause a lot of harm to the babies, the babies to be born, or to the individual itself. So these myths are very important. We need to get rid of these myths related to pain management. The same applies here. Pain is not, some people believe that it's not harmful. It's not so. It's very harmful. I've shown you why, what it can, the complications it can cause due to unrelieved pain. So pain relief obscures signs of comprehensive patients who comes with head injuries. Some of you may not use morphine, thinking that morphine can sedate the patient and that can obscure the underlying changes in the neurological changes. It's not so nowadays. We don't go by the neurological features purely, but we have the access to CT scans, MRI to diagnose underlying brain injury. So we don't depend on the science of physical parameters, but just because it can obscure or hide the physical changes, should not prevent us from using opioids. Patient will become addicted. So there's another fear some of us have. So then they're not going, if you use the correct dose, the chances of them becoming addicted is very, very minimum. So what's called opiophobia and addiction. So risk of respiratory depression may be high. So it's also not so. If you use a calculated dose, it's very unlikely. And also don't use some of these drugs on a PRN basis or SOS basis, especially simple anesthesia. You must use them on a regular basis, and you may use some of the other drugs on a PRN basis, but always prescriptions needs to be written very clearly for the nurses to administer drugs according to the prescriptions. So coming on to I told you, even though there's a lot of developments in pain management, a lot of barriers to pain, effective pain management is due to some of the patient barriers, professional barriers, and the system barriers. So as medical professionals, we must try and overcome these patients, professional and organizational and all the system barriers to try and give our patients very good pain relief. So that's the end of my presentation. So just a case scenario to sum up what I have said so far based on the right approach. Mr. G is a 54-year-old man who has just had a laparotomy for bowel obstruction. You see him on the surgical ward soon after the operation, and he complains of severe pain. So this is a common scenario that most of you will come across during your surgical appointment. So how would you manage his pain? So you can make use of the right approach. So recognize pain and assessment of pain. How? Use a pain tool, either verbal rating or numerical rating scale. Quantify the pain, rate the pain scores, and then both at rest and on movement. And record them, and also important for you to assess how the pain has affected them physically, where the mobilization, coughing, deep breathing is affected, psychologically, whether they had a good sleep or whether they are anxious and depressed, and also social impact, again, very important, especially those who are coming following major injuries. So you need to talk to the patient's family to find out to get rid of their fears. And coming on to treatment, don't forget the drugs and the non-drugs. So you can use, depending on the severity of pain, you can use different types of drugs. And also don't forget the non-drug methods where the reassurance can play a very important role. And also, if they have any nausea, vomiting, so please please use those use the antiemetics to treat those conditions. And also, if they're really very, very anxious and reassurance is not going to help them, you might use a anxiolytic in conditions in patients where it's really needed. So likewise, depending on the findings during your assessment, you can decide the kind of treatment, both drugs and non-drug interventions. So that summarizes what I've done so far in managing patients with coming with acute pain. So in summary, I remember the RAT approach, where regular assessment of pain is very, very important, preferably before and after the analgesics, and use a pain tool and maintain pain charts to record the scores that you have noted, and use multimodal therapy with adequate doses, frequency, and precise timing, along with the non-drug interventions, and always look for the need for multidisciplinary inputs where it is needed. So that way we can improve the pain services. That's all. Thank you. Any questions?
Right. Thank you very much, Madam, for the detailed lecture on pain management. I hope everyone was listening now. Right. Thank you once again, Madam, taking your time.
I'll share the presentation with you, then you can share.
Yes, Madam. We will, we will share them at the end of the sessions.
Okay.
Right. Thank you, Madam, once again, taking your time from UK, delivering the lecture. Right. So tomorrow, please join by the same 8:45. We'll start by 9. I think most probably ministry officials, including the Director General, will address the session. So also I want to remind you is if you all have any questions, please type on the chat box. It's time to answer the madams or sirs, any questions you are having. They are free to answer your questions. So make use of the sessions, right? Thank you once again, madam. Thank you.
Thank you very much, Roshan. Thank you.
Thank you. The registration link will be active for 5 minutes. Those who are here can submit their participation. Right. Thank you.